probably the economic argument also in terms of having to stent. But the proximal one, to my mind, didn't look that significant or didn't look that severe. Could have been well left alone for another time.
Mohammed, would you put the direct stenting from the beginning, or you do like what Ahmed did, aspiration first, from the first shot?
No, I would aspirate. I mean, I still use a lot of aspiration, probably about 70% of my cases. The ones that are blocked, I'll always aspirate. I know the data says no aspiration, but the two studies that approve that are flawed, and you could pick lots of argument about this. When you're comparing something with nothing, you're always going to have a positive outcome. So for me in here, yes, just a direct stent. And I do about 100, 110 primary a year. Probably 99% of the time it's direct stent. Because the less you do in acute MI, the better. You need to manipulate the artery, the least amount of manipulation. Sometimes, of course, you're trying to deliver the stent. It's not deliverable because of you need to predilate, fair enough. And this is also where you use a smallish balloon at a low pressure, because the higher the pressure, the bigger the balloon, the more showering downstream and the more chances of no flow. So a direct stent is very helpful. So I'm looking at here, and yes, that distal lesion could have been treated and left everything alone.
What is your proposed length for the stent if you can stent lesion like this?
Blade. Do you have another view, like maybe an LAO or LA caudal? Because this is like an 18 millimeter stent would have been more than enough. I mean, we need to see it. This is RAO caudal, so it's foreshortened. I just need to see another view, and that tells you what you could do. Here you go.
You can see here there is ulcerative plaque in the proximal in the mid circumflex. So you have to stand from there.
Again, you don't see it very well. Fair enough. I mean, the thing is also sizing properly is your main thing in primary. This is why you go for direct stenting, so you don't have to post dilate. And the trick to reduce your no flow is just to deploy the stent and go with the pressure very slow. You go to 8 atmosphere and very, very slowly start going up to whatever you want. If the majority of us put the stent and want the pressure up, and that's showers everything down. So just slowly and go up. You could go to 16 atmosphere as long as you're going up slow, and that reduces the chance of no flow.
احمد، عبال ما السلايد يرجع تاني، انا بس انتوا من المدرسه اللي كان عاملين استادي مع خالد شكري عن
deferred.
انا مستغرب يعني ان هو دي اول حاجه. تاني حاجه، انت كويس طبعا ابتديت بالسيركمفلكس، ده كويس. ثالث حاجه، هل ممكن كنت تعمل يعني run of
more thrombus aspiration؟
ايوه هل ده كان available؟
انا هوري حضرتك الصوره. يعني انا يعني ما لقينا الاثنين obtuse marginals.
The yield of repeated aspiration is probably not that good. I mean, the minute you do it a couple of times, especially with these small aspiration, if you have a large thrombus burden, what you could do is take the heart rail. I don't know if it's available. This used to be the first mother and a child extension. So remember the wire 5 French, the same as guideline, but it's over the wire. Or use the same one, but 60 millimeter syringe, really high negative pressure to be able to suction. But the yield after a couple runs is very little.
And what about if you have no reflow like that? What are the armamentarium you can do better for that?
انا هوري دكتور احمد بس يعني هنا دكتور احمد الصوره اعتقد ان هي خلاص احنا قلت البيت احسن كتير من الاول، والثرومبس بيردن قل، والاوبتيوز مارجن الثاني ظهر. ف يمكن كان القرار ساعتها، ما هو السؤال انا جايب المحاضره عشان كده، هل السؤال ان احنا كان الاحسن في المحاضره في الحاله دي الديفيرد ستانتنج ولا الدايركت ستانتنج؟
The flow, you get a good flow.
Yes.
Maybe a thrombi, but not occluding the flow. So maybe deferred stenting here is better. It's not in every case, not a routine deferred stenting, but in this case, I think the routine, the deferred stenting would be better.
Ahmed, to be clear, I vote for stenting.
You vote for stenting?
Yes. Here. Yes, allow me to differ with you. Yes. Because
okay.
As I said, my motto for my trainees all the time, there's always tomorrow. Once you do something or put the stent and you can't take it out. You could always come back and put another one, put a new one. When we know from primaries, this is the recipe for no flow. It's about 7 to 8% of these cases will end up with no flow. Now you asked about how you treat them. You've got the aspiration catheter. Often people, when you have no flow, start giving nitrate through the guide catheter. It doesn't reach the distal bed. So what I usually do, the best thing to do is to take the aspiration catheter on top of your wire, very distal, and then you inject the nitrate or adenosine through it. And then also you could take a picture, because if it's not clear and you don't see, you could inject some dye through it and you'll see the whole distal bed. But giving it through the guide catheter doesn't give you anything, particularly adenosine, because as you know, the half-life is very short. But if you take the micro catheter or the aspiration catheter down, you deliver to the distal bed and you get all your the outcome you want. Of course, now adrenaline is being used. Nitrobroside, people talk about it. I don't use it. It's expensive. It causes a lot of hypotension, and yeah, we don't use it.
So
adenosine, yes.
Okay, we choose to stent. We put the stent. It's complicated by NoriFlow.
Actually, we differ sometimes, but with late presentations and with more heavy thrombi, not like this, because deferral is a good policy, but still your patient maybe in the evening or in the night develops an acute occlusion, re-occlusion. So it's a risky procedure anyway, but we do defer, but not this case. This is what I mean.
One more point, if I have a fear to lose one of these branches, so I would protect them with wire.
With a wire.
Yes.
Okay.
This is an argument. How does the wire protect them?
So now let's say for the second diagonal branch, he doesn't know the site of with اهلا وسهلا دكتور محمد شرفتنا. He doesn't know the site of the branch, and he will spend more time to searching for this the second.
Believe me, it's a myth. Makes the operator feels better. The argument always about you know where the diagonal is. You've got the angiogram, and you could, you know.
اوكي.
هو كان ليت قد ايه يا احمد؟
مش ليت، هو العيان جاب تشيست بين بقاله ساعتين.
طيب خلاص اوكي.
It was very early. طيب احنا بعد ما عملنا بالونينج للاوبتيوز مارجن الاولاني خلاص خدنا بقينا تيمي 1 تقريبا، واحنا اوريدي اخترنا ان احنا نقف at that stage to put the patient on 2B3A inhibitors, anticoagulation, and then 4 days later we can re-angio them. This is angio 4 days later. The two OMs are TIMI3 flu. Maybe some pinching in the ostium of the OM2, but still TIMI3. The stent is patent, and the artery has TIMI3 flu, different projections.
So just go back one. Just go back.
Back?
Yeah, back one. I mean, is that a little perforation, or is that just
perforation
on top of that second OM, or is that a branch?
No, it's a branch.
It's a branch.
I can't see. No, branch, right? Okay.
Okay. The patient goes hemodynamically stable, chest pain off.
No, you could have a little small perforation, wire perforation like this into the cavity, and it doesn't do anything.
We did not wire the OM2 at all. Then we go to the RCA. There is a tight lesion in the proximal RCA, which is ectatic. We put a stent. Pull the stent, dislodge it from the lesion.
What is the size of the stent?
5 by 15.
And it is a direct stenting.
Yes.
Okay.
So it's dislodged. So we put another one. This is the final result. We did not go to the ostium. So what do the guidelines say? 2021 guidelines of the American College of Cardiology, it put in patients with a STEMI, routine thrombus aspiration before primary PCI is not useful. But in some cases, we are in need for thrombus aspiration. For the deferred stenting, we have advantages. We have disadvantages as we discussed. For the sake of time, my take-home message, thrombus-containing lesions are very challenging issues in intervention. Routine aspiration is not recommended. The decision of direct stenting versus deferred stenting should be individualized. Thank you.
Thank you, Ahmed. I think the main message here, there is no size fits all. Here, there may be the deferred stenting. Dr. Muhammad طبعا معترض على كده. Deferred stenting may be an option. However, the routine deferred stenting should not be the rule. Yes. في العيانين دول اللي هم عندهم marked coronary ectasia, maybe the use of intracoronary glycoprotein 2b3 inhibitor and aspiration catheter is the best option for restoring the flow in the acute situation, and then to do another PCI later on after anticoagulating the patient. So
عايز اوجه سؤال للدكتور محمد صبحي. How to prevent no reflow, tips and tricks in acute coronary syndrome or in the setting of primary PCI?
Yes, it's a very good question. I'm sorry I didn't see the case from the beginning, but I'm very asked. I'm going to answer this one because yes, if there's ectasia, it's advisable not to stent. If you're in ectasia, you should prepare everything, aspirate, and then do glycoprotein 2b3 with heparin or enoxaparin for 3 days, maximum 2b3 3 days, and then angiogram. Sometimes we don't stent 3 days. We leave the patient for 2 to 3 weeks and then re-angiogram this patient. This is for ectasia. Regarding the angiogram, this pharmacological part, patient usually diabetics, you should give the patient, if the diabetes, insulin is important. Number 2, hyperuricemia is claimed to give these drugs. Statins, high dose of statins is important. This is pharmacological. Regarding the technique itself, I'm fascinating with aspiration since the guidelines stop this. But if you have a big thrombus, you should aspirate. Don't go to the guidelines because it is exception to if there is still a big thrombus, or there is a thrombus following stenting. So to prevent this. Number 2, I prepare the lesion. I'm not advising not to prepare, but usually I don't post-dilate the patient. Post-dilate the stent. Usually if there's a thrombi, I don't post it because we have already a study in Alexandria regarding this post-dilatation, post-dilatation. We found that the instance of no reflow is more, or stroke flow is more in this patient. This I think is the most. I usually pre-dilate. I don't put a stent without pre-dilatation. I don't put a stent, and I wire pre-dilate even by small balloon just to open to see the length, and then you put a stent equal to 1:1, and don't advise if there's still there is a small thrombus, don't push direct. No direct stent. If the big thrombus, I don't like this one. If you are afraid of direct stenting, you should aspirate.
Yes, I mean, I did mention it before. Aspiration, if there's a thrombus burden. Direct stent for me in primary, I mean, it's about 98% of my cases are direct stent. The important thing is to size correctly, because you're absolutely correct. Once you put the stent and you post-dilate, this is where you get the no flow. And when I'm deploying my stent, of course, if the stent doesn't go, then I will pre-dilate because that tells you there's. And of course, sometimes if an 80 years old, they could see calcium, you could see problem, I will pre-dilate to make sure that I'm not gonna have an under-deployed stent. When I'm deploying the stent, the most crucial thing for me, and this is what we've seen in the practice many years, is just to go up slow. Once you inflate it slow and keep up, you could go up to higher pressure if you want, but as long as you're going slow, you don't cause as much no flow. And yeah, avoid post-dilatation, because if you size correctly, you probably do not need to post-dilate.
Thank you, Ahmed, again for this.
One more point. If you think you want to post-dilate and the stent is still not very good, on occasion, we've left it on the day, and you could always come back a day or two later. But of course, this is an implication for beds occupancy, and but we've done it before.
Thank you, Ahmed. I'd like to introduce Dr. Ahmed Saeed, consultant cardiologist, with another nice case of unraveled stent.
Thank you so much. أشكر أساتذتي الأفاضل في القصر العيني وأهنيكم على المؤتمر الناجح وأشكركم على دعوتي للحضور. My case today is the unraveled stent. That was a 76-year-old man. He is diabetic, hypertensive, presented with anterior STEMI. He was shifted to cath lab for primary PCI. It was done in an outside hospital. That was the coronary angio. Is it working? هنا مش شغال. ده كان الكوروناري انجيو. طبعا عندنا الهيفي كالسيفايد فيسلز. There is haziness in the LED. Also there is some moderate lesion in the OM and the CTO in the RCA with retrograde filling. The LED flow is TIMI2 flow. And that was the RCA. Actually, the decision was made by the operator to go for direct stenting at that time to the LED, noticing the heavy calcification. Multiple trials to deliver the stent was not successful. That was the second video after that. Here we notice at just outside the guiding, the stent slipped from the balloon inside the left main. Here is the stent, and also there is some part of the proximal stent inside the guiding still. Multiple trials to insert a smaller balloon inside the stent, but unfortunately the system was disengaged and he lost the position. Another operator of the same team tried to I don't know what he was exactly doing. He was trying to retrieve the stent or to crush it. But here we notice that some part of the stent is outside the left main, inside the aorta. Here there is, at that time, there was no snare at that hospital at that time. Yes, that was the next step. So our team at that time was called for help. We notice that the proximal part of the stent is inside the aorta. The distal part is
one slide back.
The distal part is trapped inside the calcification of the LED, and the portion between the two stent is structured and unwrapped. So we had to plan for retrieving the stent and fixing the vessel. Any injury to that left main, we can lose the patient. So we gained a contralateral axis, femoral axis with a 7 French, and then we secured the left main LAD and the left circumflex with 2 wires. Then to snare that stent, and in case of emergency, we are ready to deal with the vessel in case of any emergency. So that was the snare that we did, handmade Sumitsuji snare. It was invented by Satoru. Here, the guiding catheter containing a balloon and a wire, the monorail balloon and the wire over the inside the balloon as usual, and then to deflect the coiled segment of the wire to be deflected again inside the guiding and trapped with the balloon to inflate the balloon and trap the wire. So we have a free edge of the wire that can be pulled back, so we can make that snare with the full length, because already tried to make to deflect the wire and then have the 2 edges of the 300 millimeter wire. It didn't get to that aorta. The man was tall. That was the initial trial. We went with another guiding catheter. We secured both vessels with the wire, and then captured the proximal edge of the stent inside the aortic sinus. Then trying to pull unfortunately, it didn't retrieve the stent. I think at that time, because I didn't disengage the guiding from the left main. So it was preventing the other stent from coming back. So the second trial, I got the stent from the proximal part from the middle, and then I disengaged the guiding catheter outside the left main so I can pull the stent back. Now I could retrieve the stent. Notice the calcification is very heavy, but the stent is out now. Here, after capturing the stent with the wire, I have to make a constant pressure on the wire so I can get the stent. We can do a locking technique by the torquer itself. So I insert the torquer and make it as much as possible to the Y connector, and then lock the torquer over the wire so I can pull the balloon out with the guiding catheter without losing the pressure over the stent, the snared stent. And then we got the stent down till the iliac. And now at the sheath. Unfortunately, we could take the stent out through the 7 French sheath. This is the third time I do this snare. No, the first time I have seen this technique by it was introduced by Emmanuel Perlex in his channel in the YouTube, and he didn't mention even it was Satoru. I didn't know that Satoru invented that technique, but Satoru did. After searching for that technique, I found that Satoru was the first one. Later on, Satoru improved the technique, and he did it over a guide liner, not only a guiding catheter. So he can snare from inside the coronaries. But this case, it was outside.
Yeah, that's what I was going to say. You could do it with a guide liner, so you do it outside the body. You know how, because getting the wire to come back into the guide catheter could be a nightmare on the inside. So you do all the contraption outside the body, and just you introduce the guide liner into the guide, and then you go. Then you advance but of course, that sometimes, this is why you have to choose your wire rightly. You don't use a hydrophilic wire. You don't use the ribbon wire, because you could shape it and becomes really sharp. So you need one of them what's it called?
Yes, when I used this over a guiding catheter, it was very difficult to introduce the guiding catheter throughout the aorta till the aortic sinus.
No, you put it inside the guide liner, right next to the wire. So
there was no guide liner at that stage. Yeah. And that was the stent after coming out. And then after that, we completed the procedure, proper preparation of the lesion with one-to-one sizing balloon. We have chosen to stent with 3 short overlapping stents, because already we know if we use the long stent, it will not go
direct برضو direct stenting.
No, we did prepare the lesion. Prepare with the balloon 1-to-1 size. Severely calcified. Rotablator in the setting of acute MI and very long time. That's what they told me at the. Yes. But it was STEMI 2 at the beginning, actually.
Yeah, but after you dilated with the balloon, it's STEMI 3, and I totally agree, because even now, one of the pictures you showed, the stent is still really under deployed.
Yes.
And
we brought the patient
heavy
later
calcium,
on. And,
heavy calcium.
Yeah.
Yes, the middle one. Thank you.
Thank you, Ahmed. It's a nice save for this silly complication. And the first lesson, we should prevent this complication as we see this calcified artery with good preparation. As Professor Mohammed Sobhi said, that these cases needs advanced modalities such as cutting balloon, scoring balloon, and rotablation may be needed in these cases. However, I think we learned from you how to use a homemade snare that we can use it someday. So thank you, Ahmed. Thank you so much. So moving to Professor Dr. Haitham Sulaiman with the third case of stuck by the rules.
الرسالة الواضحة كمان اللي احنا اتعلمناها ان احنا مريض لازم نبص للسن. The age is 72. حتى لو انا مش شايف كالسيوم الحقيقه I don't go for direct stenting in such an age.
Sorry, just to say,
may I have the slides, please?
Just 1 second. I think it's a comment, just fantastically well done to have the improvisation to take the stent out and to do this. But there's that saying that always says, you really have to use the superior judgment so you don't have to use your superior skills. In the way that if you look at this and you see it, okay, it's the balance of probability. That artery, under no circumstances, that was going to be direct stent. But of course, always back seat driving or hind signs are very easy. But you look at the angiogram, you could expect what's going to happen from the start. So really preparing the lesion and making sure that you've prepared the lesion well for the stent deployment is very important.
Thank you so much for inviting me, and I'm congratulating all the members of the Elegant Cardio University department for this elegant meeting. So this was a 47-year-old male smoker, stable angina for 1 year. Then he became unstable. His treating physician decided to do him a coronary angiography. He chose to do the coronary angiography via the radial approach. We see that there is plenty of ectasia in the vessels. There is no significant lesion in the circumflex or the left main, but we have a subtotal occlusion at the proximal LAD before a huge diagonal branch. The right coronary also has multiple ectasia, but without any significant lesion. So the operator decided to wire the LAD and the diagonal branch, do predilation, and then do a provisional stenting to the proximal LAD. So he did that. This is the predilation balloon. And this is the inflation. He inflated this lesion twice. And this is the angiogram after the predilation. And if we notice carefully that the ostium of the diagonal has a hazy lesion, it began to appear. But unfortunately, the first operator did not notice this change at the ostium of the diagonal. Then he placed the stent. The patient began to have some chest pain and deployed the stent. He began to have a slow flow, and the patient is in ongoing pain. So he deployed the stent. And after deploying the stent, we can notice that the haziness at the ostium of the diagonal is increasing, and there is ongoing chest pain. I don't know why he pulled out the wire from the diagonal branch and decided to do pot to the proximal part of the stent. At that time, the patient is having severe chest pain. The diagonal is getting worse. And then the patient arrested in VF. This is my speculation, because in the absence of IVUS or OCT, we can all speculate what went wrong. But if you notice the edge of the balloon, this edge of the balloon prolapsed inside the ostium of the diagonal branch, crushing the wire of the diagonal against the intima. And I can speculate that this was a mechanism like the cutting balloon. It crushed the wire inside the diagonal against the wall, creating a dissection at the ostium of the diagonal branch. And this dissection was a nidus for thrombi, and the mechanism get worse after deploying the stent and doing a pot. This is my speculation.
Are you saying it's the pre-dilatation balloon or the stent?
The pre-dilatation balloon.
Because the pre-dilatation balloon is like about 2 or 2.5 and probably has not touched it.
No.
So that's a 4.0 stent, a 4.0 vessel, and the pre-dilatation balloon looks quite small.
Yeah, it was small.
So it wouldn't have touched the sides.
The problem is this pre-dilation balloon was so small and the diagonal was huge, and it was opposite the ostium of the diagonal. It was sucked inside the diagonal. This is my speculation. We cannot make sure 100% at the absence of IVUS or OCT. ما هو احنا هنشوف دلوقتي ليه حصل VF، لأن this was a nidus for thrombi that occluded both the LAD and the diagonal branch. This thrombi at the diagonal occluded both the diagonal and the LAD.
What we don't see, sorry, I know we need to finish this case, but the distal LAD had a little bit of aneurysmal area, with, and we don't see the distal LAD at this time because you might have dislodged the stent distally.
The stent?
Yeah,
no, the stent.
That's I mean, the thrombus, not the stent.
Yeah. I was called for help, and this was the picture. The LAD was totally occluded along with the diagonal. So I advised them to continue CPR, and I pushed the balloon inside the LAD, trying to dislodge the thrombus as distal as I can. And then I tried to wire the diagonal branch, and I've succeeded to wire the diagonal branch while doing the CPR, inflating a balloon inside the diagonal. The patients still have refractory VF, and we are on CPR, so I tried to stent the diagonal branch, keeping the edge of the stent as much as I can at the ostium of the diagonal branch. And then the patient began to regain his own rhythm and built some pressure. Now the patient is more or less hemodynamically stable, but I pushed a balloon inside the LAD. I've tried to reintroduce two balloons in order to do a kissing, but any attempt make the patient worse. So I've decided to stop at that time. And this is the final flow to the LAD and the diagonal. Patient now is heavily sedated, intubated, but he's hemodynamically stable. So 2 hours later, the patient was extubated, stable, discharged 24 hours later, and I advised his physician to perform another angiogram and do a kissing balloon in order to keep the long-term outcome of this bifurcation. So my take-home message or short notes that to take care of the relation of your balloon to the side branch wire, as I'm speculating, when patient starts to complain, spend some time to figure out what is the cause of chest pain. Don't withdraw the side wire branch unless you are sure it's okay and there is no complication, and don't underestimate the effect of side branch occlusion. And thank you so much.
Thank you, Aysam. Very nice case. Can we get back to the image with the index event with that started all of that? And I'd like to ask our dear professor, what is the speculation for this complication?
Yes.
Yeah, I don't think it's the diagonal. I think it's the whole milieu of the acute presentation and the full thrombus in there. This is a large LAD, and distally it has a small aneurysm and severe stenosis before the aneurysm, so it could easily have been stopped. You look at this, and these are the cases that you could make them as complex as you want or as simple as you want. The first I saw this, I thought I put a short stent stopping before the diagonal. And look at that. You could have dropped the stent just before the diagonal and the bifurcation, 408, and you would have been out without much problem. Of course, it's easy to say it right now. The operator must have seen something different at the time. If you look at this, this is a short stent, single stent before the bifurcation, and make it simple and get out.
Yeah, but what about the changes that happened inside the ostium of the diagonal after the predilation and continued?
Sure. I mean, once you've committed yourself, you're doing a bifurcation, then you'll have to deal with the bifurcation. And there was a thrombus, even now you could see it, the filling defect. And then it was dislodged to the diagonal, and then the whole spiral of thrombosis and complication becomes. And I'm assuming you've checked an ACT and everything was okay. You've given to type 2B3 inhibitor to make sure this is the least effect. But you know, once you've committed yourself to a bifurcation, and that's why I said you could make it as complex or as simple. Yeah, you have to deal with the complication when they happen.
Haitham, to me, there is no lesion in the ostial diagonal.
Yeah.
It's just the branch and a hazy maybe thrombus.
The problem is that
there is no dissection. I don't think so.
I will let myself to go forward after the post dilation and the stenting.
Thrombus.
Yes, this is the thrombus. But can we look to the ostium of the diagonal? After this is only thrombi.
The thrombus being squeezed into the, because you've put the stent and you squeezed it into the diagonal.
So why is this thrombus was getting back to the LAD?
Sorry?
Why this thrombus gets back to the LAD?
This is acute presentation, isn't it?
No.
You said she was stable for a year and then one unstable.
Yeah, this is an unstable angina. This
exactly.
Is
so unstable angina by definition is thrombotic milieu. If you IVUS these or OCT them, you'll always find a thrombus. Okay. But also you dissected with the balloon and whatever you've done, it is an area to form a thrombus, and you see it there in the one of the images after the balloon. So the thrombus is sitting there. You put the stent in the LAD and you squeeze it, and it just migrated to the diagonal. I don't think there's a dissection.
Okay.
So I think the post dilatation with both balloon in the event that started all of these. So maybe the post dilatation make the diagonal branch get bigger and occluding all the vessels in the diagonal branch.
Actually, even before it, with the pre-dilation, we saw now retrogradely a thrombus inside the diagonal branch. I think this might change the strategy of the first operator, but unfortunately, he did not change his strategy. And that was the triggering event.
Excellent case. Saving a patient like that is very good. Because of the live.
I know.
Thank you very, very much. Sorry يا محمد تفضل.
احنا عندنا بس شوية delay في اللايف. We are going to proceed to the coming session, state of art lectures. It's an honor to call for the chairpersons, Professor Dr. أيمن أبو المجد, حسن خالد, يا درديري, سامح بخوم.
هيثم الحضر جه عندنا.
Is it the proper time to stop?
يسعدنا طبعا وجود الاستاذ دكتور محمد صبحي جاي مخصوص من اسكندريه، ودايما يعني بيسعدنا وجوده وطموحه وانجازاته العلميه والجمعيات اللي بيعملها. الحقيقه نشاط يحمد عليه وربنا يكرمه دايما ويحافظ عليه. الموضوع اللي هيكلم عليه الدكتور محمد صبحي algorithmic approach to balloon and crossable lesion.
وانا طبعا بشكر كل الطب القصر عيني قسم القلب على راسهم طبعا استاذ الدكتور جلال السعيد الدكتور جلال السعيد هو اللي امتحني في الدكتوراه ونجحني من اول مره. ومثلي الاعلى نجحني من اول مره. تصور اللجنه كانت فيها مين؟ دكتور جلال السعيد، دكتور علي رمزي، دكتور خيري عبد الدايم، بس عشان تبقى فاهم الموضوع يعني، مش تبقى فاهمين يعني القصه كانت ازاي زمان. غير الخمسه بتوعنا كمان. دكتور جلال السعيد ده رمز لنا كلنا، وانا طبعا بحييه وبحيي الاساتذه، الاستاذ دكتور عبد الغني، دكتور حسام، والدكتور هشام صلاح، كل المجموعه والشباب الجميل الموجود هناك. هو الحقيقه ما قالوا لي انا طبعا مسافر الاقصر النهارده بالليل، او شفتت بقى قصه فغيرت قصه عشان خاطر عينين القصر العيني. هو قال لي هشام تقول ايه؟ فانا في توك كنت شفته يعني وضبطه، كنت هقوله في حته انترناشونال، وبعدين قلت له هقول اول مره يعني. انا لقيت مهند كاتب حاجه كده عن كروسبل، قلتها امبارح، انت مش كده؟ ما اعرفش هو زي ده، انا ما كنتش موجود امبارح. هو الجوريزم ابروتش تو بالون انكروسبل ليشن. الحقيقه ده ستيت اوف ذا ارت موجود في الجاك، عشان ما اعرفش حد قراها قبل كده ولا ما قراهوش. القصه كلها ان انت عندك كلمه جديده رجعت اسمها uncrossable lesion. In 6 to 9% of the CTOs non-occlusive lesions. The cause of failures in it to pass the balloon, severe calcification, tortuosity proximal or at the site of the lesion. Both. First, أول حاجة lesson they have to confirm in the guide wire in the true lumen. عشان تقول uncrossable لازم شو دي أهم lesson أول. Occasion resistant to crossing نتيجة perforation caused by guide wire. فده حاجة تانية lesson number 2. إيه التكنيكس أو الأبروتش؟ في كذا حاجة. في 5 لاينز. اول لاين حاجه اسمها سمول بالون او بالون ويدج تكنيك، هنشرحهم كل واحده واحده. رابشر بالون انفيسل اسمها جراندوبلاستي. وبعدين انكريس سبورت سواء بالجايد كاسترز او واير. نمبر 3 المايكرو كاسترز تكنيك او واير كاتنج بانكشرز. وبعدين ليزر اثريكتومي. فاينلي سب انتيمال اكسترنال وديستال انكل. اول واحده اللي هي سمول بالون. اول حاجه انت ممكن تعمل ايه؟ الواير خلاص مش عارف موجود، تاخد سمول بالون ماركر، يعني سنجل ماركر وكومبلاينت مش سيمي كومبلاينت ولو كروسنج بروفايل، تاخد 1.5 ولونج لينث. بعدها او رابيد اكسشينج بالونز، بتعمل البالونه بتنفخها وبتزقها. هو بيقول لك بتنفخها وتزقها، دي اسمها BYT او بالون ويدج تكنيك. حاجه سمبل، حاجه فيري سمبل. الواير موجود، انت مش عارف تعدي حاجه، مش عارف تعدي البالونه، تاخد بالونه صغيره قوي وتزقها، وتكون صغيره وطولها 20 30، وانت بتنفخها تزقها، وانت بتنفخها بتزقها كانك بتكسر في الحاجه دي. اول حاجه دي. تاني حاجه لو البالونه فيلد مش عارف تعدي، يا اما تجيب بالونه صغيره يعني نيو سمول بالون، او انك تجيب بالون من شركه تانية، لان خلي بالك لازم تعرف ان في ديفرنت بالونز مش كلهم كروسابيلتي زي بعض. او انك وده ما يكون متعود على حاجه، انت ايدك متعوده على بالونات معينه. او كروس وذ لارجر بقى بالون بدل diameter ورابيد اكسشينج، او ان انت انفليشن وذ لارج diameter بالون جاست بروكسيمال تو ذا ليشن. دي 4 اوبشنز لو البالونه الصغيره دي ما عدتش. الحاجه الثانيه اللي هي اسمها جراندوبلاستي، دي برضو سهله، فيري سمبل وسيف وافكتيف، ان انت تاخد سمول بالونه 1 ل1.5 وادفانس البالونه دي از بوسيبل للليجن نفسه، وانفليشن على هاي بريشر لغايه ما البالونه تفرقع. لما البالونه تفرقع تعمل سكشن ايميديتلي، ففي كونتراست جيت دي تعمل موديفيكيشن البلاك وتعمل كروسنج زي كده. ادي انت مع واير وتاخد بالونه صغيره تنفخها صبغه، تنفخها تفرقع خلاص. لما بتفرقع ما هي مش كومبلاينت، تفرقع زي فكره الاي في ال، انك بتفرقع، انت عايز تعمل حاجه تعمل بامبنج وحاجه سهله وصبغه وتسحب على طول. اسمها جراندوبلاستي تكنيك، يبقى BYT تكنيك وفي جراندوبلاستي تكنيك. الحاجه الثانيه كي سبورت. لما تكون انت مش عارف تعدي لازم تدي لنفسك سبورت اكتر، يعني الجايدنج بدل 6 فرنش خليها 7 أو 8. في ديفرنت تكنيكس في المايك في السبورت. حاجه اسمها سايد برانش انكور، ديستال انكور، كواكزيال انكور، او ديستال انكرنج اللي هي 2 وايرز وبالون. ايه هم دول؟ ده السايد برانش انكرنج، يعني انت الوايرز في وايرز هنا بتدخله السايد برانش انكور زي بتاع السي تي او، مش عارف ساعات سي تي او، سايد برانش انكور بالون، والواير موجوده وادي البالونه تعدي عشان تدي نفسك سبورت بالجايدنج كاثرز معاك. او تستخدم جايد لاينر. لازم الموضوع لسه كان مهند بيتكلم على جايد لاينر، لازم كلنا نتعود على وجود المايكرو كاثرز والجايد لاينرز. للاسف احنا نقول لا غاليه، لا مش غاليه. الغاليه اللي انت عملته ده اللي بوظته، لكن الغالي ثمنه فيه. في جايد لاينر موجود، ايه المشكله؟ ما انت مش عارف تعدي في بتاع رفيعه كده بتخش، ما اعرفش مين الصغيرين استخدموه، شوك اسمها جايد لاينر او جايد زيلا او تلسكوب حسب النوع حسب الشركه، وبتعمل تكنيك اسمه انش وورمنج تكنيك. ايه ده بقى؟ بتطلع بالونه بره وجوه، يعني بره الجايد لاينر نصها جوه نصها بره، بتنفليت وديفليت بالسمول بالون دي في الجايد واير اكستنشن نفسها، وانت بتنفخ يعني تعمل انفليشن ديفليشن بتزق معاك الجايد لاينر، لان الجايد لاينر ما هتيجي على نفس المكان مش هتعدي. طب اعمل ايه؟ بالونه صغيره نص جوه ونص بره وزق الجايد لاينر، انفخ وافتح انفخ وزقها لغايه ما تعدي. فدي سهله قوي. عندك بالونه وجايد لاينر، يبقى البالونه نص البالونه في الجايد لاينر والنص الثاني بره، وتنفليت ديفليت. الفكره ان انت بتنفخ وتزق تنفخ وتزق لغايه ما اسمها انش وورمنج تكنيك. النوع الثاني فيه قصه اسمها كو اكزيال انكورنج. يعني ايه؟ يعني انت تعمل تو جايدنج كاسترز، واحده بتعدي فيها بتعمل بالونه تنفخ فيها بالونه على الواير، والثانيه الجايد اكستنشن. خلاص؟ وانت في الجايد اكستنشن بتدي قوه للجايدنج كاستر. الاثنين مع بعض، الاثنين مع بعض بيخلوا زقه الواير سهله او اسهل. فاهمين ازاي؟ يعني واحده جايدنج فوق، واحده جايدنج ثانيه، واحده بتعدي فيها الجايد اكستنشن والثانيه بتنفخ فيها بالونه، اسمها كو اكزيال انكورنج. النوع الرابع اسمها بادي واير ستنت انكور، يعني برضه بس جايدنج لوحدها، وتقوم نافخ ستنت فوق بروكسيمال ستنت وتجيل الواير، فبتعمل برضه سبورت اجينست سبورت. هي الفكره كلها انا عايز سبورت سواء بالجايدنج او سواء بالسبورت بالانكور بالون او سبورت بالانكورنج تكنيك اللي هي كواكسيال او البادي واير ستنس. في الناس بتشتغل ريتروجريدز في حاجه اسمها ديب واير كروسنج تكنيكس، دي الثانيه بتخش بيها برضه الريتروجريد والديب واير كروسنجز. المايكرو كاسترز بقى او الواير كاتنجز دي انترستنج جدا. المايكرو كاسترز في ده لنوعين معينين، اسم التورنس حاجه في تورنس وتيرن بايك. التورنس ده المايكرو كاستر اللي بيشتغل في المايكرو كاسترز عارفهم، كالسيفايد وديفيكلت تو بنتريت ليجنز، وبتعمل كاونتر كلوك وايز. انت بتعمل كاونتر كلوك وايز وانت بتزقها، يعني بتزقها وبتسحبها بكلوك وايز. تاني المايكرو كاستر اللي بتشتغل بيها التورنس عكس التيرن بايك. انت بتزق في الكالسيفايد ليجن بتزقها وبعدين بتعمل كاونتر كلوك وايز وتزق وانت طالع بيها تعمل كلوك تاني كاونتر كلوك وايز وكلوك وايز. ده التورنس مايكرو كاستر. الجايدنج كاستر الثانيه او مايكرو كاستر الثانيه اللي هي تيرن بايك سكرو موديفاي برضه كلوك وايز وذروينج باي تيرن كلوك وايز. يبقى هي الفكره بتاعت المايكرو كاسترز ان انت يعني الجايدنج اكستنشنز لها تكنيكس والمايكرو كاسترز انذر تكنيكس. المايكرو كاسترز بتعتمد على كلوك وانتي كلوك، والثانيه بتعتمد على زقتك بالهاف واي ان اند اوت. في حاجه انترستنج وسهله جدا اسمها الواير كاتنج تكنيكس. انت حاطط واير، جيب واير تاني سكند واير وبعدين تحط بالونه وريموف السكند واير وديفليشن نيو بالون. جيبها لكم اكزامبل. ادي تو وايرز، والواير ده اولاني حطيت انت البالونه خلاص، وبعدين ديفليشن طلع وهكذا، دخل وطلع، حط البالونه تاني على السكند واير. يعني انت بتحط واير تاني وتحط عليه بالونه وبعدين بتشيل الواير وبعدين ديفليشن وتحط نيو بالون. كل مره بتقطع في المكان اللي انت داخل فيه. في تكنيك تاني اسمه سيسو واير كاتنج تكنيكس. ازاي؟ يعني 2 وايرز عليهم 2 بالونه ديستري انفليتنج وبريسنج وبعدين ديفليت، وبعدين تاخد الواير تحط عليه سكند ديستري انفليتد وديفليت كذا مره. ده الاكزامبل بتاعها. يعني ادي 2 وايرز حط 2 بالونه، انفخ بالونه فيها ديفليشن، وبعدين الواير بالونه الثانيه تنفخ وديفليشن. الفكره بتاعت الاثنين دول هم زي ايه؟ زي بيقطعوا الحتت اللي انت هتخش فيها، بيقطعوها بس انت استخدمت حاجه سهله، 2 وايرز و2 بالونه اللي هي سي سو واير كات. لها اسم يا جماعه، سي سو واير كاتنج. دي احنا ما كناش نعرفهم قوي، يعني احنا يعني ما حدش كان، دي تجميعه. طيب ادي الواير كاتنج تكنيك تاني، ادي الواير اهو والبالونه اكزامبل، ادي البالونه بتنفخها والواير التاني تحتيها. شايفين البالونه ديفليتد فوق، وبعدين الخضراء بتنفخها والحمراء بتفليت وهكذا، اسمها الواير كاتنج تكنيك. في حاجه سهله تانية، يعني انت عندك واير مش خلاص حطيته، حط 2 وايرز تانيين، واحده اوفر اديشنال واير وحط عليه بالونه وشيل الوايرز، كانك بتقطع في الاثنين. يعني انت حاطط 3 حاجات حديد، والحديد دول حاطط واحده فيهم بالونه ورحت ساحب الاثنين التانيين. وانت بتعمل كده بتقطع في الانتيما بتاعت الحته اللي انت مش عارف تعدي منها في الكلاسيفيكيشن. في واحده اظرف ثانيه، ان انت عندك 3 وايرز تانيين، يعني سوفت واير اللي هو مثلا متعودين عليهم اللي هم الفيلدر واكس تي والجايا فيرس والاساهي، والسكند واير يبقى الميريكلز انواعهم والاساهي، والثالثه الستيفر اللي هو ميريكلز كونكوست والجايا ثيرد وهكذا. وتاخد بالونه صغيره 1 وربع 1 ونص على هاي بريشر 14 16 وموف ذا بالون فورورد 2 and 3 ملم with each deflation. كل ما بتنفخ بتزق، وانت بتعمل الكلام ده بتسحب الاثنين واير التقال تاني 3 وايرز و3 واير من 3 انواع، وحاطط في واحده منهم بالونه، والبالونه دي بتنفخها وتزقها، وانت بتعمل كده بتطلع بره وتخش تاني، بتطلع بره وتخش تاني. بعد كده لما تعدي اول مره وتلاقيها ماشيه معاك، جيب بيجر بالون واعمل نفس الطريقه. يبقى انا ما فيش مشكله عندي، دي مش محتاجه روتابليتور قوي، يعني قصه دي 3 وايرز وواحده بالونه والثانيه الاكبر منها، اسمهم كروباور افكت تكنيك. يبقى انا عندي المالتي واير بلاك كراشنجز من غير بالونات، هم وايرز بس بتزقهم، او انك تعمل 3 وايرز وواحده منهم في بالونه وتحركها كذا مره. اخر حاجه طبعا احنا كلنا، يعني انا بريكومند ان احنا كلنا يعني لازم نشتغل في موضوع الروتابليتور بصراحه. يعني انا الناس لازم يكون في سنتر اوف اكسلنسي في كل منطقه، اتليست الجامعه لازم يكون فيها موجوده، ومكان او 2 برايفت. مش كل حد عنده اي روتابليتور، لان الروتابليتور نيدز اكسبيرينس، ومشكلته لو حصل فيه منه مصيبه كبيره جدا. الانترابمنت دي لازم تتعلموا ازاي لو في انترابمنت تطلعها. فمش في موديفيكيشن روتابليتور دلوقتي، في روتا القديمه، في روتا الجديده، روتا لينك اسهل، ممكن ناس كتير تعملها، ولازم تعرفوا كويس ان انا ما اقدرش في هذا العصر 2022 اشتغل كلاسيفيكيشنز الهيفي كلاسيفيكيشنز من غير ما يكون عندي روتا او اي في ال. دلوقتي طبعا في السمول كلاسيفيكيشن الكاتنج والسكور بالون، يعني معظم الناس ولها تكنيكس برضو، انك بالراحه بالراحه بالراحه، لازم ستوري عشان تقدر تعمل كراكنج، مش تيجي البالونه تقوم رايحه على 20 وتبقى في مصيبه في القصه دي. السب انتيمال تكنيكس اكسترنال كراش، لازم برضو نتعلم كلنا ان احنا ممكن نخش سب انتيمال. لو مش عارف اخش في الهيفي كلاسيفيكيشن عشان اعمل ديستال انكرينج تكنيكس، مش هخش في تفاصيلها بتاعت السي تي اوز. الكومباينيشن ساعات بقى بيعملوا كومباينيشن، يعني تاخد التورنس تكنيك والانكور تكنيك معاه، تاخد بروكسس تورن تكنيك، تاخد روتيشنال اثيريكتومي واكسمال ليزر. يعني ممكن تعمل الاثنين. احنا ما عندناش في مصر اكسمال ليزرز، وبرضه في العالم اكسمال سنترز، لان برضه من الكلاسيفيكيشنز انت عندك السكور والانكور والسكور بالون والكاتنج بالون، وبعدين بعد كده الروتا بالاي في ال، في ليزر كمان في كلاسيفيكيشنز في بعض السنترز في العالم موجوده دلوقتي. فاينلي بالون انكروسابل ليجنز كان بي تشالنجينج. انا قلت كذا واحده، يعني اي هوب ان انتوا تكون عارفينها. انا ممكن هسيب السلايدز موجوده هنا، ممكن توك اراوند لو في اي ديسكشن عليها، ان هي موضوع تقيل شويه. awareness of the various treatment options، وممكن تجربوا very simple sequential or simultaneous application of techniques can allow successful PCR or most of uncrossable. لان دي صراحه اصعب حاجه علينا احنا كانترفنشن، مش عارف يعني تصعب عليك نفسك، يعني بعد ما تعدي الواير ومش عارف تعدي بالون، تصعب عليك نفسك يعني، وصارف وعامل كله بس مش عارف تعدي بالون، اضرب راسك في الحيط. البالونه مش بتعدي. هي قصه كل البي سي اي كلها عباره عن سلكه وبالونه، وفي الاخر اي حاجه بتموديفاي معاها. فلو السلكه عدت خير ان جود، البالونه ما عدتش مش خير ان جود، يعني لازم ايه الاثنين مع بعض. And thank you very much.
Thank you very much. I love the algorithm والslides والرسومات. زي ما قلت, one of the worst feelings is when you cross with the wire and you think you're going to dilate and the balloon and you're unable to cross. Or when you cross and your balloon doesn't inflate. Like, definitely not being unable to cross is a horrible feeling. Sometimes we're very frustrated. One of the newer technologies, it's been used in a couple of cases. I'm not saying a lot of cases, but in a couple of cases where it actually worked is IVL. IVL is a bigger balloon. The profile is big. It's bigger than the balloons we have. However, just like when we put a drug-eluting stent and we know that the elution of the drug will extend for a few millimeters outside of the stent, the same thing apparently happens with IVL. You get as close to the lesion as possible. You won't be able to cross because the profile of the balloon is too big. But you wedge it as much as possible and you give the pulsations, and it worked in a couple of cases where they were able to pulse the calcium and subsequently allow passage of a small balloon and continue with the procedure. It was presented, the first case was actually a bifurcation, LED diagonal, and they could reach, the calcification was at the ostium, was at the LED at the bifurcation. They went and as close as possible, and they managed to actually pulse and then subsequently cross with a small balloon and continue the dilatation. Another case was presented just a week ago at CRT by Carlo Domario, the same concept. So apparently there is more cases being done where the IVL lithotripsy, by getting as close as possible to the lesion, the impact of the pulsations was capable of modifying, making deep cuts in the calcium, in the intima and the media, and reaching to the adventitia, allowing passage of a balloon and subsequent complete dilatation of the lesion and successful dilatation of the lesion. Thank you very much.
انت بتقوله ده ان لسه عمرو زكي كان مقدمين حاله احنا في اسكندريه عملناها، ما اعرفش حضرتها انت، بتاعت الروتا بليتور.
يس
الروتا ما عدتش بمشكله الروتا انها على واير واحد. انما الشوك بالون او الايفا ممكن على 2 وايرز، يعني انت ممكن 2 وايرز وتعدي بالون، بس المشكله بتاعت الاي في ال البالونه كبيره، فلازم يكون فيسل كبير. عشان فالمهم احنا عملنا فيها ساعتها كانت حاجه ريكومندد يعني، والروتا ما عدتش من المين فيسل، فشل خالص، وبعدين حطت في الدياجنال فاتعملت بالصدفه. قلت طب ما يلا فتحنا الدياجنال، عندنا الواير عدى من غير ما نعمل ايفاس، بنعمل روتا للثانيه. دي نفس فكره، بس الاي في ال السيفر عن الروتا طبعا. وعندك 2 وايرز موجودين، انت بتشتغل بواير واحد، حاط واير في الدياجنال بتعمل القصه دي. المشكله الروتا دلوقتي بيعملوا حاجه اسمها كومبو، يعني انت تعمل روتا and then you combined with the IVL بعد كده. ميزه الاي في ال انه ما فيش نوري فلو. عيب الروتا بليتور انه فيري كومن نوري فلو، دي الفرق بين الاثنين. لكن ده بالادفانس تكنيك اللي هم الاخرانيين. انا بتكلم ان احنا لابد ان احنا برضو يكون عندنا فكر تاني بالاكويبمنتس اللي موجوده معانا، ان احنا ازاي نستخدم 3 وايرز، ازاي 2 وايرز، ازاي تستخدم بالونه صغيره، ازاي تزق البالونه، ازاي تفرقع البالونه، ازاي تبوش بي تي واي وتي انك تزقه، يعني في حتت. انما الهيفلي كالسيفايد ده خلاص الموضوع خلص. انا ما بتكلمش على الهيفلي كالسيفايد، سام تايمز بالرغم مش هيفلي كالسيفايد، او تفتح سي تي او، بعد ما تفتح السي تي او تلاقي مش عارف تفتح وفيش كالسيفيكيشن بيكس اوف كالسيوم موجوده، مش هتنزل تحت قوي انك تعمل الروتا، فممكن تعمل اذر تكنيكس سيمبلر. مهند رايك ايه؟
No, just a word of caution about this. Of course, it does work occasionally, but if you remember the emitters on the IVL balloon is about 2 millimeter, 2.5 millimeter from the tip.
Yes.
So of course, yeah, when it's emitting the waves, it might reach to the lesion, because you're not going to be inside the lesion.
Oh,
so
absolutely.
So it doesn't work all the time.
Absolutely.
And it's quite an expensive piece of kit. But yes, if you're stuck and suppose you're happy to try it, it's not guaranteed to succeed. I think I've suggested to the company, actually, because we tried, they are working on a new version, and I've suggested to the company to see if they could put the emitter forward. Because the emitter now, the energy goes this way and then spread. If they could get the emitter very close to the tip, then this becomes a very easy thing to do. And this is how the laser works, because the laser goes forward, affects the lesion immediately forward. And I mean, it's a fantastic talk. Thank you. I mean, we've kind of covered.
وانا عايز بس للشباب ان احنا لو انا ما عنديش روتا وما عنديش، هل في طرق تانية تستخدم؟ ده اللي عايز اوصل بيه التيك هوم مسج من هنا. في انت لازم تبقى عارف الفكره فيها ايه وازاي تعملها، وبعدين الكروسيفيتي والدبالونز مهمه جدا، لانها سواء كروسيفيتي ستنس او كروسيفيتي ستابلون. مثلا امبارح بعمل حاله كان ايست انتري ستينوزس وعلى كيرف كبير وما عايز اخش، فتحت بالعافيه بالونات صغير كبير في وام متنين، ولاد طبعا كان في نيو ليجن خلاص، لكن عشان تعدي في ستنس ما بتعديش. مثلا لازم تختار كروسيفيتيف ستنت، اخترت نوع تاني عديت بيه، وساعات تستخدم ستنت اصغر عشان تعدي وبعدين تعمل الاكبر، ما تعافرش في حاجه. فاللي انا عايز اقوله ان انا لازم اختار البالونه، اعرف الوايرز، اعرف ان انا ازاي اعمل كذا واير وبالونه معاهم، بحيث ان انا اعمل بيكينج. ما هي نفس فكره، هي بتعمل ايه؟ مش بتعمل بيكينج، انا عايز اعمل بيكينج. البيكينج ده اعمله بايه بقى؟ بوايراتي، ببالونه، بليزر، باثريكتومي، باي فيل، وات ايفر. القصه ان انا عايز اكسر الايه؟ القصه بتاعت الكالسيوم.
Just to say, I think this, if you guys want to read, we've published similar article. It's open access. If you want to search under my name on PubMed or on Google, you'll find that article covers the whole spectrum of how to deal with uncrossable undilatable lesion with all these steps and lots of tips and tricks. So it's an open access. In real life. I mean, as I said, I'm lucky, privileged to work in a place where I have laser, have rotablation, have IVL. But I do appreciate, and I think Professor Subhi is absolutely correct about you have to deal with what you have. And I think economically, these methods you mentioned, they'll probably be successful at least 70–80% of the time. Using double balloon, using sometimes putting the two balloons, I found them very helpful. You use two small balloons and you inflate them at the same time. I know you were mentioning about inflating once in each at a separate time. If you put two small balloons and inflate them at the same time, it works like a treat many times, because the pressure that comes from the balloon is not circular then, it's focused on the side of the balloons. So that works, but all the techniques that have been mentioned can be tried and usually are effective.
Thank you, Professor Subhi, for excellent presentation. I'd like to ask about, sometimes we did an excessive manipulation with multiple balloon inflation for a calcified and undilatable lesion that creates a dissection, and we don't succeed in احنا open the artery. So بيبقى في decision ان احنا تبقى to use rota and this at this situation. هل الروتا بيبقى safe after multiple manipulation with balloons to احنا نعمل debulking in the
بس هو أنتوني كولومبو عنده كلمة when you think of rota do it. بس انت we think ان انت ده patient of rota don't hesitate. ما تحاولش تلعب لا. انا معاك ان انت تقعد البالونات وديسكشنات وتلعب دي مش ايزي ومش مش سيف، لكن العكس صحيح. انت مش ما عندكش الروتا، خلاص هتعمل القصه بتاعتك الموجود. لكن لو انت حاسس ان ده ما ينفعكش والهيفي كالسيفيكيشن، ما تقعدش تلعب بالطرق اللي انا بقول لك عليها دي طرق فانكروسبل في اللي مش فيري هيفي كالسيفايد فيسلز، اللي هي لا يمكن هتيجي معاها، لا بتعديك. لكن انت سام تايمز في حاجات موجوده، هي دي بتبقى في 10% من الحالات دي انت مش عارف تعدي، وانت مش شايف الهيفي كالسيوم موجود، ومش بتعدي برضه، مش بتعدي لان انت مش عارف حتى لو عايز تجيب ايفاس وتشوفها مش هتوصل لايفاس ليه، لان انت مش عارف تجيب انت ايه السبب. فممكن يبقى فيه كالسيوم متنطور في طرق معينه، ومش محتاج مجرد بس انك تعمل كراكنج وهتعدي. وانس عدت البالونات ديفنتلي لازم هتبقى تعمل بيجر بالون وتخش في ستيبس. لكن وبعدين انت لو نجحت في الديسكشن يبقى انت غالبا سكسيد ان انت اوبن ذا اليومن. ما هو انت البي تي سي اي اصلا هي ديسكشن. زمان انا جيل البي تي سي والدكتور جلال، احنا بدينا البي تي سي قبل الستنس، ما احنا كنا بنشتغل عشان نقطع الشريان ايمن كده ولا. وكانت مشكلتنا ما عندناش جراحين، مع احترامي للجراحين مش موجودين، ما كانش حد بيسعفك، فكنا بنعمل اندر سايزد بالون عشان خاطر ان احنا ما نعملش ديسكشن كبيره او ديسكشن تبقى نون اوكلوسيف ديسكشن مش اوكلوسيف ديسكشن. فالفكره في ديسكشن مش عيب، بالعكس once you get a dissection you have succeeded to open the artery.
Sorry, the answer to your question is yes, you can use rotablation if there's dissection. The contraindication for rotablation when the dissection, we're talking about big flap, that's the only time you don't use it. But with rotablated, when you do an open CTO, you go subintimally, you're unable to deliver, you can use the rotablation.
ما انت ساعات بتفتح الارتري عشان تقدر تعدي الواير، حتى يعني انت بتعدي الروتا، ما انت ممكن بتعدي الواير، بتعمل مايكرو كاسترز وبعدين تعدي واير عادي، بعدين مايكرو كاستر، بعدين واير روتا واير. لو انت هتعمل الطريقه دي وتحاول تعدي مش هتعرف تعدي، فبتفتح شويه عشان تعدي الروتا. بس انت ما انتش عارف سيكشن ايه اللي هو الفلاب ده بقى اجيب. اوكي.
Thank you very much for this exciting talk. Now it gives me a great deal of pleasure to introduce my dear friend, close dear friend, Professor, my hero, Professor Hussam Andil, giving us his presentation on the art of decision-making in interventional cardiology.
اوكي.
صباح الخير على حضراتكم. خليني اهني الاستاذ دكتور محمد عبد الغني والاستاذ دكتور هشام صلاح، واشكر كل الزملاء اللي موجودين. الحقيقه الموضوع اللي انا اخترته عشان اتكلم عليه النهارده هو مش في الكتاب، هوش حاجه منقوله من كتاب، وزي ما سمعتوا من الدكتور محمد صبحي جزء كبير من قصه الانترفنشن كارديولوجي ابتدت قبل ما عدد كبير من الزملاء يبقى موجود. فانا المحاضره دي مينلي للصفوف اللي قاعده ورا. الصفوف اللي قدام دي طبعا ناس زي كريم ووسيم وشريف رزق، وقبلهم سامح القفاص وحسين حشمت and so on، عاشوا معايا وشافوا الطريقه اللي احنا بنشتغل بيها ونفكر بيها. العنوان هو decision making in interventional cardiology. ايه بقى قصه الديسيجن ميكنج دي؟ الديسيجن ميكنج بروسيس في رايي هي اعقد حاجه في موضوع الانترفنشن. هعمل كل الفيسلز؟ لا هعمل واحد. هخش دلوقتي؟ لا هاجلها يوم تاني. هحط هاي بريشر، هحط يعني نومينال. كل دي ديسيجنز مهمه. انا مش هطول، هم 10 دقائق او 12 دقيقه. الديسيجن ميكنج بروسيس بتبتدي قبل ما تشوف العيان، قبل ما تشوف العيان يعني وهخش في تفاصيلها. وانت بتشوف العيان في برضه جزء من الديسيجن ميكنج during the diagnostic catheterization, during the intervention, after the intervention، وبعدين case scenario. والكلمه المهمه if you fail to prepare to fail. يعني ايه fail to prepare؟ يعني لو انت بس ما نمتش كويس. ما نمتش كويس؟ ايوه ما نمتش كويس. حطيت كذا حاله مع بعض في نفس اليوم. لخبطت في الاكل. يعني حاجات السمبل از، وانا كنت بتكلم مع كريم امبارح، انك تاخد دش الصبح. ان انت تبقى فيلينج جود، ما تكونش بتخانق مع حد وداخل على الانترفنشن. فبيفور يو سي ذا بيشنت حاجات فيها مهمه. انما interventional cardiology definitely is not for everyone. افرض واحد رجله بتوجعه، لما بيقف عليها كتير ما بيرتاحش، اقول له خش interventional، ظهره بيوجعه، نظره مش مساعده. It is not for everyone. Acquire needed knowledge and skills. اللي بيحصل في الجزء بتاعنا ان انت بتاخد الجزء التكنيكال وتعرف تعمل البانكشر مثلا وتعرف تزق الواير، خلاص بقيت ايه؟ القصه بقت. طب ما هو التكنيشن والنيرس عارفين الكلام ده. Be confident. انت if you are not confident العين هيحس بيها في اول ثانيه هم والفاميلي. والكونفدنس ما بيجيش من فراغ، الكونفدنس بيجي ان انت اشتغلت وعارف انت بتعمل ايه. هذا هيلثي لايف ستايل. ايوه طبعا لازم ما ينفعش الانترفنشن كارديولوجيست يبقى مثلا بيدخن جوه اوضه القسطره او واقف قدام العيانين وبيدخن. Wisdom is as important as knowledge ودي مش محتاجه شرح. While you examine the patient اهم حاجه تاكد اللي انت هتعمله العيان ده is indicated. هل انا مثلا هعمل حاجه والحته دي مش فايبل، العيان مش هيحس باي فايده؟ هل الليجن ده بوردر لاين وانا مش متاكد؟ بي شور ان انت هتعمل حاجه فعلا انديكيتد. اتاكد من الكدني اخبارها ايه؟ العيان اموره ايه؟ هل متلصم؟ هتدخله ويطلع بمصيبه؟ answer all questions and explain cost. ايوه العيان لازم تفهمه ايه التفاصيل، ما تخشش بيه وبعدين تقول له روح بيعوا الارض هات الفلوس دلوقتي مش عارف حطوا ايه الكلام الجنان ده. يعني ده بيحصل وبنسمع عن الكلام ده، راح قال له روح خلص وبعدين تعالوا لنا وابوك هيموت دلوقتي. الهبل ده. Be kind and do not ask for money before you finish the procedure. طبعا دي حاجات ما بنقراش في الكتب ومحدش هيعلمها لك، انما الطب لازم يبقى فيه احترام. ما ينفعش انت ممكن تقول لعيان انا تكاليفي كذا اتعابي كذا وقول زي ما انت عايز، لكن ما تقولوش حطها دلوقتي او ايه حطهم لي دلوقتي او تاخدهم منه دايركتلي. ما اعرفش كل واحد ممكن يبقى عنده رايه، انما ده اللي انا شايفه. during the diagnostic catheterization مثلا مع كريم امبارح برضه بيلاحظ ان انا بنزل الترابيزه تحت خالص. ساعات واحد يبقى قصير والتكنيشن معلي له الترابيزه وجاي يعمل البانكشر مش عارف يعمل بانكشر. لازم الترابيزه تنزل تحت وتبقى انت مرتاح، تبقى ايدك مرتاحه. وطبعا لازم تدي اناف لوكال، الحاجات اللي هي ممكن تسيبها انت تقول سيبها المساعد، دي حاجات مهمه لازم تتاكد ان هو يعملها صح. لان لو العيان مش مرتاح حتى لو انت بتعمل احسن انترفنشن هيفضل تعبك طول القسطره. ميك شور ذات هارت ريت از كنترول. دخل عيان بالقسطره وهارت ريت بتاعه 110 ونايم على الترابيزه، اذا ابتديت 110 وضغطه متلصم هيحصل لك كارثه. لازم العيان يبقى ميديكالي متظبط قبل ما يخش القسطره. وسيم طبعا عارف وكريم عارفين القصه دي انها لازم ده تتعمل قبل ما تدخل على القسطره. Do not proceed if blood pressure is below 90 systolic. ما تخشش في الضغط 70 60 70 وتقول يلا هيتحسن منها، مش هتحسن. ادي فلويد، شوف ايه القصه، محتاج اتروبين، يعني ظبط الدنيا قبل ما تكمل. take extra views if needed. انا لسه كان معايا حاله مع وسيم من اقل من شهر، واحده ست سنها 67 سنه وابنها بيشتغل في امريكا وهو كارديولوجيست وكلمني، والست جالها تشيست بين وهي مسافره له. فقال لي يا دكتور حسام من فضلك اعمل لها قسطره، انا عايز اطمن لان ما عندهاش تامين في امريكا. فدخلتها وانا بصورها مع وسيم، كل البيس شكلها كويس. ولما صورنا الرايت الستاندرد فيوز مش باين حاجه قوي. فقال لي يا دكتور حسام ناخد صوره لاترال. والحقيقه وسيم كان عنده حق، اول ما حطينا صورنا اللاترال فيري تايت ليجن ما كانش باين في الستاندرد فيوز. فهذا جود اسيستنت، ما توقفش في القسطره وانت معاك واحد لخمه. طبعا انت ما بتبقى في الجامعه ممكن تعلم واحد، انما لما هتبقى في حاجه محتاجه شغل لازم يبقى واحد جنبك، ولو انت صغير هات معاك واحد كونفيدنت عشان يديك كونفيدنس. وطبعا give minimal diet. During the intervention get enough rest and sleep، احنا اتكلمنا عليها دي. choose appropriate time of the day، ما تخشش على انترفنشن وانت مزنوق في العياده وعندك مش عارف ايه وتبقى متلهوج وعمال عايز تخلص يقوم يحصل مشاكل ورا بعضيها. do not schedule more than one complex case per day. choose best assistant اتكلمنا عليها. be a leader in the cath lab. دي نقطه مهمه. انت ممكن وانت في القسطره يخش عليك واحد من زمايلك صباح الخير وانت هتحط هنا 3.5 مش عارف ايه الحاجات اللي هي، والعيان بيبقى نايم على الترابيزه وسامع الكلام ده وحاسس ان الحكايه هيصه. if you don't give the impression that you are in control جوه اوضه القسطره الدنيا هتهيص منك خالص and nobody will respect you. ولما هتحصل مشاكل هتبقى كارثه. don't allow ان الباب يتفتح كل شويه وحد طب ما تحط، طب ما تزود البريشر شويه مش عارف اعمل ايه. والتكنيشن كل واحد بقى يدلي بداله وقصه تبقى هيصه. والليدر شيب هنا اقول لكم حاجه ثانيه برضو، ان الحكيمه تبقى بتمضغ لبانه قدامك او جنبك. Don't allow this. موبايل يعني تخليه سايلنت، انما احساس الاستهزاء او احساس عدم الجديه بينتقل لكل اللي موجودين. انت بتبقى جايب، انا بقول انت بتبقى جايب الحاله على كتافك. بتكلم على حاله سواء في القصر العيني او حاله برايفت، دي حاله جايه على اسمك انت. لو اللي حواليك حصل حاجه هتلاقيهم مش تعبانين قوي يعني، مش مشكله، انت اللي هتحتاس. فلازم تبقى الليدرشيب كواليتيز دي موجوده او موجوده بقوه. وين تو ستوب از ان ارت. الدنيا ماشيه كويس وكويس ماشي، لكن عماله الدنيا مش ماشيه معاك، وقف وفهم العين معلش مش هنكمل النهارده، هنعمل يوم تاني. خد راي واحد تاني. avoid lengthy interventions. كل ما وقت القسطره، وطبعا استاذنا الدكتور جلال موجود، كل ما وقتك جوه القسطره طول كل ما البرفورمانس بتاعك هينزل. يعني في ليميت، ما تقعدش بقى 3 4 ساعات وانا البطل القومي وانا هفتح لهم كل الشرايين والكلام الجنان ده. انت بتبقى ات يور بيست في اول نص ساعه، تدي البرفورمانس يقل شويه، وتجرب نفسك تقف كده ساعتين 3، لان انت جوه اوضه القسطره لما بتقف ما بتحسش بالدنيا. فميك شور ان انت تاخد كل الديسيجنز بسرعه في وقت تبقى انت يعني مش تعبان. After the intervention take the patient and show him the results او his family. العيان من حقه ان هو يعرف ايه الاخبار. لو اخبار كويسه قولها له، واخبار وحشه قولها له. القصه ما هياش ان انت بنعمل معجزات. Meet the family and explain the outcome. attend to hemostasis، دي حته مهمه جدا. انا بقول اللي بيساعدوني صور مكان القسطره وابعتها لي على الواتساب، وميك شور ان ما يجيش هيماتوما. لما بيجي لي العيان في الفولو اب والاقي رجل ورمه ومزرقه ببقى متضايق جدا. الجزء بتاع الهيموستاسيس ده مهم جدا. write the report with your fellows. make sure ان الريبورت مكتوب كويس، هو ده في الاخر وشك وسمعتك لان اسمك اللي محطوط عليه. attend to medical therapy and special attention to dual antiplatelet therapy. do not leave immediately. دي نقطة مهمة جدا. خلص قسطرة وجري رايح على حتة تانية. اوعى تعمل كده. تخلص القسطرة وتقعد لك نص ساعة ساعة تعمل نفسك بتعمل أي حاجة، إنما تفضل قاعد حصل أي مشكلة لازم تبقى موجود. مش بعد ما تكون نزلت والدنيا زحمة تيجي ترجع تلاقي القصة خلصت. تقعد على الأقل نص ساعة ساعة، أنا بقول ساعة. تعمل نفسك متأخر، تعمل نفسك محتاس، إنما تفضل قاعد بتقرأ حاجة بتشرب حاجة. إنما ميك شور إن أنت ما تسيبش السويت بتاع القسطرة إلا والدنيا مظبوطة والدنيا تمام واللي معاك يطمنوك وأنت تطمن بنفسك. الكلام ده مش موجود في الكتب. هوريكم بس وان كيس سيناريو. ده عيان حد من زمايلي دفعتي في الباثولوجي كلمني قال لي العيان ده موجود في المستشفى، وبعت لي الصور على الواتساب زي ما انتم شايفين كده، وقال لي الراجل ده مش عايز يعمل جراحه ومتضايق جدا ومن فضلك شوفه كده. قلت له ماشي ابعته لنا وانا كنت لسه ما شفتش الفيلم. فبعت لي العيان على القسطره وكان معايا وسيم هيفتكر العيان ده. ما تشغل الفيديو ولا شغال هنا. طيب الصوره اللي بعدها بقى توريكم، يمكن في واحده كمان اللي بعدها. فالعيان ده لما انا رحت وشفت الصور طبعا فيري كريتيكال ليشن، وبقيت متردد هو انا هعمل ايه في الراجل ده. وبعد كده التردد ما بقاش موجود لانه جاله سيفير تشيست بين على الترابيزه واس تي سيجمنت تشينجز، وابتدى كيو ار اس يوسع، وكان معايا مواسيم زي ما بقول لكم. وكانت القصه بقى خلاص بعد الدياجنوستيك ده ان انا قلت ايه ورست كيس سيناريو، ان العيان ده جاله الليفت بين قفل وجايبينه لنا دلوقتي عشان امرجنسي كاستر. لازم تدي لنفسك الريزوننج اللي يخليك تشتغل. كان الديسيجن بقى ميكنج يعني نخش على السيركمفلكس ولا نخش على ال دي في العين ده. وسيم كان رايه ان احنا نخش على السيركمفلكس الاول. انا قلت له لا يا وسيم احنا عايزين نخش على ال دي الاول. معرفش انت فاكر ده يا ياسين ولا لا، انما ليه يا ياسين؟ شايفين الواير، حتى دخول الواير كان يعني احنا بروسيد، والواير دخول الواير نفسه was not straightforward. فالمهم ان الواير دخل والامور يعني حاجه ما انساهاش في العيان ده، ان انا العيان ده كان فيري بيل على الترابيزه، وزي ما بقول لكم كان شكله داينج بيشنت، والامور دي كانت في اقل من ثواني عشان ناخد الديسيجن ميكنج. وكان دكتور سنان، واول ما فتحت الستنت قال لي انا بقيت كويس يا دكتور. immediately انا بقيت كويس يا دكتور، ولقيت وشه ابتدى يحمر، والبلاد بريشر اتظبط، والكيو ار اس رجعت كويسه، والهارت ريت اتظبط immediately. واللي عملناه بعد كده اوبتمايزيشن اوف ذا واحنا ما احتاجناش ان احنا اتليست في الوقت ده نعمل any further interventions. طبعا ما اقولكوش ان مراته وبنته كانوا مستنييننا بره، انه كان ماضي هاي ريسك كونسنت، ولو انت شفت بنته مش هتنام طول الليل. مش حكايه حلوه، هتحس انها بنتك، هتحس انها بنتك، ان انت هتحس ان انت، لا طبعا الصغيرين ممكن ما يناموش طول الليل، انما هي كانت حلوه. حلوه. فاوبتمايزيشن اوف ذا ستنت. لا يعني لو انت انسان عندك انسانيه، في ناس قلبها ميت فرقش معاها، العين عاش مات، اول ما هياخد الفلوس وعملنا اللي علينا ويلا اقلب هات اللي بعده. بس احنا اما اتربينا وطلعنا، احنا اصلا كارديولوجيست، كلينيكال كارديولوجيست. وانا لما دخلت اسم الكارديولوجي ما كانش فيه يعني، كان بالعافيه اللي يعمل قسطره ويجيب الرايت كورونا نبقى فرحانين قوي. ده جبنا الرايت والرايت ايه الحق. وانا فاكر حد ده انا جوه الكورونا ري هيصه الحق. لا فبعد كده الدنيا اتغيرت بشكل. انا هقول لكم سر يمكن اول مره اقوله. انا ما دخلت اسم الكارديولوجي، انا داخل عشان اعرف كارديولوجي عشان اروح الكاردياك سيرجري. قلت هاخد ماجستير الاول وبعدين انقل على الكاردياك سيرجري. وبعدين فوجئت الدنيا بقتش محتاجه كاردياك سيرجري، لدرجه ان احنا النهارده الكاردياك سيرجرز بيدوروا يعني ايه، هيجيبوا حاله منين ولا يعملوا. الدنيا اختلفت خالص. فالكارديولوجي از في everything you need، سواء من فولفيلمنت من كلينيكال كارديولوجي، فولفيلمنت من انترفنشن. انا بالنسبه لي طبعا كلينيكال انترفنشن كارديولوجي وامشور هو ده امتع لحظه في حياتك وانت جوه اوضه القسطره. مش هقول لكم امتع من ايه تاني، انما هو امتع حاجه خالص بالنسبه لي. انا عشان الوقت مش هطول عن كده، في كيس سيناريوز ثانيه بس انا هكتفي بده. Thank you very much.
Thank you very much. I loved your presentation. حسام دايما يبقى عنده عايز يحط عنوان غير اللي مدينه له حتى في المؤتمرات عشان يحط his thinking and his feelings and his experience, and I think this is great. And I think basically اللي حسام بيقوله is really very important، اللي هو الفرق بين كلمة sympathy وكلمة empathy. sympathy انه يصعب عليك العيان او تتعاطف معاه او مع الاهل. empathy انك تحط نفسك في مكانهم وهم هيبقوا حاسين بايه، وده هيأثر على كل تصرفاتك وفكرك وكل اللي انت بتعمله. I think that this is a super important concept اللي لازم كلنا ما ننساهاش ابدا.
Can I just have just a comment? Fantastic talk, and I think this is very important for all the junior doctors who are being trained. It's the difference between continue to be a doctor and a proper doctor or becoming a technician. The technician, because it's easy to train anyone to do angioplasty. I could get a monkey to put a wire in a stand, do it 100 times, they become good at it. This is not intervention. This is not the doctor. This is not the good doctor. And keeping in mind that it's not only about the intervention itself, it's about the patient and about being a proper doctor and communicating with the patient very well and looking after them is the most important part. And I think one thing that you mentioned for everybody is good judgment comes from experience, what you're describing in here. However, experience comes from bad judgment. Through your career, you are going to make some wrong decisions. You are going to make something that is not supposed to happen. If you learn from it and you apply it next time, you are going to have a very good judgment. You are going to have a very good doctor. The main thing is just to be a good doctor, not to be a technician. Because anyone could do intervention and open the artery. It's being a doctor.
Thank you.
أنا طبعا معجب بحاجتك طول عمري طبعا، بس الزرافة ما جاتش المرة دي. الحكاية الفاميلي دي أنا لاحظتها الفترة الأخيرة إن كتير جدا ما بيقعدوش مع الناس. ويمكن إحنا منهم برضو ساعات يعني. لو أنت ما قعدتش مع أهل العيان تشرح له كويس جدا والعيان ليه الفرق بينك وبين الأمريكان أو الأوروبيين؟ إن هو بيقعد مع العيان.
أنا بعمل كده من day one.
ماشي، بس دلوقتي دي قصدي ده ليسون لازم للناس الصغيرين إنك تقعد قبل القسطره وبعد القسطره وتشرح. انا شخصيا من النوعيه القديمه اللي هي في ورق كده مطبوع اللي هو عليه رسمه الكورونري، بحط الليجنز وحتى لو في جرافت احط ستنس عشان نفتكر. في ناس عندنا من الصغيرين يقول لك لا ده بتضيع وقت والعيان يقعد يقرفني. دي مهمه جدا. الناس بره بيبقى الرسمه دي لازم تشرحها للناس، تقعد تقول له انا عملت كذا دي كذا دي كذا وكان المفروض كذا. يعني لازم العيانين لما انت تقرب منهم وتشرح لهم دي حاجه مهمه جدا. والتراست ده لان ده هو اللي عمل فقدان الثقه بين الاطباء وبين العيانين. دي حاجه مهمه جدا. الحاجه الثانيه بالنسبه لاوضه القسطره، انت قلت كل حاجه، بس انا في واحد مهم جدا في اوضه القسطره اسمه الفني الاكسبيرينس، مش الدكتور المساعد بس. حكايه الفيو اللي انت قلت عليه رايت كورونري، الناس التكنيشنز القدام الشطار هم بيساعدوك شويه في ديفرنت فيوز ان انت تعمل، ولازم تشوف بعين ثانيه حد حتى لو في الكنترول معاك تستفيد منه بيه. ما تطلعش من الاوضه في حاله زي اللي انت قلتها الا اذا تكون متاكد تماما ان العيان ده نورمال او ابنورمال. دي حاجه مهمه جدا. انا بشكرك تاني على المحاضره الجميله دي.
ان انت ركزت وسمعت التفاصيل. حاجه اخيره برضو عايز اقولها لكم. العيان ساعات بيجي يقول لك يا دكتور اللي عمل لي القسطره ما كانش يلاقي المقاس بتاعه. ده هو يعني يكون عيان عمل قسطره عند حد تاني وجاي لك يقول لك ده كان طالب 3.5 والحكيمه قالت له ما فيش الا 3 عشان قالوا قدامه، وهو بيفضل لازق. هو انا يا دكتور اتعمل لي قسطره كويسه؟ هو الدعامات بتاعتي دي سليمه؟ بيفضل دايما عنده شك لانه جوه اوضه القسطره هو سمع ان انت طلبت مقاس وان قالوا لك لا مش موجود. عمرك ما تعمل ده بحيث ان العيان يحس بيها. لو انت هتسال حاجه اسالها ممكن ان انجلش لو العيان ما هواش يعني لغته، دايما ان انجلش. ودايما تفهم الحكيمه ان انت ما تحطيش الكلام بحيث ان العيان يبقى عايش المشكله. ما فيش الواير الفلاني ده مش عارف ايه، ابتدي العيان يحس وهو على الترابيزه ان هو فاقد الثقه، ان هو ان انت ما عندكش المطلوب.
دكتور حسام انا بحيي حضرتك على المحاضره دي. المحاضره دي مهمه جدا ان احنا نقولها في كل مؤتمراتنا. المسج لازم تبقى واضحه جدا. ده مش تكنيك، ده علم واخلاق. فبهني حضرتك على المحاضره. شكرا.
ربنا يخليك.
عندنا لايف ترانسميشن.
انا اتعلمت الدكتور جلال حاجات
الصبح رئيس الجلسه بتاعت اللايف ترانسميشن.
معلش احنا عشان
ابتدي دلوقتي اللايف.
ما يكون فور استاذ الدكتور محمد صبحي،
سام،
الدكتور سامح ايمين، استاذ الدكتور احمد مجدي.
لازم اسلمك الرايه بنفسي
حبيبي. هادي.
عندنا لايف ترانسميشن. عندنا very interesting structural heart disease case.
سكرين اوكي.
طبعا بشكر تاني الطب القصرين قسم القلب وهنيهم على الميتنج المنظم وابيري اب تو ديت. والدكتور حسام منديل طبعا لنا محاضره قويه بصراحه. الويزدم حسام مهم قوي في الكلام. مين اللي هيقدم الحاله؟
احنا لا we will go for live after
5 minutes
يعني 5 to 10 minutes كده.
لسه؟
اولا صباح الخير على الجميع. احنا طبعا بنرحب بحضراتكم. احنا النهارده معانا يعني استاذ دكتور رضا ابو العطا. هي بشكر التيم كله اللي معانا من دكاتره وتمريض وفني اشعه. احنا بننقل لحضراتكم من اوضه القسطره بتاعه القصر العيني، واحنا اخترنا حوالي 6 حالات ان شاء الله we'll be going through. بادئين بالحاجات، احنا كل مؤتمر تقريبا بنشوف حالات تافه كتيره وحالات يعني، فقلنا المره دي نغير شويه، فقلنا نعمل واتشمان ديفايس فور left atrial occlusion، ودوت اللي احنا بادئين بيه. وهنعمل تاني حاله برضه هيكون فيه hypertrophic cardiomyopathy ونعمل فيها septal ablation، وبعد كده ان شاء الله هنعمل حاله endomyocardial biopsy. التكنيكس اللي relatively should be easy but we've been for some time most of us are not doing it. هيكون عندنا حالات coronary as well وحالات كلاسيكيه تانية بس، وحالات coronary complex برضو CTOs، وحاله calcification وهنستخدم فيها الروتابليتر اللي كان حضراتكم لسه بتتكلموا عنها. طبعا ان شاء الله كده within 10 minutes we will go live تاني مع حضراتكم، فبليز continue with the program واحنا بعد كده هنكونكت مع حضراتكم ونبتدي الحلقه.
طب احنا دلوقتي ممكن الدكتور جلال سعيد يقول المحاضره بتاعته، مش كده؟ دكتور جلال بيه، انا ليا الشرف اقدم حضرتك بيه تاني. ممكن نطلع اوف اللايف ونشتغل؟ اوكي. دكتور جلال سعيد بروفيسور كارديولوجي Cairo University and the godfather of cardiology in Egypt. دكتور جلال السعيد اول واحد جاب ايكو في مصر، واول واحد جاب قسطره. بس على فكره انا اتعلمت دكتور جلال حاجه ثانيه نسيت اقولها. هو دكتور جلال السعيد كان بيشتغل الظهر، انا اتعلمت منه، قلت اشتغل الظهر. بعدين كان جايب عنده ايكو ستريس وقلت، رحت في اسكندريه جبت ايكو ستريس وقلت في العياده بقى الخاصه. بعدين انا لما جبت، بس انا سبقته في حاجه، دكتور جلال بيه سبقته في حاجه. هو كان بيشتغل، هو دكتور محسن ابراهيم، بلاك اند وايت والدوبلر. انا قلت ان في حاجه اسمها كالرد، وبعدين رحت الشركه قلت لها هبيع الديكو ده واجيب الكالرد زقوتي. رحت مكلمهم طبعا اساسك هو يا بيه ممكن يا بيه تسمح لي انا ابقى اجيب في عيادتي كده واشرف؟ انت مجنون؟ ده في الكليات عشان خاطر يا بيه المستقبل الكارد والكالرد والله. فسافرت ايطاليا، شفت ان الشركه دي عندها مصنع وبيعملوا بوردات الطيران، فاتاكدت ان فلوسي طبعا حلال هتروح بعتها وجيت. بعدين الدنيا قلبت بعد كده، فالكالرد اصبح موجود في كل عيادات مصر في المستوصفات. فهو صراحه الحاجه الثالثه الدكتور جلال سعيد اول واحد يعمل بزنس ميديكال برايفت، هو الدكتور عادل امام. انا برضو كان من وهو كلمني وناداني معايا، بس انا برضو قلدته، فهو مثل قوي جدا. الحاجه الثانيه انه الدكتور جلال سعيد من الناس اللي هم طول عمره ما بيغيرش اسلوبه في الكلام ولا الطريقه، ما بيتغيرش. هو تراستبل مان مع العيانين، ومع هو عاجبك مش عاجبك، هو ده النظام الموجود، وفي كلامه هو اللي صح في الاخر الحقيقه. فانا يعني ليا الشرف ان اقدم حضرتك استاذي الاستاذ الدكتور جلال سعيد.
متشكرين جدا يا محمد. اكشولي علاقتي باسكندريه دي، هو اول ما تعينت معيد الدكتور صلاح الملاح الله يرحمه قال للدكتور علي سرور انت لازم تبعت جلال السعيد ونبيل الشريف اسكندريه عشان يتعلموا الديسيبلين ويتعلموا النظام، لان اسكندريه كان الرئيس القسم هناك الدكتور صلاح بيه، وكان منظم القسم وكانوا بيعملوا اساطر. وقعدت اتفرج على الريسيرش كان بيعمله مصطفى عبد الفتاح على بالهرزل، فاخدت تريننج عندهم شهرين. وبعدين علاقتي بمحمد صبحي زي مش صحوبيه، ده احنا اخوات، وبشكره دايما على انه بيأبرزني. وبعدين انا ما اشتغلتش برايفت غير بعد ما دخلت على المعاش، وده مهم جدا لان البرايفت بيضيع. بعد ما اشتغلت بالمعاش يعني الانرجي اللي عندي spend it in private practice. وبعدين امبارح اتكلمت على حاله كونجينيتال وقفلنا في كوروناري فيستلا بامبلانسر، والنهارده هتكلم على حاله مسميها 3 جوبرت، يعني 3 مصايب. المصايب بيجوا واحده، ده 3 مصايب. وبعدين انا بشكر حسام قنديل لان انا كان اتكلمت مع هشام صلاح واتكلمت ان انا ممكن اتكلم كلمتين يعني على عشان ان انا the oldest cardiologist واغلب اللي موجودين هنا يا اما انا ساعدتهم في التعليم يا اما امتحنتهم بما فيهم محمد صبحي وحسام قنديل. فاول حاجه تريبل جيوبرت، 3 مصايب. والحاله دي عملتها مع الدكتور وسيم. نكست سلايد، وري اللي بعدها. العيان ده 6 year old male patient business man بس under severe financial stress، يعني البنك استولى على كل حاجته وفلوسه وكده. هو سموكر 3 باكس with never stops against all my advice. عنده positive family history of premature coronary artery disease. الباست هيستوري سنة 96 كان سنه 34 سنة وكان في شرم الشيخ وعمل كار اكسيدنت وجاله انتيريور مايوكاردال انفاركشن وجاله كاردياك ارست وريسسيتيتد وبعدين بعتوه لي. عملت له بي سي اي لل اي دي سنة 96 وب2 ميتال ستينز لان الدراج اليوتيك ما كانتش موجود. After 1 year I did for him stress, it was negative and okay. Next one. سنة 2005 stable angina وعملنا له another PCI with 3 drug-eluting stents. سنة 2015 unstable angina وanother 4 stents. The patient is not compliant at all, but still he smokes 3 packs. Next one. البريزنت إلسري في أغسطس ده من أسبوعين. لا في أغسطس العيان جالي وبيشتكي من أنجينا وبروجريسيف. قلت له لازم تعمل قسطرة. قال لي أنت كل ما تشوفني تقول لي قسطرة ورفض. بعدين بعدها من 14 فبراير يعني تقريبا أقل من شهر جاله سيفير اجونايزنج تشيست بين مع سويتنج وكولنس اند دراوز. ده هو يعني العيانين بيبقوا اتاتشد. طلبني وقلت له جري على المستشفى وده الرسم انفاركشن وجه المستشفى. نيكست وان. وده انظر وهو اول ما دخل اوضه القسطره. Next one. He was rushed to the caster room. Door to needle كانت اقل 20 دقيقه. انا كنت بره رحت جري وكلمت وسيم جه لحقني وعملنا له كورونري انجو. لقينا اوكلودد ال اي دي واوكلودد رايت كورونري واوكلودد سيركمفلكس. العيان كان عايش على 1 obtuse margin, small obtuse margin. Next one. دي الصورة شايفين السيركمفلكس مقفول وشكله كرونيك والال دي مقفول مطرح ستنت. Next one. فبسرعة دخلنا. يعني أنا على ما وصلت كان one of the assistants اللي في المستشفى حط الشيس ف there is no waste at all. فجه وسيم بقى وفتحنا ال دي. next one. دخلنا واير دخل ايزي جدا لأنه ريسنت. وبعدين قعدنا ببالونات نسلك وبعدين وبعدين في البروكسيمال بارت اللي فيها ليجن حطينا ستنت. نكست one. وده الفاينل ريزلت. انا عارف واحد هيسال ما عملتش سكشن ليه؟ خلاص ما دام انا دخلت واير وبالونه وسلك والبرانشز بانت. why I do suction which may have complication. Next one. السيركمفلكس سمول وقلنا نسيبه احسن. الرايت برضه توتال اوكلوجن. كله مليان ستنتس. دخلنا باير ودينا اجرستات.
ايوه.
ونكست ون. نكست ون. وحطينا ستنت فوق وستنت تحت. نكست ون. وده الفاينل ريزلت. مش شايف من جنب كده. اللي بعدها. اللي بعدها. البين ديسابيرد بعد ما رحنا الرايت. didn't disappear بعد ما فتحنا الليفت. والبلاد بريشر رجع. والانجو والانتروب سويند. والpatient was kept on agrestat for one night. At night, and I did for him echo, and the ejection fraction was 33. Next day, ده البوست بعد الكاستر على طول. السكند داي الايجكشن فراكشن اللي كانت 30 بقت 58 بقت 58. فهو ده example of stunned myocardium, but because we interfered rapidly, it improved immediately. And the CKMB والتروبونين كانوا very high. CKMB كان 300 وحاجة. تاني يوم normal. Indicates that إن الليفل اللي عالي الأولاني كان ووش. Next one. The patient discharged after 3 days on medical treatment, and I give him antithrombotic small dose because it was thrombosis. Next one. Next one, Karim. Before we finish, I will. أنا برضو يعني حسام قال كلمة جميلة مش في الكتب. فأنا عشان يعني my experience في هشام واتكلمت معاه إن أنا أقول some of my feelings to my colleagues and my friends. I would like to, number one, I would like to congratulate an organizing committee. This is a meeting with the standard of قصر العين. Which and that's why it's this is what we want. Next one. I hope that everyone do his best and fight hard to restore قصر العين status as it was usually. قصر العيني was in the front, and I hope it goes again in the front. Next one. At the end, I would like to share some of my thoughts, which are not medical, like the nice talk of Hussein. You know, I'm still working part-time, despite my age. For the following reasons, which I want to convey to everyone. Work is life, and I always advise those who retire not to work anything, but to avoid health and psychological problems. Next one. The beauty, the second thing which made me still work is the beauty of interventional cardiology. Changed us from diagnostician to therapist. It gives us enjoyment and the pleasure while treating especially challenging patients. When I went to cardiology, we had only Down Brothers stethoscope and the X-ray film. And when we went to Custer, we were doing Custer to send surgery. But now we treat patients, and this is enjoyment and pleasure, and so we have to keep. And next one. Most of the patients, the pleasure, the case of the fistula, which I presented yesterday, gave me pleasure because I was thinking and were able to close it with the device. And the second, this patient is attached to me. And most of the patients I am treating now have been with me for a very long time. And they are attached to me. And I am attached to them. Like this patient who I was treating for more than 30 years. When he collapsed, he called me. And when he went into the hospital, he refused to go into the Custer room until I arrived. Another example, daughter, another funny example, daughter of one of the ministers of finance. She had rheumatic heart, and I was treating her. And when she deteriorated, she said, my will, Dr. Galal, is that you walk in my funeral. She was attached and wanted me to walk in her funeral. And I did. And that's obligation for us. لا مش فاينانس بروفيسور في الديفنس. انت عارف ده كانت بنت حيدر باشا. My dictum in life spoke with new advances, and I advise all of you to do. I moved with technology. Every new technology I moved. Now it's difficult with this CTO and the retrograde and the things, but I moved all my life with the technology. And I advise the young cardiologist, you cannot be a good cardiologist without being a good physician. And you have to learn some congenital heart because they come to us like this child, which I close to with the device. Finally, remember, this is my dictum. Fight the resistance, fighting, and the hard work leads to availability and success. You have to fight. Yeah, Muhammad Abdul Ghani, you have to fight to finish things, as you know. And you have to persist. And I have persisted. Magdi Yaoub's success is because he has persisted. And the hard work, he is also hard working. And finally, I would advise people, the doctors, to be good physicians so that they can be good cardiologists. And my advice to them, you have to love people so that they love you. The love of the people is from the love of God. And finally, I thank my young colleague, Karim, for preparing this.
شكرا لبيه. طبعا محاضره قيمه جدا ومليانه حاجات، وحاجه فعلا المسج اللي حضرتك قلتها كذا حاجه. اول حاجه بالنسبه للكيس نفسها، يعني دايما لما بيجي العيان هنا بيسال حضرتك دايما بيقول لك خلاص يا بيه انا انتهينا، يعني مش هنعمل اي حاجه ثانيه، تقول له لا اتس ذا بيجيننج اوف ذا ستوري، يعني انت هتبقى عايش معايا سنين. فربنا يدي حضرتك الصحه، حضرتك شفت العيانين دول طول عمرك وشايفهم بيجوا لك على طول على مدار الناس وبيسالوا في حاجه، سواء دلوقتي كمان على فكره ممكن تلاقي العيانين بتوعك عندهم حاجات كاروتيد، يعمل ستنتنج، يعمل ايفار، يعمل تيفار، يعمل يعني بريفرال، يعمل بريك بيس ميكرز، يعني طول السنين دي وانه طالب حضرتك بالاسم بعد 35 سنه وعايز يجي، دي حاجه مهمه. فدي حاجه بيشنت ريليشن. الحاجه الثانيه بس في البيشنتس بقى حضرتك اللي عملته كلينيكال الحياه دي فيري جود اكزامبل اوف دبل انفارشنز، ان في عيانين كتير اللي هايلي ثرومبوتكس مش بيبقى عندهم، احنا عندنا الجايد لاين بتقول تعمل اونلي وان فيسل، بس دي اكسبشن because this is double infarction. يا جماعه اللي هناك بس دول، انت عندك اما تلاقي انفيريور وانتيريور يا ليفت مين، يا اما عندك تو فيسلز. الدكتور جال عملوا اللاد. الحاجه الثانيه طبعا النصيحه انك تفتح اللاد. العيان بيعيش باللاد، العيان بيقطع من اوضه العمليات باللاد. لو ليمه مش متركبه العيان بيموت، لو ليمه متركبه ويسيب الرايت بيعيش. فده بيست ان حضرتك عملته ده كده، والرايت كونجراتيوليشن بيه على المحاضره العامه، وربنا يديك الصحه يا فندم.
اسمحوا لي بس اقول كلمه للدكتور جلال، مش بس الاب الروحي القصر العيني، دكتور جلال الاب الروحي لكل اطباء القلب في جمهوريه مصر العربيه والميدل ايست باي ذا واي كمان. دكتور جلال ما زال بيعمل سبورت لاسم القلب. دكتور جلال جاب لنا خلال الشهور اللي فاتوا احدث جهاز موجات صوتيه في القصر العيني، جاب لنا جهاز رسم قلب مجهود، جاب لنا بمجهودات عن طريق البنوك جهاز هولتر جديد. دكتور جلال هو المرشح الوحيد من جامعه القاهره لجائزه الرواد. دكتور جلال ما زال بجدي، احنا بنشكر حضرتك على العطاء المستمر، واحنا كل ما بنحتاج حاجه بنكلم حضرتك. دكتور جلال يشاركنا في كل المؤتمرات. احنا سعداء بحضرتك معانا، احنا صحيح عايشين تحت ظل حضرتك، ونتمنى لك كل الصحه.
دكتور جلال، انا عايز اقف وانا بتكلم. I loved your presentation. I think it's amazing. I commend you tremendously for what you've done, your efforts, your continued efforts. I commend you for the wonderful message اللي حضرتك بتديه. It's an incredible message of persistence, perseverance. It's very inspiring, extremely inspiring. يعني it's amazing ده الواحد دلوقتي حتى لما بتخش على حالة acute الواحد اعصابه بتتشد. It's amazing ان حضرتك ما زلت قادر انك بتخش وتستحمل الستريس والمنتل ستريس especially in your patients معاك من زمان. This adds another level of stress. Super, all my respects.
أنا طبعا يعني استمتعت زي ما كل اللي موجودين استمتعوا. محاضرة جميلة جدا وكل كلمة فيها يعني لها وزن وقيمة. لكن لو أنا هقول حاجة واحدة على الدكتور جلال، وأنا عشت معاه عمري كله، الدكتور جلال كان له مرضى من أعلى مستوى في الدولة. يعني مش محتاج أقول لكم أسماء ولا إيه الناس اللي كانوا موجودين، وأنا كنت بشوفه وبشوفهم. الحاجة الواضحة قوية جدا إنه هو كان عمره ما بينزل كرامته واحترامه ثانية. كان دايما بيحسسني، لأنه أنت بتبقى حاسس إنه الأستاذ بتاعك ده أو الشخص ده هو الحيطة اللي أنت بتسند عليها. بتحس إنه هو فيري سوليد قدام الناس اللي هم بيشار عليهم بالبنان، وعمره جاب سيرة حد منهم، وعمره ما قال أنا بعالج فلان. ودي حاجة مهمة قوي. في ناس بتعالج مش عارف إيه وتلاقيه حاطط صورته على الفيسبوك هو معاه وفرحان قوي، عمره ما جاب سيرة حاجة زي دي. فدي حاجة بتخليك تحس إن أنت أعلى من أي فئة تانية في المجتمع. أنت المجتمع كله بيجي لك عشان تعالجه، وأنت صاحب كرامة وصاحب قيمة، والمجتمع بيبص لك بالاحترام ده لما أنت تتصرف بطريقة الاحترام دي. شكرا يا دكتور جلال.
في نقطتين دكتور جلال بس حضرتك قلتهم برضو نريفايز الناس. احنا في العصر الاولاني كنا كلينيشن فعلا وسماعه، وحضرتك من اوائل الناس اللي جبت الايكو. انا فاكر كويس ان انا وانا صغير كان عندي لسه جايب الايكو، فكنت ليفل اعلى من البطنه، مش قصدي احسن منهم يعني، بس كان دايما يبصوا البطنجي ده راجل بتاع سماعه ومالوش، والجراحين يبصوا لك جذبه الكلاب كده، روح الولد بتاع البطنه ده. بقيت نطيت بقيت ايكو وستريس، بعدين نطيت بقيت دايجنوستيك، بعدين نطيت بقيت انترفنشن. بقينا قعدت مع الجراحين في نفس الاوضه، هو انا يمين، انا حتى في الاي سي عندنا انا يمين هم شمال. الحاجه اللي اتعلمتها من احنا بقى دخلنا في الكومبلكس بي سي اي، بقينا بنعمل شيب بيشنت، بقينا بنعمل سي تي اوز، الليفل بيعلى. بقينا دخلنا بقى في الليفل بتاع ستراكشرز الاعلى واعلى. لما تقعد مع الجراحين، الجراح الشاطر اللي هو بيعرف كارديولوجي كويس، والكارديولوجي كويس اللي بيعرف ازاي يعمل سيشن كويس. اذا انا لازم اخد الاجريسفنس بتاع الجراح والبرايتنس بتاعت الميدسن. انت ليه الكارديولوجي مهم؟ انت بتجمع بين الصفتين دول. انت راجل بتشتغل كلينيشن، مفيش حاجه بقى قسطره على طول. اصل احنا بنشوف دلوقتي الجيل الصغير كله عايز يطلع قسطره على طول، ما ينفعش ما ينفعش. لازم تاخد الاول الميدسن وبعدين تاخد. والحاجات اللي بتميزنا الجيل زمان انه بياخد الميدسن من الاول، والعيان لما بيجي له مش بيفكر انه في قسطره، بيفكر فيه از بيشنت، وممكن يبقى يطلع منه اي حاجه ثانيه. مش انا فاكر والله دكاتره، مش عايز اقول اسماء ناس، بس يقول لي انا بشوف العيانين بيقولوا لي قد ايه في العياده اطلع منهم بكام قسطره. يخرب عقلك، مش دي القضيه. القضيه انك تعالج عيان. دكتور جلال رمز كبير ان طول عمره كلينيشن وبيشوف الروشته بتتكتب ازاي، وبعدين التكنيك ده بيساعد الدكتور. انا بشكر حضرتك على الحته الاولانيه دي، انها مهمه جدا جدا جدا. الحاجه الثانيه البيشنت ريليشن شيب. البيشنت ريليشن شيب هي اللي بتستمر، وعدم انك تقول انا بعالج مين، ودايما عندك احترام لنفسك قدام الناس مهم. دي برضو صفه من صفات الدكتور جلال احنا اتعلمناها كلنا. انا بشكر حضرتك تاني والله بيه. انا مش احنا مهما اتكلمنا على حضرتك مش هنوفيك حضرتك على مجال الكارديولوجي حاجه. شكرا يا بيه.
جاهزين لللايف.
شام خلاص ولا لسه؟ بتقفل؟ يا باشا ده انت تأمرنا.
ايه ده مش هنسى. ربنا يخليك. بالنسبه للدكتور جلال، احنا طبعا غني عن يعني كل الكلام اللي اتقال، بس انا اضطريت اتكلم لاني اعرف واقعه
ديبلويت وبعدين نروح لايف.
اعرف واقعه.
اوكي خلينا ديبلويت وبعدين. لا لحظه يا محمد give us 2 minutes.
اعرف واقعه معينه. في واحد راح له في العياده فسابه استنى الدور. راح له في العياده واستنى الدور ده، الناس كانت بتملس عليه كده عشان يحصل لها البركات. والله العظيم انا لما عرفت ذهلت انه هو عمل كده ازاي، انا مش عارف. الحاجه الثانيه بقى، هو اتكلم عن نقطه مهمه قوي، ان موضوع الكاثيترايزيشن قلب من دايجنوستيك لثيرابيتيك. الخطوه دي خطوه مهمه جدا، وحتى في نفسيه كل الجماعه بتوع الانترفنشن، انك انت مش كنت بتشخص، لا ده انت بتخفف العيان بيخف من عندك، شكوته انتهت. في الفتره الاخيره ال5 سنين الاخيره حصل اضافه ان في فيلد جديده اتفتحت، مش مجرد انك انت تعمل انترفنشن للكاروتيز تفتح الكاروتيز، ده احنا دخلنا في السيريبرال سيركيوليشن، دخلنا وبنتائج مبهره. واحد بهيموبليجيا فكت الهيموبليجيا، انا شفت ده. فدي حاجات ثانيه في الالكتروفيسيولوجي اتعمل حاجات كتيره. وبعدين الحاجه الثالثه في الرينال ارتري برضه كاسيترايزيشن والكلام اللي بيتعمل وهايبرتنشن، كلام جديد كتير. فالفيلد وسع قوي خلال يمكن السنتين او 3 الاخرين. وبعدين اخر حاجه حتى كنا بنتكلم فيها امبارح، موضوع البلمونري امبوليزم. احنا البلمونري امبوليزم ده مشكله من نهار ما عرفنا طب. البلمونري امبوليزم ده مصيبه. احنا امبارح الكلام كان واضح ان هو برضه الحل انك تعمل رايت اند ليفت كاسيترايزيشن. شكرا.
Are you ready to هشام صلاح؟ Are you ready ولا انت؟
ايوه we are ready يا جماعه. Live please.
اوكي.
معانا يا جماعه لايف؟
يس اوكي جو اهيد.
دكتور صبحي نرحب بحضرتك وبدكتور حسام ودكتور عبد الغني وكل البانل الجميل. انا معايا هنا استاذ دكتور رضا ابو العطا، ومعانا تيم رائع من المدرسين المساعدين بتوعنا وطقم من النيرسينج ستاف. طبعا احب اقولهم واحد واحد. ومعايا طبعا استاذ دكتور محمد عبد المجيد. الحقيقه احنا النهارده we are dealing with a case it's a bit complex case. مش في التكنيك بتاع الانستولمنت، ولكن it's an 80-year-old lady having ischemic heart disease. She developed an inferior MI in 3 years ago, and she deployed 2 stents. وبعد كده ابتدى يجي لها some problems related لإسكيميا. اتعمل لها انجيو، باين ان عندها CTO في ال LAD. احنا مشكلتنا هنا ان هي she develops paroxysmal AF، وفي نفس الوقت she bleeds repeatedly. اخر مره دخلت من around 3 days ago الهيموجلوبين drops to 6 grams، واضطرينا ندي 2 units blood. هدير معانا هنا النائب بتاعنا. I think she can be giving us some data about the patient. هدير, go ahead.
Can you hear me?
Yes, go ahead.
Okay. Yes, doctor.
احنا مش سامعينك يا هدير.
Ladies and gentlemen, I'm here to present the case that Dr. Hisham reported.
لا انتوا سامعين هدير معاكم
ولا؟ سامعينها كويس. اوكي.
اوكي جود تمام.
Our case is an 80-year-old female patient. She's known to be hypertensive, paroxysmal atrial fibrillation with CHA2DS2-VASc score of 6 points and Hasbled score 4. The patient has history of acute coronary syndrome in the form of inferior STEMI, for which she underwent primary PCI to the RCA with 2 drug-eluting stents 3 years ago. She is also known for heart failure with repeated hospital admission by acutely compensated heart failure, and also she experienced the recurrent attack of melena with subsequent hemoglobin drop and anemia, for which she received repeated blood transfusion. Our patient on admission was vitally stable. Her laboratory panel was normal, except for the hemoglobin level was 6.5. She received 2 units bagged RBCs, and now the hemoglobin level is 9.2. The ECG shows sinus rhythm with poor R wave progression, pathological Q waves in the inferior leads, and ST depression in the high lateral leads, while the echocardiography show borderline RV dimensions with impaired overall contractility, ejection fraction of 42%, dilated left atrium 4.7, regional wall motion abnormalities in the LAD and the RCA territory, and there is also moderate mitral regurg and moderate tricuspid regurg, pulmonary artery systolic pressure of 67 millimeter mercury. The TE was done for her, showing free left atrium and left atrium appendage from any thrombi. Upper GI endoscopy and lower GI endoscopy shows diffuse gastritis and the multiple colonic polyps, for which there was no further intervention to be done for her. So our patient has a high bleeding risk, as we mentioned before, has blood score 4, and also have high risk for developing thromboembolic event. So we chose to proceed with non-pharmacologic solution for her, which is the left atrial appendage occlusion by Watchman device.
شكرا يا هدير.
الهاسبلد can you explain to us الهاسبلد itself items for this patient, how do you calculate it?
Okay,
this is the issue.
80 years old. She's hypertensive. She has obvious cause for anemia, which is multiple colonic polyps shown by the lower GI endoscopy.
Okay.
So she's elderly, hypertensive, and she had bleeding.
So warfarin and NOAC are contraindicated or not needed.
مش قادرين يا دكتور صبحي. شكرا يا هدير. احنا هنا طبعا it's a bit difficult to give anticoagulation for this patient، والحقيقه احنا مضطرين برضو عايزين ندي anti platelet. فاحنا we are in a real يعني problem regarding الانتيكواجيليشن والانتي-thrombotic management. وبيجي لها paroxysmal AF and she has a CHA2DS2-VASc score of 6. She has a Hasbled score of 4. فاحنا في موقف لا نحسد عليه. عادة putting a Watchman or whatever device to occlude the left atrial appendage is a class 2B indication. بس هنا I think it's highly indicated, and I think it was mandatory. It was mandatory to go for this step. احنا بعض الحاجات اللي قعدنا نفكر فيها, should we go for the coronary first or go for the device first? When should we be doing the coronary? واحنا I think if the coronary status is stabilized, I think ان احنا we should be waiting. احنا we went through the steps, ومعانا بروفيسور رضا ابو العطا, ومعايا على الترابيزه برضو دكتوره ميرنا ممدوح, ومعايا من الصباح معايا فني اشعه محمد, ومعايا طبعا اسامه سعدي على الTEE, والحقيقه الرول بتاع اسامه كان برضو extremely important. الحقيقه احنا كتير مننا طبعا عنده اكسبيرينس في قصه الترانسبتال، بس بروفيسور رضا ابو العطا الحقيقه طبعا is a master in such technique. احنا استخدمنا both the fluoroscopy as well as the TE to decide the point of entry and the puncture site. بنستخدم multiple views REO، بنستخدم طبعا برضو باي كيفل فيو، بنستخدم at least 2 views في التي اي، وبنستخدم 2 views بالفلوروسكوبي. الستبس اللي اتعملت، لو بروفيسور ابو العطا يحب يقول لنا كده عشان just to go through this educational case. احنا على فكره احنا we went through the steps and finally the device. انا حبيت انكم تدخلوا معانا في اللحظه اللي احنا بنحط فيها الديفايس اللي هو just immediately now it's installed. بروفيسور رضا.
Good morning, everybody. Thank you very much, Dr. Hisham, Dr. Hussam. Thank you very much, Dr. Muhammad and Dr. Sobhi. It's my pleasure to be here with you. As we heard this lady, she is indicated for non-pharmacological. I would like to go to the steps step by step. First of all, this type of patients, we need to have a transeptal, which is a little bit different than we are used to. For the mitral, we should get an inferior and posterior stick. If we have the echo images, and Dr. Osama will give us the images, and then we'll go to the anatomy of this appendage in a bit. Can we have whatever, ya Osama, if you can give us the anatomy first or the transeptal? Okay, so this is the images. He will get us the images. If we look carefully, usually we get the appendage in 4 views, which is at 0 degree, and then at 45 degree, and 90 degree, and then finally
can we see the echo?
Yes,
we will be showing the echo now.
We need to see the echo.
والحقيقة برضو من غير قطع كلام
crucial point the echo now.
من غير قطع كلام دكتور ابو العطا، الحقيقه this is a complete science. يعني حتى مش بس choosing how to choose the size of the Watchman or whatever device we are using, type والشيب بتاع الابندج differs from one patient to another. ممكن اشوفه شكلهم كلهم كانهم مثلا slit like كده، بس هي انواع، في cauliflower type زي اللي طلع في الحاله ديت، وفي different other types. بروفيسور ابو العطا we will be explaining to حضراتكم.
Do we see echo, Dr. Sobhi, or we don't?
No.
Okay.
ممكن ننقل يا جماعه ايكو.
اوكي
كان نعمل وايد سكرين للايكو، بس بلاش الصور الثانيه عشان الايكو يبقى واضح. Okay, go ahead. Yes, correct.
Go back to 0 again.
شايفين كده يا دكتور؟
كده احسن، صورة احسن.
Usually this is the home view. We can see anatomically, we can see the left upper pulmonary vein. You can see the appendage. We see the inflow and the main body of the appendage, and we see the aortic valve in the middle of the image. Next view, please. Here we can see it in the what we call in the oblique view, which is a 45 degree. We can see again the appendage in the same view. It looks as in 0 and 45 and 90 degree, it all the same. But when we go to the 135 degree, we can appreciate how with the shape of the appendage here, we can see it is a cauliflower view. Can you mark here, Osama, please?
Very nice.
Yeah, this is, you see the termination of the appendage. It looks as a cactus or a cauliflower. It's not very strange shape. It's a big sized appendage for this lady. And when we size in the landing zone or the os of the appendage in all the views. And the average diameter we got here, it was a 22 millimeter. When we have an appendage size for a 22 millimeter, we need a 20% oversize of the device to make sure that it is catching the appendage. The next is to have an angiographic images of this one. Can we please see the angiographic images? Usually we have 2 standard views, which is the right anterior oblique caudal.
من الأول
right anterior oblique caudal and right anterior oblique cranial. If we see the no just to get
يعني بس عشان الستبس برضو معاهم من الأول يا دكتور رضا. احنا we go first by طبعا بنعمل arterial وفينس entry. في الارتيريال بندخل ببيك تيل كاثيتر وبنحطها على النون كرونري كاسب. وطبعا زي ما دكتور رضا كان بيقول لنا ان النون كرونري كاسب is usually lower than the right coronary cusp. ودي نقطة مهمة علشان احنا برضو دي حاجة من الحاجات اللي بتدينا guidance during the entry. ما بنحطهاش على الرايت كرونري، بنحطها على النون كرونري كاسب. وبندخل بعد كده بالفينس في الفينس سايت، وبندخل عادة بالسيستم العادي اللي هو المولين سيستم or whatever other system عشان نعمل الترانسبتال puncture. الترانسبتال puncture زي ما الدكتور رضا قال it is a bit different عن الاوردينري، لان احنا بنبقى عايزين نبقى بوزيشن بطريقه اريح لينا بحيث لما نيجي نحط الديفايس يدخل باسهل من لو احنا عاملينه هاير اب. فعاده بندخل حسب ما الدكتور رضا inferior posterior وده بيخلينا فعلا very near and aligned towards the left atrial appendage.
بس قبل الدكتور رضا ما يتكلم عشان دي حته مهمه، السايز او الشيب بتاع الابندج هل انت بتجيبه بالايكو بس ولا سي تي قبليها؟ ده سؤال. السؤال الثاني ايه الويندو اللي ما تسمحش انك تركب فيها ليفت اتريال ابندج؟ يعني قد ايه؟ انت قلت ده 22 ف 20%، هل في حاجه ما ينفعش فيها تركب؟
Yeah. Thank you, Dr. Sobhi. This, if I look carefully to how we do study of the patient, CT is a very nice complementary tool, but in this aged population, usually chronic renal disease and the difficulty to get an access to the CT usually is a problem. But it is a very, very useful tool to give you the full study of the appendage, size, shape, type, relation to left upper pulmonary vein. But here with our elite echocardiographers, they give us a very nice image. If we have the image of the fluoro in front, we can see that the areocaudal view, the first one, this view, if we see, we can appreciate that the areocaudal is the outlet of the appendage, which we can see here, the termination of the appendage, it looks at the cactus or the cauliflower, it's very clear. Yeah. And here we can see it has a big ostium. Next one, which is the areocranial, is the one we can measure the inflow of the appendage. Here we can see the comedine ridge is upper at 11 o'clock, and then we can see the longitudinal axis with very nice position of the big tail inside the main lobe. If we look carefully to the echo, when we started to do the transeptal, if you see the echo, this is the short axis, and we can see the tinting of the needle and its relation to the aortic root. This is very important. This is what we call the posterior anterior relation. We should have it as posterior as much as I can, and it should be 2.5 centimeter away from the aortic root at the best site of the stick. It is little bit different than the mitral clip or paravalvular leak, but it's for this one, it looks fine. This is the anteroposterior. If we look carefully to the bicaval view, the next view we can see on the left side of the screen, here we can see that the only stick we could get it for this patient is little bit higher than we need, but we accepted it and we said that we will manipulate it. And after we had this stick, the septum for this lady was very difficult to cross. So we had to use the mitral valve 14 French dilator to dilate the septum and then to put the sheath. The sheath dedicated for the left atrial appendage closure for this 27 is 14 French, and this sheath has a characteristic shape. It's a double curve because the appendage is an anterior orientation. So this curve, it gives us this sheath, it gives us the curve to come inside the appendage, and the other curve, when we do a counterclock, it oriented the sheath in the upper what we call it the anterior and upper direction of the appendage. Here we can see the sheath inside the appendage, and here we can see there is some marker on this sheath. The tip, we have the tip of the sheath marker, and then we have 3 consecutive markers. Each one of these 3, it gives us the depth of the appendage and the depth of the sheath I need to put it. Say, for example, if we can name it from the most proximal, we call it 33. The next one is 27, and the third one is 21. So for a 27 millimeter device that we elected to use it, the middle marker of these 3 markers is exactly in position just distal to the comedine ridge, or this ridge we see in the fluoroscopy. It means that when you deploy the device in this position, this will be the proximal part of the device when you put it inside. So
وأسامة حاطط موري صور برضو جميلة.
Yeah, we can see from the echo how the sheath and the dilator is seen. Little bit if I elect to change the position, I would like to go 1 centimeter just below to this one. And then next view, please. The next one. Here we can see the deployment to Dr. Hisham. Dr. Hisham, he did it very, very nicely, that he started deploying the device by fixing the main mandrel of the device. And this is the distal anchor of the Watchman device. And then very slowly, very carefully, he started to deploy bit by bit the device till it is popped out in a very nice shape with a very good orientation to the
أرجو إنكم تكونوا شايفين الشاشة يا دكتور صبحي.
When we look carefully from the echo view, this is a little bit an unusual appendage, but the device, if we can see the slowly deployment next here, Osama, of the appendage.
Before the point of no return, يعني مش ده step now. يعني
yes,
بتعمل deployment وبعدين بتعمل انجيوجرام وتشوفها بال 3D عشان تبقى sure ان انت
Definitely. Usually we count on the echo. We have an elite echocardiographer actually, and if you see the echo images, you can see the appendage. It is occluding exactly the ostium of the appendage itself with no any residual flow you can see inside the appendage. What we usually do here is to have some angiogram, as you said, that to make sure that we are in a good position. Okay, give me some contrast. Contrast. Sini.
Sini, عايز.
Yeah. You see, here we are exactly closing the whole silhouette of the appendage in a very nice position, and this device is nicely impacted and it takes the shape. Dr. Osama, when he measured the transverse diameter, which is very essential step here, is to make sure that we have adequate compression of the device, at least a 3 millimeter reduction in the transverse diameter of the device. In this view, I'm happy with the position, and with this angiogram, we can see that the appendage already is excluded completely.
كان زمان وما زال طبعا السي تي is quite important لأنه بيدينا 3D reconstruction، بس في نفس الوقت احنا الترانس esophageal echo can be giving us يمكن as good as if not even better 3D images. وبالتالي السي تي برضه carries some risk regarding the use of contrast. فهنا مش it's not very mandatory in most of the cases that you go for a CT prior.
دلوقتي بقى
احنا عاملين دلوقتي في
images في الاوضه القسطره يعني سي تي
احنا عم مستخدمين في صور دلوقتي هتطلع لحضراتكم 3D images by TEE.
العيانه اندر جنرال انستيزيا.
العيانه ده يمكن اللي اخرنا شويه ان احنا كنا عايزين التخدير يجي ومعانا دكتوره نهله. دكتوره نهله الحقيقه ساعدتنا جدا في الحاله لان البيشنت was quite irritable so she's under GA وبرضه ده مساعدنا ان احنا all through the way ان احنا وايه صوت الموبايل ده؟ ده مساعدنا ان احنا all through the way ان احنا حاطين transesophageal probe without the patient being irritated because she is under GA. يعني احنا يعني مش عايزين نطول على حضراتكم عشان النهارده
عايز اسال الدكتور رضا ابو العطا التي ده مانداتوري خلاص ما اقدرش اعملها الا من خلال الترانسوسوفيجيال ايكو.
The transesophageal echo is the best available tool we have, but now because we have the 3D intracardiac echo, ICE is another alternative. It is very efficiently, we can do the transeptal and appendage closure with using this modality without going to the general anesthesia. Actually, it's far away more convenient to the patient, and it's only the operator who is doing everything. We don't count on the echocardiographer or on the general anesthesia. I think if you calculate it as cost-wise, the cost of anesthesia plus the cost of echocardiographer is the same cost of the ICE catheter, which is it can be a good alternative.
But definitely having TEE on board, while if not using ice, this is quite a helpful thing during the procedure. لأن إحنا عندنا أكتر من طريقة إن إحنا to confirm our position, سواء when we are puncturing the septum أو سواء when we are positioning the device. كل ده بيخلي حياتنا أسهل بكتير. We are having more than one technique to check that we are on the right track. And I think having TE on board was something extremely important in this case.
What about the pharmacotherapy during the procedure? Especially this patient went to hemoglobin down to 6 after anticoagulant. And what's the procedure?
Yeah, لا إحنا هنا what we did إن إحنا we went all through the procedure without giving any medication except بعد ما عملنا septal puncture we gave heparin.
Yeah. For Doctor, if you allow me, Dr.
Sure,
Hisham, based on the ASAP trial, which is a SAP trial, all patients, if I have a reasonably okay left ventricular function, which is 45 above, post the procedure, we keep the patient on dual antiplatelet without giving any anticoagulation at all. Specifically, if I don't have any leak, as we see inside the appendage. The appendage is completely sealed. We don't have any leakage. So this patient will be discharged on aspirin and Plavix for 3 months. And after the 3 months, we will keep her on a single antiplatelet, and that's it. No anticoagulation, NOAC, or warfarin at all.
Sorry, just a quick question in here. Number one, about the transeptal puncture. You mentioned 2.5 from the aortic root. What is the kind of range that you could accept? That's number one. Number two, what's the rationale for dual antiplatelet therapy, particularly in a woman like this? Because the the PCI option was discussed, and one of the reasons we kind of said, let's just wait and see, because she had all this stomach irritation, and aspirin probably will cause her more problem than the DUAC itself. So what's the rationale for dual antiplatelet therapy?
Okay, for the first question, when we are trying to engage the appendage, we need to make sure that when we are getting the puncture, we have a trajectory that the sheath, when coming from the IVC across the septum to the long axis of the appendage, you need to be away from the aorta. If we are nearby to the aorta or our stick is anterior, either we will have an aorta hugger that the aorta will not allow the device, the sheath, to be maintained on the long axis of the appendage, or we will have a pulmonary vein hugger that the sheath will be kept hitting toward the pulmonary vein without easy engagement of the appendage. According to the previous trials, I think using a single antiplatelet does not give you the full protection for this lady, which has already a high Chad's VASC that we had to give it. And actually, she is known to be a coronary patient, and she will have an additional PCI to recanalize her LAD. And we can see the RCA stents, very long stents. So she is already on dual antiplatelet, and I will not take the risk to keep her on single antiplatelet.
هو يمكن السؤال يا دكتور رضا هم they are asking طب ما احنا عايزين ان appendage to occlude.
Yes.
Okay. So maybe it takes some time to be fully occluded. فهم يعني هو السؤال, should we be giving all patients dual antiplatelets for 3 months? And what about if the patient is a real high risk as this one and will not probably be tolerating giving dual antiplatelets?
This is an important point. If you go back to the Protect AF trial or whatever the initial trials for the Watchman to be used as a mechanical plugging alternative to the pharmacotherapy, what was the standard at that time? The patient will have the Watchman device and then will be kept on oral anticoagulation for next 6 weeks. And after 6 weeks, another new transesophageal echo will be done to make sure that there is no leakage through this appendage and that there is no thrombi. And actually in this study, it was almost 26% of the patient, they have either thrombi, it was a subclinical one without any clinical transformation into any peripheral embolization. or there is a significant leak around, which was 5 to 8% of this leakage was significant leak. So this is why they had to use the transesophageal echo in 6 weeks before stopping the medication. But when the ASAP trial came, it gave us a more sense of security that we can go to a less invasive pharmacotherapy, which is the dual antiplatelet, to make sure that we have a reasonable protection. The endothelialization of this device, it takes around 6 weeks, so it's 1.5 months, and for safety, it's almost 3 months to make sure that the appendage is completely excluded, and this nitinol frame had been covered already with an endothelial tissue, so it will minimize the risk for any what we call it thrombus formation across the device or inside the left atrial cavity.
We'd like to thank you علشان احنا طبعا for the sake of time عشان to start the other cases واحنا بنشكر حضراتكم بنشكر طبعا
دكتور هشام.
نعم
انا عايز اقول لحضرتك ان الصور هايله جدا واحنا شايفين ان الصوت ممتاز جدا والبرزنتيشن بتاع الحاله سوبر واحنا بس عايزين حضرتك تقول لنا بقيه اللايف بتاع اليوم هيمشي ازاي قبل ما تقفل.
احنا عندنا النهارده في 4 structural cases. ال4 structural cases دولت خليك معايا يا دكتور.
ريليز سكرين بس هنا نكمل.
اوكي شايفين يا جماعه واحنا بنعمل ريليز؟
شايفين ايديك بس. ايوه كده صح تمام.
شايفين الريليز؟ اوكي كده احنا خلاص we detached from the Watchman device. وبقيه الحالات النهارده احنا second coming case will be a septal ablation for a hypertrophic cardiomyopathy case. وبعد كده هنعمل endomyocardial biopsy وبعدين هنعمل حالتين واحده منهم with severe calcification and the use of rotablator وواحده منهم تانية CTO وهيكون عندنا حاله كمان بالون mitral just a step-by-step approach to teach our younger generations how to do balloon mitral. عندنا طبعا another list of cases but probably will not be doing them live. احنا هنحاول نعمل بعضهم في الدور اللي تحتينا في القسطره وهيبقى بس معاهم كاميرا مان ويمكن نبقى نعرضهم لايف in a box if we have time. انا مش عايز اعطل حضراتكم واحنا بنشكر حضراتكم جدا.
If you give me 1 minute and this is for our next generation, I hope that they will pray for me. This is when we have this above 10 French sheaths up to 30 French sheaths for valve replacement or for the mitral clip is how to close the vein in the figure of 8. This is very important, very convenient. If you can see, do you see my hand or you can?
عايزين الكاميرا على ايدك.
كاميرا
لا من الناحيه الثانيه. من الناحيه الثانيه مش هيشوفها من هنا. كاميرا من الناحيه الثانيه.
هو دكتور رضا عايز يوري حضراتكم ازاي بيقفل
الفوطه واللي من بعيد.
باي فيجر اوف 8.
مش هيعرف يجيبها. طيب يعني ورينا كده.
اوكي.
انتوا شايفين كده يا جماعه؟
لا لازم الكاميرا اللي قدامك دي
عايزين الكاميرا فين عايزين الكاميرا تنزل على البانكتشر سايت
بالظبط كده.
Here I need to see
يا ابني من فوق ماشي.
Here.
طب ممكن تشرحها theoretical قبل حضرتك ما تقول.
Okay, if we can see the puncture, all what I need is to get the connective tissue and the skin to be the compressive material instead of the manual compression done by one of our colleagues. So we go 1.5 centimeter medial, distal, and take it 1.5 centimeter proximal medial. So it's parallel one suture from distal to proximal in the medial side. Then I will go lateral to the sheath, the same from distal to proximal, and this one will take a bite without getting any bite to the artery itself. It's completely away, or to have any bite to the sheath in the vein, or to have any bite to the vein itself. So distal to proximal medial, then distal to proximal lateral. When we take this suture and we look carefully to it, we have here a figure of 8 that we can see. It's a figure of 8 when we have this suture tied. This one, it is efficiently.
This is for the vein, yeah, Dr. Rida.
Naam?
For the vein.
For the vein only.
Yeah, for the vein.
For the vein. So patient with balloon valvuloplasty, patient with complex long multiple sheaths in the ABS or pulmonary vein implantation, pulmonary valve implantation or mitral clip, or what we call it leadless pacemaker. All this need more than 25 French sheaths. And this one will take very long time for compression. But for us, this is only this suture. You just tie it, and this will be enough to control the bleeding. Yeah, yeah.
Any experience with the Perclose devices?
Yeah,
yeah. In the vein.
Yeah, that's it's okay. I think we're doing this. This is a bad suture.
No problem.
That's fine.
So
we are used.
No, we're using Perclose device for mitral clip or mitral valvotomy, and for the vein it does work exactly the same.
Yeah, we use it. We use it even for the pulmonary valve and mitral clip. Only single piece will cover it very nicely and efficiently. But the figure of 8, I think there is more than one trial. It proved the efficiency of this figure of 8, similar to this ProGlide or ProStar. The same. It does not have any bleeding, and it is well controlled puncture site without the additional cost of this figure of 8. ProGlide, yeah.
تريد في important point في ال left atrial closure device اللي هي لازم تستيميت left atrial pressure.
Yeah.
So left atrial pressure is low. You are not allowed to implant. لازم تعمل hydration to the patient عشان ما يحصلش escape من المكان. ممكن تكومنت على your experience about this, what you are doing.
This is actually, it's an excellent point that usually when we have any patients coming for left atrial appendage closure, we have to ensure that the mean left atrial pressure is above 10. And here, when we measure it for this lady, it was 15, 20. above 18 20, even. And the other solution for this, when we inject with the power injector, this one will expand the appendage to the actual size. All what is our problem mainly is when we are undersizing the appendage to put a device which is already smaller for the actual diameter of the appendage. So we have to safety to hydrate the patient till we have a mean pressure of above 10, and to have the power injector for the angiography to see that we are
يعني ممكن نوريكم برضه يا دكتور صبحي، نوري حضراتكم TE 3D TE
طيب اوكي
picture بتاعه الاوكلودد اوريدي left atrial appendage. It seems very nice. Please لو تقدروا تنقلوا لنا على الايكو.
I'm asking for the question.
اتفضل يا دكتور صبحي لو عندك سؤال.
في امبلاتزر ديفايس دلوقتي غير الواتشمان ديفايس. بدات طبعا الاول زي ما حضرتك عارف ودافيد هولمز وكل الترايلز، وبعدين وقفت سنه لسم يعني ترايلز وقالوا ان هي مش questionable to be revisited وعملوا امبلاتزر ديفايس. انت رايك ايه الفرق بين الامبلاتزر في التكنيك؟ هل هي easier؟ لان طبعا انا بس عايزك انت اللي تتكلم في الموضوع ده.
Again, I like this question, Dr. Sobhi. Actually, it's an elite question. This the ACB or Amblatzer cardiac block, what the initial device made by Abbott or the Amblatzer. This is different in design. It is formed of two main pieces. One is similar to the Watchman device, which we call it the loop. And this loop will be plugged mechanically inside the appendage. And there is a disc which is connected with a small waist. And this disc is covering with a good retention from the loop, is covering the os completely. This device has been changed now to what we call Amulet. The two devices are similar, but the initial one has many problems. That the delivery sheath was extremely tough and long. It was 110 centimeter compared to an 80 or 65 centimeter length sheath, which was not convenient to do the case. And the new one has a bigger loop, more anchors, more what we call coverage disc for the os. My personal preference is for this Amblatzer type because it has two mechanisms to occlude the appendage, and I had never seen any leakage related to this device after the closure.
And finally, we'd like to thank حضراتكم جميعا. We'll please go back to the program. وإحنا we will start our second cases إن شاء الله. Thank you very much.
Thank you very much. An excellent case and looking for the next session. Congratulations.
Mohanad, I want you to comment on the practical and scientific aspects of the Watchman or atrial closure devices from the point of view of you as interventional cardiologist, and how common is this in the practice, in your practice?
How common is a very good question. I mean, I think there's clinical indication, which is a case like this, with people who have high risk and they are high risk for bleeding, obviously, and their anticoagulation could cause them a long-term problem. So these are the indicated one. In the UK, we have a funny system. So when this first came out, because it's expensive, despite being an advanced country, it has to have the NICE approval. It has to have a randomized trial. And despite this, it wasn't approved immediately. So there was something called commissioning by evaluation. So before they started rolling it out to everywhere, they chose a few centers. One of our center was one of them, luckily, to perform this and do a cost analysis as well as a long-term outcome. And after 4 years, now it's approved. And so we are doing it regularly when it's clinically indicated. And I think it has a very important part in playing in preventing a thromboembolic event in people who cannot take anticoagulation. This was something that about this woman, because she was discussed yesterday, and I was worried about giving her dual antiplatelet therapy, to be honest, having seen or having heard her the gastric endoscopy result. Because now she gets aspirin, and that's the main reason you bleed most of the time. So now she's having 3 months of dual antiplatelet therapy. Maybe she could have had also her coronaries. So then you save her having the second dose of dual antiplatelet therapy. But to go back to the question about how important, I think it's very important, it's very helpful, and it does save people from having bleeding if it is in the right, it shows in the right patient. And it is not, as you saw, I mean, it's a very elegant and simple procedure. A lot of us have got a good experience with transseptal puncture. Now that we do mitral valvotomy, we do ASD BFO closure, we do mitral clip. It's only about the limiting step for me for all these procedures where you do receptal puncture. You do it in the right place, your procedure is just really good. And the second important part is recognizing the different shapes of the appendage, because there are 4 or 5 different shapes, and you have to choose your device correctly. Almost like when you're choosing the stent, if you undersize or if you choose the wrong one, you might not get the result that you require or you desire.
Excellent. Thank you very much.
How does the shape influence? That was the question I really wanted to ask. How does the shape of the left atrial appendage influence your choice of the device?
I mean, it's only for the size.
This, then you choose this, and is it just the size, or is there other aspects?
It's mostly the size, to be honest, and how it's shaped, because the most important part is the entrance, or where the device is going to be hooked so it doesn't move. But the different shapes is almost academic to a certain degree. It doesn't make too much difference. It's the sizing. You get your size right, and everything is fine.
That's the most important thing, the orifice area rather than the shape.
Yeah, the shape, I mean, is just academic because it's nice to know it. But sometimes there has been some report, despite the closing the ostium, and if the appendage itself is still large, especially the cauliflower one, if there's still areas where, at least at the beginning, there's still some flow into the appendage, you can have some thrombosis. This is maybe where the dual antiplatelet therapy, or originally you continue with anticoagulation for 6 weeks. So this is the only side difference, but it's the opening. Yeah. Yes.
ده هو الاول كان قبل الواتشمان موديفيكيشن كان الشيب مهم. بعد كده اهم حاجه الاورفيس مش 20 ما فيش واحده اكبر منه. دي نمبر 1. السؤال اللي بتقول عليه هو قبل النواك كان هي كامينج اب، وبعدين لما جت النواك فقللت عدد استخدامه. ولكن الناس اللي بيجي لهم بليدنج حتى عن وك هم دول انديكيت، عشان هي ده كلاس 2 بي، بس لازم تبقى موجوده. الفرق بين الاثنين اللي هي واتشمان ولها ترايلز كتير قوي، ام بلازر وضحت دلوقتي موجوده. فعندك اثنين مفيش فروق بينهم، انت حسب ما تتمرن على حاجه منهم. الحاجه الثانيه ان لازم يكون عندك اجود ايكو. من غير الايكو كويس مش هتعرف تعمل الحاله دي خالص، لان هو بيقول لك انت صح، انت مسافه قريبه، مش ممكن انجيوجرام. هي فيري تكنيكالي ما لهاش مشكله، هي بيك تيل انجو، تحط المالز وبعدين بتدخلها والدوتس السته على نصهم بالظبط وبتعمل درو، مفيش اي مشكله خالص. مشكلتك الايكو. لو ما عندكش واحد كويس بتاع ايكو، هي مش لازم 3 دي، مش لازم، بس الاحسن لو 3 دي، يبقى انت بالنسبه لك اسهل واسهل.
There are some cases now, some centers are doing it just angiographically without echo. You get the evaluation before.
دي بالامبلاتزر مش بالواتشمان.
We're not with the watchman, yes, but some people are doing it now. There are some studies ongoing just
ممكن اعمل 100 حاله
angiographic.
اعمل 100 حاله
angiographically without any TOE.
I don't advise to make it.
No, you do the TOE before you get early evaluation. Then the procedure is done under angiographic guidance.
Okay. Thank you very much, Dr. Abdul Ghani. بقى مين السيشن؟
Now it's time to go to STEMI session. Can I call for Professors هشام يحيى, طارق عبد الغفار, محمد عرابي.
I have the pleasure to co-chair this session. This is actually very important and intriguing session about tough scenarios in STEMI management. The first speaker will be Professor Ahmed Magdi, who will tackle the issue of STEMI and multivessel disease.
صباح الخير. I thank my professors and my colleagues and friends, Professor Jalal Saeed, Professor Hussam Andil, Professor Muhammad Abdul Ghani, and Professor Hisham Salah, and wish them luck for this ongoing very important scientific activity. أنا هتكلم عن ال multi-vessel intervention في ال acute infarction. هيثم هي مش بتمشي ليه؟ شغالة هنا؟ كده اقف هنا. طيب, this is a patient we have seen last week. He presented with acute coronary syndrome, anterior infarction, with some changes also in inferior leads, and it was hard to tell whether this very bad circumflex lesions that is also subtotally occluded with a thrombus that is not involved as culprit in this process. This and so we did both the LAD and the circumflex. This is another patient with anterior infarction, totally occluded LAD with a thrombus. And in the same time, this lady had also total occlusion by thrombus and lesion in the RCA. And so, as in literature, at least 25% to 30% of the patients presenting with acute coronary syndrome, they have more than one culprit. But on the other hand, also, patients who are presenting with acute thrombotic occlusion in one of the coronary arteries, there is multi-vessel involvement of the coronaries. This is another patient, 55 years old, presenting with STEMI, left and right band branch block. And in the same time, he had also very tight lesions in the circumflex, and so whether to do the culprit or culprit plus. The incidence of multivessel disease with STEMI in literature is high, almost 50%, especially in countries like Egypt, where the ischemic heart disease is very prevalent. And the impact of multivessel disease, the more the vessels involved, the more is incidence of shock and deterioration and worse outcome. So the questions, what to do with the non-culprit lesions if they are not the culprit by themselves also, and if treated, when to do, and what to do in cardiogenic shock. So in Regis's, there is some comparison between culprit only or culprit plus or multivessel PCI. Now the answer is towards the culprit better than multivessel intervention, but this is a general question, general answer. So the culprit compared to stagey PCI is better than the culprit, and then multivessel disease or stagey PCI, still the staged PCI, which we call the intermediate approach, is better. So this is the rationale why to do aggressive multivessel intervention initially, or to do conservative on the other side, only the culprit, and intermediate to do staged procedure. Why to do the aggressive? What is the rationale for that? Is complete revasc, no residual ischemia, no additional PCI, cost effective, but more contrast. The patient is unstable, overestimation of the lesions, and potential unneeded, maybe the lesions are not in need of PCI. While the intermediate, still complete revascularization, no residual ischemia, but you give some time for recovery and for better assessment of the lesions. Conservative, on the other hand, is properly indicated vascularization and stable condition, and but still there is residual ischemia and more cost for that. So what is the meta-analysis are telling us? Complete revascularization as an important note is important. What is the difference between CABG and between PCI in most of the studies? That if you allow complete revascularization, even the ischemia study, even in the freedom study, comparing the CABG and intervention, but when you do complete revascularization, they are comparable. So the issue is to do complete revascularization. Don't do just one artery and leave the others. In this study, on the non-culprit lesions, the plaque morphology seen by OCT in patients with STEMI. This is from the complete trial, optical coherence OCT sub-study. Obstructive non-culprit lesions are most likely to be vulnerable. They assessed by OCT. So 50% of the patients, they had obstructive non-culprit lesions containing vulnerable plaques. And so as in the two cases that I have shown, they are very clear vulnerable plaques there. However, even in the in less severe cases, still there is vulnerable plaques because acute coronary syndrome is inflammatory process. In the large landmark studies comparing aggressive, intermediate, and conservative, we remember the PRAMI and the culprit, comparing aggressive, doing all the vessels in the same setting, or doing conservative. These were in the past, maybe 5 or 6 years before. In the PRAMI, they call doing the multivessel intervention, they call it the preventive PCI, and the preventive PCI was better than the just culprit intervention cohort in the outcome. Also, the culprit was showing that complete revascularization is better than just doing the culprits. Then comparing the intermediate and the conservative, the NAMI 6 and the NAMI 5 and the Primolot, still the intermediates doing stagey PCI is better than the conservative, as we know. Compare acute, they did something else. They depended on the physiology of the non-carpet vessels. If there's ischemia below 0.8 FFR, then they do the intervention. If there is no ischemia, they leave it. And the conclusion was in multivessel STEMI, FFR guided complete revascularization of the non-infarct related lesions in the acute phase of primary PCI, significantly reduced the risk of the composite outcome compared to the strategy of just doing the infarct artery. And this reduction was mainly driven by decreased need for subsequent revascularization. You remember the syntax score, depending on the anatomy and the pathology of the lesions. When they involved the FFR, the functional syntax score, they even changed vessels from our patients from 3-vessel disease to 2-vessel disease because some of the regions that are apparently significant, but doing the physiology showed they are not significant. So if treated, what is optimal time? I think I answered that in one of the studies, that you better do it while the patient is hospitalized, except if you don't know which one is the culprit, then you are allowed to do during the intervention procedure. But most important to remember that complete revascularization is very essential to keep good outcome in the future. In this particular study, comparing staged immediate or staged PCI, the staged PCI was better. However, both, I mean, comparing here the culprit only, immediate intervention or staged wins, followed by complete revascularization, followed by the culprit artery intervention. So the guidelines prohibit doing all the vessels in patients with cardiac shock. Still, the STEMI guidelines did not change since 2017, that you are allowed to do the non-carpet vessels, and this was not clear when to do. However, subsequent explanation was showing that it's better to do it while the patient is in the hospital. This is special group of patients with sudden cardiac death and showing the difference between culprit only or multivessel intervention. Still, multivessel intervention in this particular group was essential. They didn't specify only the culprits. What happens with cardiac shock? First, you have to define what is shock. Not every patient with hypotension is shocked, but you depend on certain criteria, the urine output, the cardiac output, all these things. The classic teaching before 4 years ago that we should do all the available, all the coronaries with tight lesions if the patient is still in shock. However, after the culprit shock study that had shown worse outcome when they do all the vessels because of the increased mortality depending on renal replacement therapy. And so it was completely contraindicated to do intervention in the non-carpet vessels in shock patients. And this is the algorithm. And remember that in shock patients, reperfusion is one of them. However, you need medical therapy, inotropic support, teamwork. Some patients are due to mechanical complications. And so still in shock and acute heart failure, you are obliged to do only the culprit vessels. So back to our patient. We did the left main and circumflex, and then we came back to do the LAD before hospital discharge in these patients. So finally, when to do multivessel intervention in STEMI, when the culprits, this is from practical points of view, when the culprit vessels had been treated successfully, and the non-culprit vessel has a very proximal or have a proximal significant lesion with a lot of myocardium that is jeopardized. And if you can verify significance of this non-culprit vessel, preferably with FFR physiologic testing, and when the features of this lesion predict a good PCI results and a small amount of contrast in a short time, then you may consider multivessel intervention in STEMI, particularly if the large complete trial is concordant with that. So in summary, the randomized controlled trials and registries, they show improved outcome of complete revascularization, which should be our aim. When complete revascularization of the non-infarct lesions should be done acutely or staged remains unclear, but early revascularization during the index hospitalization, maybe within a week, seems to be reasonable. Whether revascularization should be guided by FFR or just angiography, the FFR is, it seems to be more logic and justified. immediate or early stage complete revascularization should depend on good clinical judgments and expertise of the operator. In shock patients, do only the culprit vessels, and it is more safe. Thank you very much. And this is our meeting at the end of this month from Batimahai in the same place here.
Shukran, Dr. Ahmed, for this comprehensive coverage of the topic over a short time. I think we have time for 2 short questions. We'll start here from the panel.
Dr. Ahmed, thank you very much for your nice talk. I have a reservation on the use of FFR in the guidance of for the non-culprit, because there is a new trial called the Flower trial, and it showed that it is not useful to use the FFR in doing the non-culprit lesions. It had no value, Flower trial. And it is published in the New England Journal of Medicine last year. The other thing that the presence of 2 culprits, we sometimes, there is, if you see 2 culprits, of course, you have to do the second culprit. But if you, by imaging, see that this is a vulnerable plaque, I don't think it is, as you said, it is an inflammatory process. So it is, it can, the inflammation can go with the medications you are giving, like the statins and like the anti-thrombotic. And also we can give anti-inflammatory. The anti-inflammatory colchicine have been used in some cases, in some trials, and have been shown to have good outcome if there is a high inflammatory response in this patient.
Yeah, answering your questions, if you go by the, of course, the Flower study had been completed, but we have the acute study before. Most of the guidelines now, especially if you are doing bifurcation, left main or others, even the chronic, guidelines are something depending on the practice of our work and also on the large studies. So the chronic ischemic trials, the chronic syndromes, that was the last guidelines released 2 years ago. They specify very important doing FFR. If you remember, if you do invasive study for the patients, and if it's 90%, you will open the artery. If not 90%, they specify with 10 lines below it FFR to justify that this is a physiologically indicated lesion. The other side, I don't believe very much that if you see 2 arteries and you open the artery and the other vessel, you say, I will give for him statin. What statin will do for established lesion, significant and physiologically indicated, this may be a needle for infarction. So I don't believe in, I believe in complete revascularization. And when Mangalore from New York compared the Freedom study, revised that with complete revascularization, he found the same cabbage compared to intervention.
Oh, I didn't mean that you defer a significant lesion.
But of course, medical therapy is important. I mean, medical therapy is the default, of course.
شكرا يا أحمد. يعني the guidelines are very good for education, but for the patient, we have to use our experience and the circumstances of the patient and the circumstances of the country. You know, the guidelines change every day. And I cannot, and at all my experience, when I do a primary, if it goes smooth, whether the patient is shocked or not, I do the rest. You know, the Egyptian patient cannot tolerate FFR. The Egyptian patient, to bring him another time to do another vessel, you know, I never understood this. And so I use my own guidelines with the patient according to circumstances. And you said we do FFR, and now no one does FFR in the world. And the guidelines change. It's good. I'm not against guidelines. It's good for education and orientation. But the patient is different. Every patient is different from the other.
هو دكتور جلال حضرتك ادي للاسف هي مش محطوطه هنا تاني. الاف اف ار از ون اوف ذيم. احنا بس بنقول كيف يفكر العالم، هم بيقولوا كده. احنا ما عندناش، احنا مش بنعمل اف اف ار ولا حتى في الحالات العاديه الا فيري رير. لكن انا قايل الحاجات زي ما حضرتك بتقول كده، ان احنا طبعا ان اكسبيرتيز اكسبرتانز لايك يورز غير واحد شاب صغير. واحد شاب صغير بيعمل يعمل كالبريت وخلاص. واحد بقى زي حضرتك زي محمد الغني زي انا غالبا هعمل ممكن الاذر فيسلز. هو الاف اف ار از ون اوف ذا 5 or 6 كرايتيريا، بس هم لما نختلف وهي موجوده هيبقى كويس. ما قلتش ان هو لازم نعملها في مصر واحنا اصلا مش بنعملها الا فيري رير. انا اوافق حضرتك طبعا يعني.
دكتور احمد مجدي، اديني فرصه بس اهنيك على المحاضره، وكمان كونجراتيوليشنز على عضويه مجلس اداره جمعيه القلب المصريه، واتمنى لك كل التوفيق. مؤتمر الكارديو مؤتمر بتاعك الجميل لكومبات ام اي في نهايه الشهر ده. انا عايز استفيد من وجود دكتور مهند اجرد جنبي. دكتور مهند، عايز اسالك على الديلي براكتس in Newcastle. In the setting of STEMI, you did fix the culprit lesion, but you have other arteries with moderate and severe lesions. What would your policy in this situation?
Thank you. First, Ahmed, very good talk. Thank you. It's very comprehensive. I think it's one of the most difficult and undecided area up till now, because multiple studies have shown you multiple different things. And to my mind, just to echo what Dr. has been mentioned recently, I said it yesterday, I say it again. Guidelines are there to protect the patient from young and inexperienced operator. Experienced operator are there to protect the patient from guidelines. Guidelines are changing every day. Every study comes out, give you something different. To go back to our practice, multiple operators do multiple things. There are multiple factors that we take into account according to the patient. For instance, myself, and a word of caution before we go into any of this, when you're doing a primary angioplasty, the images you see or the lesion you see on the angiogram sometimes are overestimated because the patient is in a really severe state, adrenaline is on, vasoconstriction. And we have many, many examples where I think this is really a really severe lesion. You left them and bring them back about 6-8 weeks later, and the lesion is completely different. So you really have to be very careful how you assess your lesions. And the FFR, I don't think it's really valid in acute MI. It's a completely different, and I think I echo that. We don't use FFR very often. In the same token, a couple of my colleagues, they love FFR. Even in acute MI, if they see a lesion, they use the FFR and use it as a guide. So it's still up till now, it's an individualized approach. According to the patient, whether if they're an elderly patient, there's a severe proximal lesion, you have to take into account the myocardium at jeopardy and also the simplicity of the lesion. If there's a calcified lesion after I've opened the infarct-related artery and there's a calcified proximal circumflex tortuous, there's no point of doing it. You could always bring the patient because, again, you've heard me say that yesterday and today, there's always tomorrow. But sometimes if an elderly patient, a difficult access, or they live far away, or they don't want to wait, then you could do it if everything has gone okay. Because if you have an area that's already infarcted and compromised, you start doing another area, you cause a problem, then you're kind of double jeopardy to the patient. I think up till now, and we took part in the complete trial, and there's another trial going on right now to assess the same thing. Do you do it immediately? Do you do it within the hospital admission? Do you bring them back in 6 weeks? And I think we're still gonna, after these trials come out, we're still not gonna have a complete answer. It's gonna be an individualized approach and experience, and also what you do with the cases will be different.
خليني من غير ما اخد وقت اقولكم بس هقول السبيسيفايد ده عشان الدكتور جلال يبقى انا حاولت الخص الايجيبشنايزد فيو ان هي when the culprit vessel was done successfully. نمره 1. 2 non culprit حاجه بروكسيمال وسيجنيفيكانت وبيغذي جزء كبير من الميوكارديوم. 3 الاف اف ار لو انت عندك. 4 لو you can do this in a contrast amount قليله وفي وقت قليل. والخامسه ان انت لازم تكونسيدر الكومبليت ريفاسكولايزيشن. 6 بقى ان احنا لو طبعا انت ممكن العيان مش احنا في القلب ممكن العيان هيخرج مش هنشوفه تاني، فيستحسن وهو في المستشفى لو فيها ريسك. انا دايما بقى اقول للشباب الصغيرين عندك بقى ليفت مين بايفركيشن بس الثانيه بليز دونت دو واستنى ثاني يوم يكون حد معاك اكسبرت يعمل.
هو بعتقد دكتور احمد طبعا حضرتك استاذنا هو which the lesion او الارتري which patient يعني لو انا عندي inferior STEMI
وعندي كريتيكال LED ليجن، انا لازم افتح كريتيكال LED ليجن. دي
اللي انا اعرفه
اكسبيرينس. انما دي لازم. وبعدين لو البيشنت في شوك وهيمودايناميكلي كومبرومايز وكونجستد وعندي LED هو الكريتيكال هيت اند ران، هفتح LED وبس. شكرا. دكتور محمد بيه صبحي.
Yes, I think in this respect there is a third point that we should raise. We are working about the patient. We are working about the patient and whether total revascularization or calcification only. I think there are certain points should be considered. Periprocedural cardiac enzymes. We should do the enzymes. If we find that there is periprocedural rise in enzymes, I should revert to staged revascularization because the stage is bad prognosis. If the enzymes are not rising, this will be somewhat a green light to continue.
ما ستيمي دي دكتور احمد بيه، الموضوع اسهل من كده شويه بس معلش مش هنقول جايد لاينز وحشه و60 كلب، لا جايد لاين حلوه وده القانون اللي هتحاسب عليه قدام المحكمه. معلش لو انت في مشكله عندك لازم الجايد لاينز، لازم يكون في كتاب. زمان كان في كلمه اسمها بيرسوناليز ميديسن، ده موضوع تاني. يعني ايه؟ الحاله الجايد لاين بتقول الاتي: ستيمي تعمل الكلب. الثانيه عندك طريقين: اندكس. يعني ايه اندكس؟ يعني في المستشفى محدش قالك تروح العيان، تاني يوم ثالث يوم تعمله. لو عندك التوتال ترايل بتقول لغايه 21 28 يوم خلصنا، مش هنفتي في اي حاجه تاني. الشوك ما تعملش غير الكالبت وتعمل الباقي بعدين. ليه كالبت شوك 30 يوم وسنه؟ قالت لك ما ينفعش، ده غير كلام زمان كان لازم تعمل المالتي. في كلمه ثانيه اسمها ريزيدوال سنتكس. يعني انت لو عندك حاجه ولقيت ريزيدوال سنتكس اكتر من 8 ده لازم تعمله في المستشفى. اقل من 8 من غير اصلا ما تعمل FFR ممكن ده كان بي ديليد according to what's known as ischemia او فريدم او اللي هو بعد السنه. سمبليفاي موضوع بقى اللي انت بتقوله. لو انا خدت ربع ساعه والصبغه قليله وحاجه سهله، دي بيرسوناليزد زي الدكتور طارق ما بيقول، يعني مش هتاخد، دي مش جايد لاينز. بس انت هم بتوع الPCR كانوا ودوجلاس بتاع دانجس كانوا بيقولوا TCT وPCR في فتره قبل التوتال، ان انت لو عندك اللي انت بتقوله ده، لو انت عندك وقت صغير والعيان صغير وكريتيكال رايت او كريتيكال ليد وداي قليله، جو اهيد واعمله. دي بيرسوناليزد. فمش يا جماعه ما ينفعش ناخدها قاعده عشان ما يبقاش ده الترند. ما هو فلان قال في المؤتمر. ارجوكم لان احنا حتى ايفن انت عندك الستاند فور لايف اللي عندنا في مصر عاملينها على 1 فيسل مش على 2 فيسلز. تاني، العيان الفقير اللي الدوله بتعمله واللي تبعته لك مؤسسات الجامعيه، مش من حق حضرتك تعمل اذر فيسلز. مش من حق حضرتك تعمل 1 فيسل محسوب عليك ريمبرست على 1 فيسل، وده القانون اللي عاملاه ستاند فور لايف وستاند سيف لايف في كل. فمش عايزين بقى نقعد نقول ماشي. احنا اخر جايد لاين توتال بتقول، انا بقول لك عليه.
جديد. Thank you very much. Yeah, thank you very much. معلش يا ايمن لو بعد اذنك. Now we had took a long time for this.
Just a quick note, sorry, about the guidelines. Just a quick note. They take about 2 to 3 years before they come out. And we all know this, 2 to 3 years or sometimes more to come out. So the practice changes and other studies come out. So guidelines are there, important and really very, very important to be followed. But they're not set in stone. There's a patient, there isn't a disease.
كل مكان ليه برضه بروتوكول. احنا عندنا في مكان مثلا بنعمل عيان عشان يقدر يجيب تاني، جامعه اسكندريه يمكن هيقرروا عليه ويرجعوه كل واحد كل سنه.
طب can we call Dr. Samhi Mil for the second? Thank you very much.
Good
afternoon, Mr. Chairman. وبحب أشكر طبعا اسم القلب في القصر العيني لدعوتي للمشاركة في السيشن دي، ودكتور محمد عبد الغني، دكتور هشام صلاح، وكل أساتذتي اللي موجودين. الستيمي سيشن و my topic is about the STEMI with a high thrombus burden. Angiographically identifiable intracoronary thrombus can be detected in up to 90% of STEMI cases, and up to 50% fail to achieve complete microvascular reperfusion by blush grade or ST segment resolution criteria despite normalization of the epicardial flow. However, angiographic distal embolization and no reflow complicates a much smaller proportion of patients. The impact of a thrombus on coronary intervention includes that there is a need for targeted treatment for the thrombus, which increases the cost and may prolong the procedure. And there is some adverse effects on the lesion, the vessel, and the clinical outcome of the patient during and after intervention with a heavy thrombus burden, like increase in the infarct size, increase in heart failure burden, and increased mortality. There is also increased procedural-related risk of distal embolization and no reflow, acute thrombotic occlusion, periprocedural myocardial infarction, and need for emergency bypass surgery and death. And the presence of a big thrombus is a predictor of major adverse coronary events, early and late stent thrombosis, and in-hospital complications, as well as a risk of 6 months recurrent myocardial infarction and death. During the procedure, there are some complications due to the presence of a thrombus, like dislodgement of friable thrombotic material by balloon and the stent deployment, which is an issue of concern in heavy thrombus burden grade 3 to 5. Also, embolization may lead to distal arterial occlusion, side branch occlusion, and myocardial microvessel occlusion. So overall, distal embolization occurs in the range of 6 to 15% of standard PCI for all lesion types in acute coronary syndromes, and is associated with up to 7-fold increase in the rate of periprocedural MI. These are the TIMI thrombus grading. As we all know, that the grade 0, no thrombus, and starting from grade 3 to grade 5, it is a heavy thrombus burden. In the latest European guidelines for the STEMI, it's a class 3 to use routine thrombus aspiration in all patients according to the TEST and the TOTAL trials. But they stated that in cases of large residual thrombus burden, after opening the vessel with a guide wire or a balloon, thrombus aspiration may be considered. So this is a proposed algorithm to deal with a thrombus in a STEMI patient. After wire passages, we look to the thrombus grade. If it is a low-grade thrombus from 0 to 2, so go for direct stenting, whether using a balloon or not. If a high-grade thrombus, we will look for 2 things. The first is the presence of ischemia and the TIMI flow. If there is no ischemia and it's a TIMI 3 flow, consider giving glycoprotein 2B3A inhibitors for 48 hours and defer the angioplasty. If there is ischemia or a TIMI flow less than 3, so go for thrombus aspiration, then go for direct stenting. All through the procedure, we can put glycoprotein 2B3A, and it's very important to ensure adequate oral dual antiplatelet or IV cangrelor or glycoprotein 2B3A with adequate anticoagulation during the procedure. These are the glycoprotein 2B3A in use, and we all know that they have been found to be effective in dissolving angiographically proven thrombus and restoring TIMI flow. Dealing with thrombus, we need targeted thrombus strategy. In a low-grade thrombus 1 or 2, go for direct stenting, while in a significant grade 3 or heavy thrombotic burden grade 4 or 5, targeted thrombus strategy is warranted in such situations, especially when there is a pathologic or clinical features that demand this. These are the pathological features: the presence of atherosclerosis associated with a thrombus, a thrombotic embolus in a coronary artery or a saphenous vein graft, or the intracoronary thrombus accumulation secondary to hypercoagulable state. While clinically, we need to reduce the thrombus burden in clot-laden lesions if the thrombus is doing impairment to the forward flow and if there is thrombotic embolization or no reflow. The approach to mechanical thrombus removal, we have 4 main types according to their activation mode, whether it is manual thrombus catheters, power-sourced thrombectomy, ultrasound-induced sonication, or embolic protection device. The clinical benefit of thrombectomy appear to be influenced by the device type and with a trend towards survival benefit with manual aspiration catheters and worse outcomes with mechanical devices. So the thrombus aspiration catheter is indicated in the infarct-related vessel and is useful method for the rapid reduction in the thrombotic burden, prevention of thrombus embolization, preservation of the microvascular integrity, and reduction in the infarct size. Yet in the total trial, patients with STEMI who were undergoing primary PCI, routine manual thrombectomy as compared with PCI alone, showed no reduction in the risk of cardiovascular deaths, recurrent MI, cardiogenic shock within 180 days, but was associated with an increased rate of stroke within 30 days. Also, the thrombus aspiration catheters has some limitations that they may prolong the PCI duration. They depend on the operator technique and experience. They may not achieve complete thrombus removal. They can cause distal embolization due to device manipulation, and they do not completely eliminate no reflow. Also, they do not reduce the need for adjunctive stenting, and there is an increased cost with the use of these devices. Other power-sourced thrombectomy devices include the angiojet rheolytic thrombectomy, the Excider thrombectomy, and the excimer laser coronary atherectomy, which has the advantage of dealing with platelet inhibition of the platelet aggregation, what we call stunned platelet phenomena, and also the embolic protection devices, which are used more in the saphenous vein graft intervention. The stenting strategy in the presence of a high thrombus burden, whether it is a direct stenting in a small thrombus burden, or there is some thoughts to use covered stents, but at present there is no sufficient data for routine use of covered stents in this situation, or we use deferred stenting after getting rid of the thrombus with glycoprotein to be 3 or 48 hours. Here we have some cases to show how to deal with the thrombus. This is the first case, as we can see from the right side, the figure on the right side, that there is a small thrombus burden. So here we use direct stenting technique, and as we can see from the last figure that the direct stenting technique showed successful revascularization of this vessel. I don't know why it's very slow like this. هنا عندي بطيئة قوي مش عارف ليه الكمبيوتر هنا. طب This is another case. This is another case where we passed a wire in this ugly thrombus, but the wire doesn't restore the flow. So using an uninflated balloon passage here. This restored the flow. So we go for direct stenting after this with this final result after passing an uninflated balloon. The third case here, also another thrombus occluding the vessel, but here only passing an uninflated balloon does not restore the flow. So we use some balloon dilatation for a small balloon, 1.5 millimeter, and this restored the flow. And then we go for stenting of this part. And this is the final result of this third case. The fourth case here, we also can see this heavy thrombus burden, and passing a balloon does not restore the flow completely. And as we can appreciate, the heavy thrombus burden in the distal RCA before the bifurcation. So here we used an aspiration device, manual aspiration catheter, which restored the flow. And this is what we get from the aspiration device, this bifurcating clot for the bifurcation of the distal RCA, PDA, and posterolateral branch. And finally, we put a stent. And this was the final result of this. So we have these 4 examples of dealing with a thrombus in a STEMI patient. This paper was published in the JAMA 2019 by Dr. Hani Atiba. It's about the effect of low-dose intracoronary alteplase during primary percutaneous intervention on microvascular obstruction in patients with acute myocardial infarction. And sorry, I have 2 minutes only. طبعا مش باين. طب ماشي، هم 2 minutes ابتدوا بس الشاشة ما ظهرتش. Okay, they concluded that using this policy did not reduce the microvascular obstruction, and that the study findings do not support this treatment. Yet, last year in the Journal of Canadian Journal of Cardiology, this systemic review and meta-analysis was published about the safety and efficacy of intracoronary thrombolysis as adjunctive therapy to primary PCI in STEMI patients. And they included 6 trials, and the result of this meta-analysis that there is complete ST segment resolution was more common with intracoronary thrombolysis with a highly statistically significant p-value, and there was a strong trend favoring fewer in-hospital MACE with the IC thrombolysis when compared to IC placebo. And their conclusion was that given the limited studies to date, our meta-analysis suggests that the targeted intracoronary thrombolytic approach is safe and potentially effective to augment primary PCI. However, these findings deserve confirmation in a larger randomized controlled trial. And in an editorial comment on this meta-analysis, they suggested using upfront thrombolytic therapy in the management of patients with high thrombus burden and STEM. There are some ongoing trials in this issue. The adjunctive low-dose TPA in primary PCI, the STRIVE trial. The other trial is the OPTIMAL trial, and the third trial, which is the RESTORE MI trial. All they are discussing the same subject, using intracoronary thrombolysis in small doses in the STEMI. So to conclude that the largest thrombus burden in STEMI can further complicate primary PCI, each patient requires individualized approach. potent depth must be used and effective anticoagulation should be maintained. High thrombus burden may lead benefit from IV or intracoronary administration of glycoprotein 2B3 inhibitors. Direct stenting may be sufficient if the extent of thrombus is small. However, if there is a large thrombus burden, manual aspiration thrombectomy may be considered, waiting for randomized controlled trials on small dose intracoronary thrombolytics. Thank you.
For this elegant presentation. Actually, I have a question for you and for Dr. Mohanad. What is your experience, if you have any, with the use of intracoronary streptokinase? We know that the literature is full of data about alteplase, but what about streptokinase?
Yeah, actually, I used intracoronary streptokinase in a dose of 250 in a patient with a heavy thrombus burden. This thrombus burden was not, it's not a STEMI, it was an elective case. But after doing an IVUS, a big thrombus اتكونت جوه ال دي، وكل ما ننفخ في الثرومبس تروح نازله في السيركمفلكس. فضلنا كده والعيان طبعا كان في سيفير بين وشقد وكلام من ده، واستعملنا جلايكوبروتين 2B3 انتراكرونري، وبعدين في الاخر حقنا ستريبتوكاينيز انتراكرونري كانك غسلت الثرومبس. It was washed completely.
Your experience, Dr. Mohanad, do you have any experience with streptokinase intracoronary?
Very rarely nowadays, very rarely. But I mean, this is something you have to understand the pharmacology from streptokinase, TPA, alteplase. If you are going to use intracoronary, you should use streptokinase because of how it works and attached to the fibrin in the thrombus. And remember, with the acute MI, the thrombus composition is a little different, particularly in the acute phase. So if you are going to use something, probably this is a proof of this, but you have to give heparin for 6 to 8 hours because it triggers the thrombotic cascade if you don't do heparin on board. But if you are going to use intracoronary streptokinase, is probably the one. But it has been a long time since we've done it. If you are concerned, you aspirate and establish some flow. 2B3 inhibitor now is becoming the more norm. And in fact, actually, streptokinase, if you want to ask for it in our lab, probably they're going to have to go and look for it somewhere because we don't store it anymore.
Yeah, I agree. I think we're all, those of us who practiced intervention from the very beginning, when they first started, really, there was a term called strept and stretch. Because remember, in the beginning, there was streptokinase. And then we had the balloon. But still the standard was everybody, 100% of patients got the streptokinase. And then they would be taken to the cath lab and stretched with a balloon open. So it was called strept, then stretch. So this has been studied extensively a long time ago. And it never made a difference in multiple studies, even with the stents afterwards. Okay. Now, a long time ago, we also used urokinase. We used urokinase, lower dose, direct intracoronary, especially in vein grafts, because there was a lot of thrombus burden, or an acute MI with a large thrombus burden. We would give 100 units per hour for 4 to 6 hours, and you've never seen bleeding like you've seen with the urokinase intracoronary. Because there was no benefit, it stopped gradually. Now, what is coming back now is the use of double bolus, which has really been my practice for the last 8-10 years. Every single one of my patients gets a double bolus of 2B3A blocker. The problem with 2B3A blocker a long time ago, when they compared it with bivalirudin, was bleeding. But that's when you give the maintenance dose. But if you give just the bolus, you get the benefit without the risk of bleeding, especially since now many cases are done transradial. So whether you're doing it transradial or femoral, transfemoral, just the double bolus provides a lot of protection versus against extensive thrombus formation, and it makes the procedure much safer. You also, one last thing I want to say, we have to remember the concept of giving the patient loading of Plavix or Brilique does not work, even if crushed. Perhaps if you give it in the ambulance, but then the diagnosis and the treatment has started in the ambulance, and I don't know if you can really trust this. So when the patient comes to the hospital and you give him the Brilique.
What you are saying about the loading is not in the guidelines nowadays.
No. The data, okay, like Muhammad just said, the guidelines take time, but what we've learned is that the loading, you give the patient, they swallow it. There's a big difference between absorption of the pill in a stable patient versus absorption in an unstable patient.
Yes.
And where the absorption is very poor, and you finish your procedure and the pill is still in the stomach. They took pictures actually, so it does not work.
معلش احنا يعني خلينا سمبليفاي لاننا ناس صغيرين كتير وانتوا بتعملوا الميتنج ده عشان الناس. فاحنا دلوقتي 2022 مفيش حد بيقول ثرومبوليتيك ثيرابي اصلا بتبتدي. خلاص كده؟ يعني نمره واحد الا اذا عملت الاي سي جي في 10 دقائق والعيان عندك اكتر من 90 دقيقه تروح تعمل له ثرومبوليتيك ومش ستريبتوكاينيز اللي هو عندنا اللي هو جينيريك. فتنسوا موضوع الثرومبوليتيك خلاص كده عشان ما نقعدش ندوغ نفسنا. هم بيعملوا الار تي بي اي ده قصه ثانيه مش عندنا وغاليه وبيدوا له دوز وبيجرب. فلما يجرب ويلاقي نتيجته مش احنا زمان الجيل اللي جرب ستريبتوكاينيز فشل وانترا كروني انا جربته كتير فشل وكنا بنحقن في الجرافس زمان بنحطه اوفر نايت فشل. فكل الهيصه دي هتفشل. انت عندك خلاص عندك 2 بي 3 اي قائمه عندك اسبيريشن قائمه. المشكله انك لازم تعرف انه فريش ترومبس انك لو عين جالك نجلكتد وانت مش عارف بس انت بتعمل ايه فيرست ميديكال كونتاكت. مين فيرست ميديكال مين ده اللي هو شافه في اوضه في الطوارئ ولا شافه في بيتهم ممكن بقى له 3 ايام هو فيرست ميديكال يجي لك ثرومبس ما تعرفش ده ريت ثرومبس ولا ما تعرفش. احنا ما بتحلله لازم تعرف هو هيستجيب ولا لا. لو ما بتحللوش خلاص. احنا جربنا عملنا استادي على الكلام ده وعرفنا في اسكندريه فرق بين الاثنين. في الاسبريشن عملنا اسبريشن عيان بقاله كذا بيقولوا مش كذا فاكتشفنا ان الناس مش تستجيب اللي هو ديليت اللي هو اوريدي جالنا بس هو بقاله يومين وانا ما اعرفش ان هو الانفارشن اكورد بالاف ام سي. فاذا قدامنا عشان نسمبليفاي لازم العيان يعني تعرف الجريد ثرومبس. الالجوريزم اللي حضرتك عامله ده هو احسن واحد بتاع اللي كنت عامله الجوريزم وانك تشوف 0 تو 1 ودايركت ستنتنج ولا لا. الدكتور مهند بيتكلم على دايركت اللي هو 0 1 وانا قبل بدري الصبح. الثاني لازم تعمل اسبريشن لو بيك ثرومبس وان بتوين ممكن تعمل بري دايليتيشن تو فراجمنت اكوردنج تو ذا جايد لاينز. ان كل الترايلز بتاع الثرومبس الاخرانيه قالت ان مفيش فايده. التوتال قالت مفيش فايده. خلاص خلصنا عشان بس الناس بقى المشكله بتاعتك مين الناس اللي هم عندهم اكتاتيك لازم تديله تعمل اسبريشن وتعرف ازاي تعمل اسبريشن تعمله بروكسيمال تو ذا ثرومبس وتقعد تصبر عليه لغايه ما تتاكد ان الفوطه الخضراء بتاعته الثرومباي مش متكونه. خلاص يبتدي يديله اوفر نايت او 3 ايام ماكسيمم 72 ساعه 2 بي 3 ومش دبل. وبعد كده تعمله قسطره والله هو كويس هو مش هو كويس استنى اسبوعين واجيبه تاني اعمل. This is my policy and this is the guidelines still now. ان اي افتراضات تانية انا شايف ان هي
يعني اللي انا عرضته على الانترا كروناري ثرومبولايتكس دول حاجات لسه جايه جديد يعني لسه no it's not a guidelines up till now بس
just ايمن داخل في قصه كبيره ابعد الثرومبوليتيك.
But the thing is the reason why they're doing this study, this 3 study going on with the intracoronary thrombolysis now because there was some evidence that it makes some difference. Yeah, but some of them, there's a study with streptokinase. So 2 of them are being with RTPA and TPA or some of the other ones, alkylase in fact, because there was some evidence that it does make a difference. So whether the study will show a positive outcome or not, we have to wait and see.
هو يعني thank you very much for your excellent let me just give يعني part of my experience because يعني I have seen lots of these cases with thrombi and if there is a flow I think my experience is that if you give glycoprotein 2B3A and do it on the next day or after 2 days, it will give you a better outcome. If you put a stent with a thrombus, there is a possibility of slow flow or no reflow in the distal part. I remember one of the first cases was in the early times when I started intervention, and there was no stents, no just balloon, and there was no glycoprotein 2B3A, and there a middle-aged lady and had a big thrombus in the LAD, and I didn't know what to do. So I put her on enoxaparin for 1 week, and then after 1 week, it disappeared, and she didn't even need a balloon. Another thing is that use of covered stent. I have seen someone who has done it, and it was a catastrophe. So covered stents should not be used.
في حاجه اسمها ام جارد، في حاجه اسمها ام جارد. ام جارد دي ستنت يهوديه، هي مش بتاع، واشتغلوا بيه كده يا ايمن. الام جارد، وبعد يعني كنا زمان بنعمل فيه كذا حاجه اللي هو كلير واي، والكلير واي ده خلاص فانش، وحاجه اسمها ام جارد بتحطها جواها ومش موجوده. حاجه كلمه لها ستنتس دي اللي هي دي مش قايمه، ده في الليجن في الاكتيزيا بس.
Yeah, please don't use any covered stent for such cases, because the outcome is absolutely horrendous, and even acutely you achieve something, within 6 months everything is gone. So don't use covered stent, are not good for this. And I think this takes you back to, if you understand the pathophysiology of the acute MI, what the thrombus forms, this goes to your point that we don't know when the thrombus has formed, because it could be 2 or 3 days. It starts changing from red thrombus to white thrombus to fibrin to different things. And this is where the difference in the outcome of which medication you use plays a role.
Thank you, Dr. Sameh, and thank all the doctors for the nice discussion. If we are going to continue for this, we'll stay for the whole day. Now I'd call for the next speaker, my colleague, Dr. Mohammed Hassan. He will give a talk about STEMI with no reflow.
Bismillah ar-Rahman ar-Rahim. Good afternoon, everyone. I think all of us have encountered such scenario and such complication in the cath lab during primary revascularization of STEMI patients. But firstly, what's no reflow? No reflow is failure to restore effective myocardial perfusion despite removal of large epicardial coronary artery occlusion. And it's mainly occur during primary PCI of STEMI patients, but it can occur during elective PCI, mainly during SVG, PCI, and also during the use of rotablation. The incidence really is variable. It ranges in the literature between 11 to 41%, but it depends on patient, vessel, and lesion factors. No reflow have strong impact on the outcome and prognosis of STEMI patients. It's those who had actually no reflow during primary PCI is associated with a higher rate of post-MI complications, arrhythmia, pericardial effusion, cardiac tamponade in hospital, and adverse ventricular remodeling on the long term with repeated heart failure and higher mortality. So here, when they say, when they detect microvascular occlusion by CMR, they found that those patients has significantly higher mortality compared to those who did not have microvascular obstruction as detected by CMR after PCI. Also, on the long term, this is 5-year follow-up study showed that patients with no reflow have doubled mortality at 5 years compared to those who did not have no reflow during the primary PCI procedure, with a significantly higher infarct size during follow-up. And if you look at the cardiac function, those patients have more adverse remodeling. The ventricle is bigger on the long term with less function and actually higher incidence of heart failure with definitely significantly higher end-terminal pro-BNP. But importantly, we need to understand the pathophysiology and mechanisms of no reflow in order to prevent and early treat such complication to avoid the adverse remodeling of the ventricle and the poor outcome on the long term. The Pathophysiology, it's multifactorial. We have 4 interacting mechanisms that explain the phenomena of no reflow. Firstly, ischemic injury and reperfusion injury, what's called ischemic reperfusion injury, and the distal embolization, in addition to some individual susceptibility, and I'll mention it later, elderly age, hypertension, diabetes, acute hyperglycemia. There are many factors in the patient that increase the risk of no reflow. This is the pathophysiological changes that happen in our patient when no reflow happen. If we look, this is the microcirculation. So if we look at the wall, there is endothelial swelling, endothelial edema, endothelial plebs, there is gaps and exudate and extravasation of cells lead to swelling of the myocytes that compress the vessel from outside, in addition to spasm also due to many inflammatory markers. From the lumen, there is actually intravascular blogging by inflammatory cells like neutrophils. There is platelet aggregation, in addition to the atheroemboli that can cause intravascular occlusion. So here it's very clear that we have what happened in the vessel wall. There is edema, there is a spasm, there is extracellular compression, there is intravascular blogging by platelets, neutrophils, in addition to the thromboemboli. So importantly, that if no reflow happened, it could be reversible. And in 50% of patients, no reflow actually can improve with follow-up. So, and patients who had reversible no reflow, this means that the changes that happen, it's just only functional changes due to spasm, and it's reversible. But if the changes in the beginning was irreversible, this will lead to unfavorable LV remodeling on the during follow-up. This actually a study which detected no reflow at the beginning and actually followed up the patients at 1 month using contrast echo. Here we have good perfusion of the myocardium. Here we have a perfusion defect. And patients who had sustained no reflow had significantly larger ventricle and more deterioration of LV function compared to those who have improved perfusion during follow-up. But importantly, how can we diagnose and detect no reflow? During our coronary angiography, Tamiflu can help, but the sensitivity is really low because you can have poor myocardial perfusion even with Tamiflu grade. So combining the myocardial blush grade with Tamiflu increases the sensitivity. So to diagnose no reflow, you need to have myocardial blush grade 0 or 1 in addition to Tamiflu less than 3. Echocardiogram, ECG could be helpful with an ST segment resolution less than 50%, but also the sensitivity is low. We know actually even with Tamiflu 3, you may find that the ST segment did not resolve. Contrast echocardiography, CMR, and also SPECT can detect perfusion defect and can help the diagnosis of perfusion defect secondary to no reflow. But knowing the mechanisms and the 4 mechanisms that can explain no reflow, we can see what are the predictors. How can we predict no reflow in our patients? So we said distal embolization. So definitely, as Dr. Sameh said, large thrombus burden is one important predictor for no reflow. Ischemia, so the ischemic burden and importantly, the time of ischemia, it is the most important predictor of no reflow. So delayed presentation and long door-to-device time is an important, actually, it is the most important predictor of no reflow. Reperfusion, so the neutrophilic count and the mean platelet volume is one of the predictors, and individual susceptibility. So we can classify the predictors of no reflow into either clinical, angiographic, or serological. What are the clinical predictors? If the age is more than 65, systemic hypertension, importantly, acute hyperglycemia, regardless whether the patient is diabetic or not, acute hyperglycemia is a predictor of no reflow because it's associated with more hypercoagulable state, and they found that this patient has higher markers of thrombin formation and platelet activation. Schad's-Vass score is a predictor of no reflow. Lack of preconditioning if the patient does not have ischemia before this actually increase the risk of no reflow, and importantly, delayed perfusion. Angiographically, SVG, PCI, SVG is PCI is associated with a higher risk of no reflow. If the artery is big and ectatic, this is associated with higher risk of no reflow. Long lesion, high thrombus burden, grade 4 or 5. And this is defined if you see the linear length, the length of the thrombus is 2 times bigger than the reference diameter of the vessel. This actually increases the risk of no-reflow, floating thrombus, and definitely stent over expansion. That's why we do not recommend high pressure inflation and the stent over expansion. And there is some serological biomarkers that can predict the white blood cell patients with significant high leukocytosis. We know that those patients has poor outcome and larger infarct size and higher risk of no-reflow, the mean platelet volume, and the troponin. So knowing the predictors, so how to prevent no-reflow in our patient. As we said, importantly, we need to decrease the ischemic time. We know that if the patient has delayed presentation, we know that the risk of no-reflow is high, but reducing the ischemic time and the Doherty device time has a significant impact on the incidence of no-reflow. Individual susceptibility, actually correction of blood sugar while you are preparing the patient. In some studies showed that it decreased the risk of no-reflow, but importantly, if the patient taking statins long-term, this is proved to preserve the microvascular integrity and decrease the risk of no-reflow. Intra-stenting, if you have good distal visualization after the guide wire, so definitely it decreases the risk of no-reflow. If you have large thrombus, as Dr. Sameh and Dr. Muhammad Sobhi have illustrated, glycoprotein 2B3A and thrombus burden to decrease the thrombus is important. If still you have residual large thrombus after thrombus aspiration, it's better to defer stenting and not to put stent. Better keep the patient on glycoprotein 2B3A for a couple of days. If the patient is stable, this is what I am doing, is even to keep the patient on heparin for extra 3 days and then have a control angiography. You find a completely different image and you can put stent later on if you have a big thrombus burden. This will decrease the risk of no-reflow and the myocardial damage with stenting. How can we manage no-reflow when happened? Importantly, we should exclude other causes of abrupt vessel closure, rule out that there is a dissection or thrombus migration or a spasm by giving intranitroglycerin, ensure that the ECT is good, and we know that intracoronary vasodilators that we can give in order to treat or to decrease no-reflow, adenosine, verapamil, and nitroprusside, and we give sometimes, if the patient blood pressure is low, you give epinephrine, and actually it gives good results if the patient has refractory no-reflow and hypotension. But when you give the drugs intracoronary, it's better to deliver the drug into the distal coronary bed, either by microcatheter or over the wire balloon. But what we are doing in our daily practice is just do a puncture in your monorail balloon and deliver the drug distally to ensure the delivery of the blood to the distal coronary bed. And importantly, it minimizes the systemic effects of these drugs and minimize the incidence of hypotension when you give these drugs. You can give different vasodilators in multiple boluses. And even so, but unfortunately, no actually study have showed that these drugs improve the mortality or the risk of heart failure in those patients. Even adenosine, we know that in some study it decreases the infarct size, but in another study it causes actually increase in the infarct size when it's used in large dose during no-reflow. So to conclude at the end that no-reflow phenomena remain a significant challenge in STEMI patients. It's associated with poor prognosis, independent of other relevant clinical factors, including the infarct size. And although we have a number of drugs and devices to treat no-reflow, still there is increasing need to know, for more research to know the how to prevent and how to treat such unique phenomena. Thank you.
Thank you, Dr. Mohammed.
Excellent presentation, Dr. Mohammed. And this is a very common problem we usually face in the cath lab. We have seen some cases with overexpansion of the stent. Sometimes repeated inflation inside the stent induces this phenomenon. Do you suggest you have to have optimal results and maximum inflation and deployment of the stent, or you might be satisfactory with the TIMI-3 flow while you think that the stent is not well deployed in these situations?
Very important question. We know that during the primary PCI, the vessel actually is smaller. We know that there is a little bit some spasm, but you have the challenge that if you did high pressure inflation balloon, you may have some no reflow, but if you keep the stent smaller, you have stent malopposition. What's not recommended is to do over expansion with a ratio more than 1.2, but if you found the stent is not well opposed or there is tail waste, you should have post dilation. But it's not recommended to have repeated high pressure post dilation.
Another point, the degree of LV dysfunction is not considered one of the predictors of no reflow or slow flow. Do you think that there was no relations because you didn't mention this item?
Yes, heart failure is one of the predictors of no reflow. The patient has an LV systolic dysfunction. It is one of the predictors in addition to also AF, Schatz vascular. There are many clinical predictors.
Okay, I think the point that was just mentioned is very important. And I think it مهم جدا التفرقة ما بين under-deployed stent or mal-deployed stent and mal-opposed stent. Mal-opposition is not a big problem. Mal-deployed, under-deployed stenotic stent is a problem. So there's a difference between the two. Malopposition actually is not correlated with bad events afterwards. It is bad events are more common in malopposed stent, but there was no correlation between malopposition and adverse events down the road. There's a difference. So once you make sure that your stent is well deployed, and you can easily do that with stent boost, and there's no obstruction, no problems, that's fine. And obviously, always you weigh the risk-benefit ratio. If you're worried about thrombus protruding through the stent struts, when you post-dilate, then and the stent is well deployed, everything is good, you can leave it alone. So you will make decisions during the procedure, but I think it's very important to separate the definition of malopposition versus mal-deployed or under-deployed stent. Yes.
ممكن ان احنا نعمل ديستكشن مانيبيوليشن لو في توتال بنعمل مانيبيوليشن وبنعمل ديستكشن بالواير وبنحط الستنت في الفولس تراك فده بيعمل نور فلو بعد كده والناس ما بتبقاش عارفه هي برضه النور فلو امبولايزيشن.
محمد thank you, excellent presentation as always. But I'm picking up على اللي الدكتور أيمن قاله and I think it's absolutely correct. So long-term adverse outcomes are much more associated with under-expansion compared to malopposition. But being في القصر العيني where we are very academic in terms of definitions, I think we use the term under-expansion in so many ways. And unless there is a clear definition, this is especially true for younger colleagues, it becomes a bit of a myth. فممكن نرجع لدكتور أيمن, how do you define under-expansion?
Obviously, you're not going to do IVUS for every single patient. It's not going to happen. The easiest thing to do is basically with stent boost. You can look at it and you can tell. It's a poor man's IVUS. If there's an area that's not well deployed, the stent is not smooth, then you would go ahead and inflate some more. Remember, at the end of the day, the aim of doing intervention for an acute infarct patient is not to put a stent. The aim is to reperfuse the vessel. If you've reperfused the vessel, then you've done your job and you've saved the day. Further, minor modifications may sometimes push you back and you lose things. The other thing I wanted to mention was in no reflow. When you put a table that shows many drugs being used for no reflow, then automatically it tells me one thing. Just like when somebody has a flu, a cold, you ask 6 people, each one will tell them, take this medicine, no, take that medicine. no, take this one medicine is better. It basically means there is no one that is good enough. I think actually the most important thing is perfusion, keep the pressure up, and time. Time, ultimately, they will get better.
Last question.
So just a comment. I mean, I respectfully disagree a little bit with you about the unopposed stent. Because you could put the 2.5 stent in a 4.0 vessel and it'll look very, very nice and well deployed. Yeah, sure. So sizing the stent correctly is important. We are in an era right now that all the stents are excellent. The outcome, whatever you put, sometimes we see small stent and big arteries, it's still very good. So not, sure. Yeah, so not every undersized. Okay. Look, just to be clear of that, yes.
I think
because not every under-deployed or undersized stent is going to cause you a problem because they're that good. But almost invariably, every time you see a problem with the stent is under-deployed or unopposed. Yeah.
I think to make it clear, proper sizing and proper expansion of the stent is important. Don't leave your stent under-expanded and not match it to the reference diameter, because we don't use actually most of the time intracoronary imaging during primary PCI. But proper sizing, proper expansion. Don't fear that with more expansion you will have no reflow. Avoid over expansion if you have a satisfactory result. So this will be good. Last question.
Thank you, Mohammed, for this elegant lecture. I personally have some experience because I have some interest in this very particular issue in no-reflow the last couple of years that I did a lot of research. As Dr. Ayman said, there is much of unknown about this specific phenomena more than the known. And you mentioned a lot of the predictors, most of it like the pathobiological and the pathophysiological plausibility. And this means that most of these predictors are actually going to detect from the data by Cox regression analysis or whatever. So this is a matter of statistics. But to me, we don't have well-established understanding for this phenomena unless one small piece of information. This is a kind of small disease, small vessel disease. You have a patent, very patent major epicardial coronary, but the small microvasculature is disease, which is the case. The coronary physiology, it doesn't look like a bump to bump. No, myocardial muscle act as a suction power with a downward grading of the pressure. When you close these pressures, you elevated this pressure, loss of this gradient was makes the no reflow. So my understanding translated into the pharmacology. If you could improve the pumping power of your heart, you may have some improvement in this particular phenomenon, especially if you exclude thrombus dissection or whatever of this mechanical complication. So one of the unmentioned predictors, elevated LV EDP pressure, LV dysfunction. So if you fall a catastrophe with no reflow and you find no other option, I recommend to go with increasing pumping power by dopamine, dopatrix, or even adrenaline. Thank you.
Yes, I do agree with you that there is much information that we don't know about this phenomena. And importantly, you should even improve the hemodynamics of your patients and decrease the filling pressure. This could help. But not all patients have microvascular disease. There is a predisposition in the microcirculation, but there is a lot can happen during the acute event, as we said, from the inflammatory status, the thrombus burden, the distal embolization, all this actually predispose them. But till now, we don't know which patient they will face this phenomena or not. We said this actually in the conclusion that we need more research in this field to know really more about this phenomenon.
Thanks, Dr. Mohammed. Thanks. Next is.
We conclude this session and for the next session.
Okay, now we're waiting for live transmission. We'll move to a very interesting session, the nightmares. Can I call my colleagues, Professor Mohammed Al-Ramli, Ahmed Al-Gindi, Ahmed Tamara, Hamdi Sulaiman, Basim Zarif. They're going to chair the second nightmare session in this meeting.
لا presentations يعني presentations فين النايت ميرز يا محمد؟ انهي نايت ميرز؟ 2 يا محمد 2 نايت ميرز 2 17 بس احنا هنروح على اللايف ترانسميشن يا دكتور محمد دلوقتي؟ لا لسه شويه اوكي واحمد وصباح معلش ممتاز طيب محمد let's we'll start this nightmare 2 session. I'm calling on Dr. Ayman Abul Majd, an unknown complication.
Can I have my case? Okay, while we're getting ready, I am deeply honored, and it's a great pleasure to be invited to participate in this very exciting day, Asr Al-Aini Cardiac Intervention Day. It's wonderful science, wonderful cases, wonderful variety and interaction. I'm really happy. I learned a lot. I always do. And I look forward to continued cooperation. The case I'm going to show is really weird. And I don't say weird often. This was really something, we'll see.
It will be
Should
even
I
weirder.
describe
It will be even weirder if we can't see the slides.
But
That's going to be.
it's it looks like a very simple, and it seems somehow the cases that look very simple are quite often are really not. And that's what I learned a long time ago. The only easy case is the one that you have finished and the patient is left. This is a case I did recently, a couple of months ago, في مستشفى الشفا في التجمع. Assisting me was مدرس مساعد من عين شمس. His name was Mustafa. And it looked like a very simple, straightforward case. He's a 71-year-old male on whom I had done PCI with a stent for proximal LED lesion 20 years before. It was before we had drug-eluting stents, and I put a bare metal stent in his proximal LED. And since then, he was doing fine. Everything was perfect, no problems. He now presents with acute chest pain, acute coronary syndrome, at rest, severe chest pain, His wife called me panicking. They live close to the hospital. I told them to go to that hospital, it's just across the street. At the hospital, his EKG showed inferior wall changes and the troponin was positive. So we took him to the cath lab. I'm going to show, this is the left system, this is the proximal LED, and you can see it looks good. It's not fantastic, but it looks fine. We took multiple views, and it looks fine. Circ is fine, LED is fine. This was the right coronary. Approximately looks fine, and there's this lesion. Focal, tight. It's the only possible culprit, consistent with his symptoms, consistent with the EKG changes. So we took other views, and you can see it's a tight lesion. We inflated the balloon 2 millimeters, and then a 2.5 millimeter balloon. And this is what it looked like after 2.5 millimeter balloon. I'm a bit keen. I don't just go with a 2 millimeter balloon. I want to make sure I work with balloons. I like balloons before I put the stent. So then I said, well, this is a short focal lesion, and I love short stents. I always use the shortest stent possible. I felt somehow that I wanted to undersize. So I said, I'll take a 2.5 millimeter, and I can post-dilate. 2.5 times 12. Short stent, a little bit undersized, and I'll post-dilate. Now, I want you to look at something. Look at the proximal right. Any problems in the proximal right? Ostium or the proximal segment? I'm going back. I want you to notice here the curvature, but the ostium looks perfectly clean. That's how deceiving angiography can be. What actually happened was I could not cross the ostium of the right coronary with a 2.5 times 12 millimeter stent, ultra low profile. Then, after multiple times, I did what I always say don't do. I always say don't push. Your stent has to go smoothly. But this is humanity. We're humans. And the ego says, no, 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 come on. Don't tell me I can't cross this. And after multiple times, the stent got stuck at the right coronary ostium. At the ostium. It felt like a Doberman grabbed it and bit it. كأن كلب دوبرمان عضه. It would not, it was completely stuck. Part of it across the ostium, part of it in the aorta, mainly in the ostium, across the right coronary, but a little bit was in the aorta. So I tried to have gentle manipulation and stuff, but nothing. So ultimately, what I did was I decided to use the guiding catheter as a sheath. And I went in, I wanted to protect it. And I started pushing and pulling gently until I felt release. And when I pulled it back, the stent, we pulled it back, and that's the delivery system had the balloon and the steps, the footsteps of the stent, but there was no metal on the balloon. So we looked, and the stent was dislodged in the descending aorta. At first, the stent was down, at the renal, just around a little bit above the level of the renal artery. Then it suddenly, this is the stent, then it suddenly started shooting upwards against the flow. I'm sorry I didn't get it. I was shocked. It was shooting, it was like a yo-yo. It would go down and then it would shoot up. I'm talking somebody not jogging, I'm talking somebody sprinting. واحد بيجري 100 متر بأقصى سرعة, up, then down. Zero aortic regurg. None. None. So it was obviously a very scary, because when I first saw it in the descending aorta, I just want to go in sequence. I started shooting upwards, some reaching the base of the heart.
ده سؤال مهم. هو when you retrieved the stent with the guide catheter, was there still a wire across it?
Yes.
So you retrieved the full system and the wire was still across the stent.
When I pulled, but when we pulled it down.
But somewhere it obviously got dislodged.
Yes.
But initially up to the level of the descending aorta, it was still on the wire.
Probably,
بس
yes.
احنا مش شايفين صور, فهم just we're trying to get our head
let
around
me finish.
Sorry, but the coronary wire is still in the right coronary artery.
No, it's not. It was pulled back.
Right, okay. So this is the other thing, is whether it was still, the stent was still hooked
Right.
to the wire.
We thought it was pulled back. So we pulled the whole system because I was, the worst thing to me when it was stuck was I didn't want it to go to the cerebrum. So I sheathed it and I thought I pulled it. But apparently that's what happened. Anyway, so sometimes it would shoot up to the base of the heart and then it would go down near the renals. It was difficult to even look for it fluoroscopically, to run up and then run up, run down. So now, what to do? The initial instinct when the stent was in the lower descending aorta was to leave it there and hope it just doesn't block a renal or popliteal artery. But this was quickly abandoned once we saw the stent shooting up to the base of the heart, because I thought it was going to go straight up to the cerebral circulation. But number two, but stents are usually retrieved in much smaller vessels, such as the radius, iliacs, femorals, or often just left alone when in a harmless location. Obviously, surgery is an option, but where are you going to cut? And it's a moving target. It's not sitting near the renals. It's not sitting in the ascending aorta, in the descending aorta. It's just running everywhere. It defies logic. It defies logic. This is not logical. Why should something move against the force of flow? And the patient had a blood pressure of 120 or 130. So how can it move up? I looked, I read physics, and I still have not found it. Anyway, so first we withdrew the, what did I do? First thing I did, I said, cool down. Withdrew the Judkin right guiding catheter down to the descending aorta at the level of the stent. Then I inserted a 0.035 wire just to see in which plane the wire will appear in the wide, 2 centimeter big, 3-dimensional descending aorta. I would push the wire and look different views just to see where I am relative to the stent. Subsequently, we tried several other catheters, Williams, Amplas Right 1 and 2, which seemed to be in a better plane, but all attempts using a variety of snares were futile, failed, due to the extreme difficulty in determining our precise location relative to the stent and to the fact that you're running after a stent. It's not sitting there. I called it like إنه في المحيط. أنت في descending aorta في المحيط. It's huge. And it's moving. Finally, I tried an Amplatz left 1, which seemed to be in a better plane. I would take different views, multiple different views, LAO, RAO, AP, lateral, LAO, lateral, RAO, lateral, because I'm trying to reconstruct a three-dimensional structure from a from a 2D image. So at last, after using multiple snares, we decided to use a different snare. But the stent was suddenly more active in trying to escape our attempts. It was as if it's alive. I decided to stay, finally I decided to stay above the stent. Rather than running after the stent, I decided to stay above it and try to reach for it as soon as it started to move upwards. When I reached for it as planned, we could no longer find the stent in the descending aorta, as we couldn't find it anywhere. So I decided to, I had decided to try to catch it and pulled it in, and then we looked. So we couldn't find the stent. So I said, well, it must be caught in the sheath. So we pulled the sheath down, and this is the retrieved mangled stent. Finally, I could breathe. I mean, for about 45 minutes, I had no idea where is the stent going to stop when it runs up, and where is it going to stop when it comes down. We're not talking logic, we're not talking physics, we're not talking flow. This is reality. This is what happened. I'm very sorry.
Can we have one more minute,
guys, changed position. Give me 2 minutes, exactly 2 minutes.
2 minutes, please.
This is the stent in the descending aorta, and this is the retrieved, dislodged stent. This is the retriever I used. This is the IVC. This is the, it's an IV, inferior vena cava filter retriever. And this is the only one because all other ones are too small. This is the big one, and it has a beautiful flower-like appearance. It really, this is how I felt. كأنه واحد زي الcowboys when they run after the cattle until they finally catch it. The lessons learned, exactly 2 slides. Number 1, do not push against obstruction, even if unseen. Forget your ego, ما تزهقش زي ما أنا عملت. This may be due to wire bias or calcium spikes or nodules unseen on luminography. Options include converting to transradial to change the angle of entry of your wire and away from the wire bias. Sometimes, when I have faced similar situations, I would go with a balloon and dilate the proximal area. But in this distal right coronary, I did not want to risk dissection and having to put multiple stents in a big right coronary just for the distal lesion. Why was the stent running? Perhaps due to systolic vortex with stored energy in systole in the distorted stent, then released upwards. You should have a variety of snares available on shelf, especially this big one. It's not rare if it happens to you. I looked in the books, I couldn't find it, and finally, some of you may know this gentleman, many do not, but he is the only interventional cardiologist who was told not once, not twice, 3 times, you are the best in the world. This is Jeffrey Hartzler. I've always admired him. He came with Grunsig, and he carried the torch after Grunsig died. With ACC, they told him, you are the best in the world, the most skilled. There's nobody like you. At TCT, Greg Stone said, Jeffrey, you're the best in the world. There's nobody like you. And the same thing at Sky. He was a kind, gentle, وخجول. He used to say, our fallibility and the limitations of our knowledge should make us peaceable, gentle, and humble. فشلنا وحدودية معلوماتنا يجب أن تجعلنا نتسم بالرقة والتواضع. Thank you for your attention.
Thank you, Dr. Ayman. Any questions, any comments from the panel, any questions from the audience?
Just a simple, quick inquiry about the decision of trapping everything, the whole system. I think at a time you feel that you already some detachment or dislodgement of the stent over its balloon. So to take this decision, because we have some juniors in the room, so we should it clear. If you can control your stent, you can get out the stent without pulling out the system. But if there is a resistance or some dislodgement, you do what you want. We want to know what happened to take this decision.
Okay, actually, as I said, what I did was wrong. What I usually do, this is the first time I've ever had this happen to. There was بقول كأنه كلب عضه. It simply would not move. I could have gone with another wire and inflated a balloon and get some release. But sometimes we're human. I mean, let me put it this way. And I had 10 years before this. كان في عيانين جولي بسيميلر ستوري وقالوا لي قعدوا ساعتين ثلاثه مش عارفين يحطوا الدعامه. I told them don't worry ولازم يعمل جراحه. فجولي قلت لهم don't worry هعملها in 20 minutes. And I did a different approach and it took me 20 minutes. لكن as a human being, and this is my main message, you may know everything, you may know the precise mechanism, you may know what to do, but we don't do it sometimes. Because the ego sometimes says, what do you mean I can't cross this proximal, good-looking right corner?
A lapse in judgment, as we say. I think it's important. Before Muhannad, I just want to carry Ala Bassem's point. If you stent, the stent usually gets dislodged when you're trying to withdraw it in the guide catheter rather than the other way around. If you're outside of the coronary tree, the absolute priority goes to removing it from the arch to avoid embolization into the cerebral vessels. Once you're at the level of the descending aorta, when the stent, keep your wire in. If the stent is already deformed, it becomes impossible to pull it through the sheath. The best way is to establish a contralateral access.
I was lucky.
Snare it with an 8 French sheath and remove everything together from the contralateral access. This is the safest way if this happens. Muhannad?
This was going to be my point about how to retrieve it. The point about how to retrieve something, the guideliners now help you to keep your position. So taking a guideline and down to that stent would be probably the easiest option. Of course, this is easy to say here in backseat driving.
You saw the angle. Sure. It was a horrible angle. I think the calcification from the ostium into the
مساء الخير يا جماعة.
The whole internal lumen was deformed from the calcium.
What I'm saying is the guideliner could come very close to the stent and you could pull everything together.
مساء الخير يا جماعة، انتوا سامعيني؟
The snares, what we have for the CTO is the end snare, which is at the tulip thing. So if you're stuck and you need a big snare, these are very good for the aorta because they fill the whole aorta.
It would be too small for the width of the aorta.
No, the end snare, they come up to 33 millimeter.
Oh, okay. I looked in physics. I read in physics.
Dr. Ayman, I think we need the ready for us in the cath lab, but we have one pressing question or comment here.
I want to tell a story, a true story which happened to me some 3 years ago. One of my colleagues, professor in Al-Azhar University, has got a myocardial infarction. I sent him to Cleopatra Hospital, and there it has been taken consent to make catheterization and intervention for him.
Sorry, can we hold on to that thought? Sorry, I'm very sorry, because they're ready in the cath lab, and I think they're holding the patient, so they would have to take priority. Dr. Hisham Salah, Dr. Rida Abul Ata, and Ahmed Al-Gindi, وجنبي دكتور محمد الرملي. The whole panel is with you. We don't want to waste your time. Please.
أحمد محمد الرملي، أهلا بيكم. احنا حاليا في الحالة الثانية لايف. بنحب نرحب بحضراتكم جميعا. معايا هنا في الكاث لاب من القصر العيني بروفيسور أبو العطا، ومعايا مساعد دكتورة ميرنا، ومعايا نيرسينج ستاف إيمان، ومعايا محمد على راديولوجيست، وطبعا معانا بقى المايسترو بتاعنا بروفيسور محمد عبد المجيد اللي الحقيقه بيحاول دايما يخلي السيت اب سيوتابل. الحقيقه احنا النهارده اتس كيس قلنا يعني واي نوت دو ان endomyocardial biopsy حاليا بقالنا كتير قوي ما بنشوفش حالات نعمل لها اندومايكارديال بايوبسي، فالحقيقه في وجود الدكتور رضا ابو العطا it was a good opportunity to start to do this case. الحقيقه التكنيك is very easy، ومعايا كمان اسامه واحمد اسماعيل على التي اي. احنا هنا we opted to have TEE guidance بالرغم ان it's not mandatory خالص، ولكن maybe it's helpful لو احنا عايزين ناخد يعني patchy biopsies from multiple sites، لانه ده الحقيقه بيساعدنا جدا ان احنا to locate the site of the biopsy. معانا دكتور عبد الرحمن كمان هيدينا ال short history about this 41-year-old lady. عبد الرحمن.
Our patient, 41-year female patient, blind at age of 4 years, intellectual disability, recently discovered hypothyroidism, present to ER with dizziness. ECG show third degree complete heart block. Labs TSH12, calcium hypocalcemia, workup for amyloidosis, kappa lambda ratio below 1/3. Bedside echo, ejection fraction 50, LVH, septal wall thickness 1.3, moderate to severe mitral regurgitation, dilated left atrium, mitral inflow E/A ratio more than 2, E/E prime 20, TAPSI 1.4. CMR show
يعني دكتور عبد الله الأغا هيقول لنا السي ام ار، لان احنا طلبنا لان الكيس was suspected to be an infiltrative heart disease، فطلبنا من دكتور عبد الله الأغا ان هو يعمل لنا ال CMR for this case. زي ما قلنا لحضراتكم العيانه is 41 years old، والحقيقه جايه هنا بكمبليت هارت بلوك، اتركب لها temporary pacemaker، بس طبعا لما جينا نعمل ال CMR اضطرينا نشيل التمبري. البيز لاين هارت ريت بتاعها ماشي usually in the range of 40s and 50s، والحقيقه بعد ما رجعت من السي ام ار احنا ما اضطريناش نحط لها temporary wire. بروفيسور عبد الله الأغا لو يقول لنا كده what did he find.
تمام، شكرا دكتور هشام. الانديكيشن طبعا في حاله السي ام ار انه البيشنت عنده ال في اتش او عندها ال في اتش وعندها كومبليت هارت بلوك. طبعا كومبليت هارت بلوك هنا ممكن يبقى مسليدنج. كتير هنفكر في الساركويدوزس، بس طبعا السي ام ار مختلف، بيعمل تيشو كاركترايزيشن. It's not a histopathology. Complete heart block can be with any infiltrative heart disease. ممكن يبقى مع الساركويد، شفناها قبل كده مع الاميلويد، شفناها مع ديزيزز كتير. فمش معنى ان عندي complete heart block يبقى انا لازم افكر ان البيشنت عنده ساركويدوزز. الايجكشن فراكشن طبعا جولد ستاندرد سي ام ار is mildly impaired 43% الليفت و44 الرايت. احنا عشان ما نضيعش وقتكم هنخش على طول على الصور المهمه بتاعه الكاردياك ام ار اي اللي هو الديلي انهانسمنت. الديلي انهانسمنت الباترن بتاعه بيديني فكره انا بتعامل مع ايه الديزيز اللي انا بتعامل معاه. Again it's not a histopathology. لو بصينا هنا الشورت اكسس تمام، ابيكال وميد وبيزل. لو بصينا هنا في النص هنلاقي فيه ديفيوز سب اندوكارديال انهانسمنت. هو مش واصل للمايوكارديوم نفسه بس هو ديفيوز. الحاجه دي بنشوفها في حاجتين مرضين بالظبط، البيشنتس اللي عاملين كاردياك ترانسبلانتيشن اند اميلويدوزس. وبصينا في بقيه الصور، احنا بنبص في اكتر من فيو. This is a 3 chamber view. شايفين كل ده diffuse enhancement مش ماشي مع الاسكيميا طبعا. وده في 2 chamber view باين diffuse endocardial enhancement. المنظر ده ما بنشوفوش الا في الحالتين دول. ممكن ان احنا نشوف في حالات ساركويدوزس، بس الساركويدوزس بيبقى عنده predilection لللاترال وول والسبتال وول، ما بيبقاش ديفيوز، بيبقى انترا مايوكارديال يعني ميد مايوكارديال او سب ابيكارديال. Again so this is suggestive highly suggestive of amyloidosis، ما عدا حاجه واحده، حاجه في تكنيك معين اسمه لوك لوكر اللي هو بتقروا عنها اللي هو difficulty to nullify the signal، بس this is an advanced feature هو ما كانش موجود هنا. فاحنا ممكن at a certain stage ما نشوفش الساين بتاعه السي ام ار. سي ام ار conclusion highly suggestive of amyloidosis.
ميرسي جدا يا عبد الله. Thank you very much.
Dr. Hisham, sorry, just to get our heads around the clinical thing. اتعمل tagging at any point during the MR study يا عبد الله؟
Yes, tagging we use it طبعا عشان زي ما دكتور احمد جندي بيقول احنا بنستخدم التاجنج علشان نشوف الامبيرد دايستولي. الحاجه الثانيه اللي مهمه جدا برضو ان احنا نشوف حاجه اسمها الامبيرد لونجيتيودينال كونتراكشن. كل العيانين اللي بيبقى عندهم انفلتراتيف هارت ديزيز بنلاقي فيه اللونجيتيودينال كونتراكشن امبيرد، بيبقى واضح جدا في التاجنج وبيبقى واضح حتى في السيني، وبنعمل سترين بالظبط. بس هنا يعني البيكتشر كده suggestive of amyloid.
طيب
وفي كمان طبعا ليفت اتريم، نسيت اقول ليفت اتريم ورايت اتريم في انفولفمنت. الار في بصراحه يعني هي دي بقى المشكله، ان انا ما عنديش يا دوب very small area في الرايت فري وول، فانا مش عارف البيوبسي هتجيبه ولا لا. احنا يعني اتس بلايند، فمش عارفين نشوف هل البيوبسي هتطلع بوزيتيف ولا لا.
دكتور هشام congratulations for the different kind of cases. باسم ظريف مع حضرتك.
يا باسم ازيك؟
I'm really good morning. I'm really congratulating for having different case scenarios in the case.
احنا قررنا المرة دي نقاطع التالي الصراحة.
Yes, بس في حاجة مهمة أنا I want to ask about this patient that have multiple endocrinal and electrolyte abnormality. There is any suggestion for a syndromic diagnosis before for this lady?
Well, يعني I don't think that this is a syndrome. بس طبعا يعني لازم كلامك صح. We have to be considering يعني some other forms of infiltrative heart disease. بس anyhow احنا ما فيش سندروم معين. العيانة كمان is I think she's deaf أو she's blind since the age of 4 years. communication with her is a bit difficult because she is للأسف يعني شوية mentally subnormal. احنا هنا طبعا لازم نبقى فاهمين ال indications for going for an endomyocardial biopsy. بس يعني this is not the thing that we'd like to talk about لأنه عموما بيتعمل في transplant rejection. وطبعا في حاجات تانية منها ال undiagnosed cardiomyopathies. Sometimes we have to go for this, but the definite indication is usually cardiac transplant rejection. احنا هنا التكنيك اللي احنا استخدمناه طبعا زي ما قلنا العيانه is a complete heart block، فحطينا لها شيس femoral وشيس jugular. ما حطيناش temporary wire ولا حاجه لان الهارت ريت and the blood pressure was okay. يمكن بعد ما ابتدينا بشويه لقينا البلاد بريشر شويه dropping والهارت ريت شويه يعني dropping، فحطينا لها arterial sheath كمان عشان just to make sure that things are going in the right direction. بعد التخدير before the procedure. مهم جدا زي ما الدكتور رضا دايما بيقول planning the procedure is something extremely important. القصه مش حكايه يجي لك ورق ولا تبص كده بصه سريعه. No, you have to look by yourself by the echo تشوف يعني to reconfirm the diagnosis and to recheck the indication that you're doing. هنا دخلنا في البشيس 40 سم من كوك والبايوتو والبيوبسي فورسبس اللي احنا استخدمناه في بيوبسي فورسبس طويل اعتقد بيبقى 104 سم يا دكتور رضا، بيستخدم فيمورال. بس اللي احنا معانا هنا هو 50 سم اطول من الكينك ريزيستنت شيس اللي احنا مستخدمينه اللي هو 40 سنتيمتر. الكينك ريزيستنت ده ليه جي شيب كده في الاخر، ده بيساعد ان هو immediately to engage very easily على السبتم. بيساعدنا كمان ان احنا بندخل ببيك تيل كاثيتر، لان الحقيقه one of the complications اللي ممكن تحصل من الاندومايكارديال بايوبسي ليس فقط قصه ان احنا يحصل انجري ويحصل مايكارديال perforation وكده طبعا which is extremely important and dangerous، وبتحصل في نسب متفاوته ما بين 1 to 3% according to the studies that has been addressing this issue. ولكن كمان مهم جدا ان احنا ما نعورش الترايكاسبيد اباريتس، لانه الحقيقه اما بيحصل injury to the tricuspid apparatus حتى لو العيان استمر انه يتن ويبقى asymptomatic، اللي بيحصل in this per se is one of the things that lead to long-term morbidity and mortality. وبالتالي ان احنا بندخل احيانا بالبيك تيل بحيث ان هي تقربنا من السبتم، وبعدين بندخل بعد ما نبوزيشن اور سيلف. هنا احنا we were very lucky مش مجرد ان احنا بنبوزيشن اور سيلف using the fluoroscopy، ولكن كمان بالتي اي giving us wonderful 3D pictures هنبقى نوريها لحضراتكم. يمكن ده برضو اللي مخلينا شويه بناخد وقت اطول شويه في البروسيجرز plus اللوجيستكس in general. احنا لغايه دلوقتي واخدين around 4 sections or 4 bites. هناخد الخمسه. يلا يا ميرنا. احنا بندخل بالبيوبسي فورسبس ده وبنتننا داخلين جوه.
Do we see the echo and fluoro? Do we see the echo and fluoro يا شباب? No, they see it or not? Ahmed, do you see the echo? Do you see the fluoro?
Yes, absolutely. Perhaps if you can, guys, minimize the ECG. We don't really want to see it now. We can look at the echo and the fluoroscopy screen.
Yeah.
احنا we are in good position كده يا أسامة.
زوم يعني قلل الزوم شوي. قلل.
I was going to ask, thank you, this is a good case to show, but how secure is the diagnosis of amyloidosis and what's the biopsy going to show?
Yeah.
Particularly with the right coronary artery showing a very small area of involvement. In the differential diagnosis on the MR was one of two cases, and the first one was excluded. Yes. So the amyloidosis is probably more likely.
Open.
I think we can now focus on the. It's a valid question, Mohana, that I was going to ask about the nuclear scan and the validity and whether we did a subcutaneous mass aspiration. So there are many things that we can do, but this is the. Besides Dr. Hisham and Dr. Rida, do you mind, for people who are not familiar in particular with biopsy, but this is a beautiful position right across the septum. We don't see your hands. Rida, which cup size is this?
This is it's a 5.5 French bioptomal bioval of Cordis, which I think it gave us around maybe 4.5 transverse diameter. That it can give us the cup. It's almost 1.5.
Yeah, that's the. It looks like not the biggest, but it
it's not the biggest.
Lead to a reasonable bite.
Do you guys use the TOE always, or is it just for this case?
Yeah, it's just for what we call it's a demonstration for the team, because if they are next morning they have a case in the right atrium or in the right ventricle patchy or a specific spot they wanted to get to be familiar how to get the end of the sheath end on and how to see the bioptome itself to make sure that we are getting the appropriate position and the appropriate site and target we need. It's a complementary imaging, but it's not mandatory.
Definitely, it's not mandatory, but I can tell you, I'm really finding it quite helpful that you're having two confirmatory techniques through fluoroscopy and through the TEE. We know it's not actually mandatory, but I think during the procedure, we already took the 5 bites that we wanted, and I think it was quite helpful. Ahmed, كنت عايز تسأل إيه؟
Yes, we just wanted some tips again for people. Unfortunately, بسبب essentially that transplant is not available in Egypt. There are very few centers who do myocardial biopsies.
Yeah.
And, many of us don't have experience, many around the room. And Nama, I just want to, you mentioned a particularly important point about the need to avoid getting entangled into the chordae of the tricuspid valve.
Exactly.
And hence introducing initially via a pigtail well placed into the apex is an excellent way to do it. I just wanted to pick your brains and Dr. Rida's as well. How do you make this, especially in high volume units, Rida? We obviously do it occasionally bedside nowadays with echo guidance or with fluoroscopy guidance only. How do you make it a safe procedure? What's your advice to younger colleagues?
Yeah, this is actually, it's how to avoid what is mandatory to avoid. Perforation of the tricuspid valve, perforation of the free wall of the right ventricle or the RVOT is the commonest problem, or perforation of the right atrium. What is meant or what is mentioned in the literature, they go with a short sheath, which is an 11 centimeter to be in the mid cavity of the right atrium. And then to go to advance the bioptome across the tricuspid valve, I don't see this as the appropriate way. But in our practice, we adopted to do this way to pick up a sheath that it can go directly from the mid cavity of the right atrium, assisted by the big tail with a 40 degree or 45 degree, and sometimes we shape the sheath to be directed on purpose toward the septum as where we are going to go. As regard what type of safety of the patients, we don't have to give it if we are not going to do a general anesthesia or a TE. We can use the ICE catheter to locate our position if we would like, or we can just go with the fluoroscopy if we have maybe 20 mil of contrast in the RV, in whatever the projection and the LAO, we can locate exactly the septum and the infralateral wall of the right ventricle, and we know exactly where the level of the tricuspid valve for anatomical localization if we don't have to go to the TE. If we are going to do it as a bedside, the same, we can go, we can do also bedside with an echo guidance without going to the fluoro. We have the very nice radio opacity of this system. We can see exactly where the pipe tome is going to get the pipe. So every is available, but in my personal practice, I prefer to go in the cath lab to get in fluoro guided. If I need to do it on an ice, if I'm not planning to do a TE and I'm planning for maybe tumor or masses or something, I'm going to get a particular spot. But for whatever it's a septal bite, I don't have to get imaging rather than the angiography, and this is, I think it's enough.
I think we are having also some limited experience regarding patients who had cardiac transplant.
Yeah.
But the audience and Professor Reda, do you think there is a difference between the biopsy done in patients, ordinary patients having myocarditis or whatever indication it is, and patients who had a heart transplant?
The risk of perforation is higher because
exactly.
It's multiple bites, multiple visit, and this ectopic heart, usually the probability of getting a perforation is higher. So we have actually in Saudi Arabia, there is a lot.
Yeah, the second question, is it also related to this is, for instance, if you did for the first 3 months biopsies, a biopsy more than one time, and then you did it later, will it be less risky?
I think so, but the problem here is usually if you avoid the RV wall all through and you get your bites from everywhere from the septum, because the septum is a tremendous space that you can get a lot of this one, I think it is much safer.
Abdullah Agha wants to
I just have a comment on
I have a question,
and just 1 second, Abdullah Agha here from the panel, from the cath lab wants to have a comment, please.
Okay, so I'm commenting on Dr. Mohannad and Dr. Reda Abul Ata about the blind biopsy. So we sometimes we get a negative biopsy because we are just puncturing or just taking the biopsy from the wrong side. What is a new or a known modality is a hybrid modality. So we hybrid or we fuse the MRI images with the fluoroscopy. So we can get a direct, we know where's the amyloidosis or where's the infiltrative tissue that we are planning to take the biopsy. And this one will help a lot.
Yeah.
Dr. Reda, this is Hamdi Sliman. Welcome, Dr. Hisham.
Ahlan bik.
Dr. Reda, when do you expect a complication? And when you decide to quit this procedure?
Yeah.
Okay. Actually, the blind maneuver is the first step to be entrapped into a complication. When we plan it, we have exactly a very nice echo images to see where is our bite is coming to get, and we have all the time monitoring of the pericardium. If you look carefully to this image, when Dr. Hisham, he touched the septum and he is against the septum, the sheath is coming back. And when he is biting and coming back, the sheath is again is forward moving. So this is a good landmark. Number two, we can look carefully to the silhouette of the pericardium or the cardiac silhouette to make sure that we don't have any pericardial effusion, because this is the problem if la qaddar Allah, if we have perforation. And another issue that in the echo, this lady already, she had an anterior pericardial effusion. We mapped it, we decide the size exactly, where is it, and to all the time we are following after each bite to make sure that we don't have any injury. So fluoroscopy, echo guidance, if la qaddar Allah, if we have perforation, we have to stop, and mostly it is a self-limiting because it will be a very tiny just to keep the hemodynamics, and that's it.
Reda, a practical question, not related to the technique. So we do frequent biopsies in patients on LVADs in our unit. And one thing we've battled
patients
with is
of what, Ahmed? Patients of what?
On LVADs, with LVADs.
Okay.
And one question which is not always easy to answer, how do you manage the anticoagulation? Because if your indication is mere AF, we probably know how to handle that, but with LVADs, obviously, stopping anticoagulation for a prolonged time becomes a bit of a concern. So how do you manage anticoagulated patients?
Actually, if I have a venous access, if I'm not planning to have any bite from the left side, if my bite is going from the right side, even with a INR up to 2.8, we go from the venous axis, and when we finish, we close it with figure of 8. We don't have to worry about it, or we can use a ProGlide. But if we have an arterial axis, I prefer to go from the radial axis to, if I'm going to do something from the radial, because it is more or less, it's a 6 French compatible, so I can go through the radial. I can get, if I have to bite from the left side. And I keep the patient on his own full anticoagulation. I do not stop, I do not manipulate. And this lady, because she is not on anticoagulation high doses or a full anticoagulation, we give her a heparin despite we are in the right side. This is just for safety, because we had to put her an arterial sheath in the femoral to monitor her hemodynamics. But actually, I do not change, I do not manipulate it. So as long as I'm going with the venous axis with a 6 French, 7 French sheath, it's not a problem.
طيب احنا just for the sake of time يعني you'd like to thank حضرتك.
اسمح لي بس عايز اسال سؤال مهم.
sure.
What to do with the biopsies؟ احنا في سبيشال
ما طبعا يعني احنا ما شغلناش بالكم باللوجيستكس. اوكي احنا طبعا before starting we sent to the pathology department وجبنا formaldehyde وده موجود already، جبناه من الاسم هناك، ومرتبين ان الباثولوجي specimens will go there. طبعا في حاجات more advanced than just having pathology. خلاص ده بيديبند على الايتيولوجي اللي احنا بنفكر فيه. are we talking about myocarditis مثلا ولا بنفكر في ايه بالظبط؟ بس anyhow، وطبعا حتى انواع الستينز اللي بتستخدم بس in general احنا خدنا already خدنا حوالي 6 عينات لغايه دلوقتي، و I think this will be enough probably. ويمكن ناخد دكتور رضا هو بيريكومند كمان 2 ولا حاجه. بس يعني المهم ان احنا كمان طبعا احيانا بيحصل premature beats when we just touch the septum. ما اعرفش ده كان ظاهر لحضراتكم ولا لا. و I think يعني
هشام دكتور جلال عايز يقول كومنت.
اتفضل يا دكتور جلال.
دكتور رضا والدكتور هشام. هشام رضا.
نعم مع حضرتك يا دكتور جلال.
You know, I would like to make a comment, then tell 2 stories.
Okay,
Number 1, I did over 150 cases of biopsy, and I didn't have this luxury, even transthoracic echo. I did it for Ayman Addah because at that time there were no investigations, and it was difficult to differentiate constrictive pericarditis from restrictive cardiomyopathy. And even we had to open window to take a piece of the pericardium. And so I did biopsy. And if the myocardium is healthy, it's constrictive pericarditis. If it is diseased, it's restrictive cardiomyopathy. The second thesis I did it for مدحت الرفاعي.
ممكن نشوف ايد دكتور هشام يا جماعه. This is important for people who are not familiar with the technique. الكاميرا. سوري يا دكتور جلال اتفضل. The second story.
I did it for مدحت الرفاعي. At that time we were doing a closed screen. And
يا دكتور رضا.
After you
دكتور رضا screen.
The patient does not improve. I thought that there is going on myocarditis, and I did for biopsy for all the rheumatic cases with normal C-reactive protein and ASR, and I proved that there is inflammatory process going on,
resistant,
and even there were Ashov nodules in the myocardium. The third patient I did, she had transplant in France, and she was unable to go.
قطعة صغيرة.
I was doing for her
البايت الأخيرة
from the leg.
عملنا بريكابيل.
It's supposed to be from the neck.
Just to finish and we'll put her.
And so I didn't do all these sophisticated things.
ومن غير لايف ترانسميشن ولا حاجة.
كفاية؟ كفايه enough. طيب احنا بنشكر حضراتكم، ميرسي جدا يا دكتور جلال على الكومنتات الجميله. وجاست وي ويل بريك
دكتور
ناو.
جلال لسه ما خلص. دكتور جلال اتفضل.
اتفضل يا دكتور جلال.
There are two important stories. One very important person, probably he was the second man in Egypt.
ورينا كده يا
Went to Cleveland. And a doctor did for him biopsy and he died. And it's a
أسامة ايوه وريني كده.
Not so far ago.
مش بريكارد ديفيوجن كبير قليل.
And you know there is another.
Not so long ago يا بيه.
Keep it.
بس ميرسي جدا يا دكتور جلال على الكومنتات الجميله دي.
واحده بس ما اخلص.
اتفضل يا دكتور جلال اتفضل. انا مش سامعين اصلنا معلش.
A little patience.
Another important person was in prison and they want to give him release medical and they were suspecting amyloidosis and they asked me to do biopsy. I said it's contraindicated and I refused. And you know, it's a very simple procedure. They made it now more complicated and very afraid.
احنا بس كنا عايزين نشوف دكتور هشام ودكتور رضا شغالين سوا. مش
هشام do you have bicardial
عقبال ما نبقى سوا يا احمد.
نعم
زايد شويه.
ايه السؤال يا جماعه؟
we can appreciate that there is some bicardial effusion.
Yeah, we can see it. It's not that much. It's the same from the very beginning, very minimally increased. Probably, I don't think it's an issue.
So perhaps one last question من دكتور شريف صقر وبعد كده if you have nothing else to show us we can carry on with the program يا دكتور هشام.
اوكي اتفضل.
I think one of the
اديني صنايعي.
طبعا excellent to be trained for this maneuver يعني not be done as important in some cases but in such cases with high susceptibility, high probability of amyloidosis. One important non-invasive test is isotope study complementary with a sensitivity of more than 90% cases. We are underdoing this test in such cases.
I think in Hoa there are some doubts. I think this was meant for the technical part, but I agree there are a number of concerns and raised eyebrows about the indication of a biopsy in amyloidosis. There are perhaps a few other techniques that can be done to be both more rewarding and perhaps less invasive.
Actually احنا في 16 يناير اللي فات عملنا مايوكاردايتس داي بالتعاون مع قسم الباثولوجي واتفقنا على بروتوكول مشترك ان هم نبدا نعمل حالات مايوكاردايتس بايوبسي. هم عندهم نيو تكنيك السلايد بتاعت زمان الميكروسكوب بتعمل ديجيتال ايميجنج وبتعمل بتاعت العالم كله ويبداوا يناقشوها مع بعض. فذيس از بارت اوف بروجرام مع اسم الباثولوجي في القصر العيني.
So any last comments from you in the cath lab دكتور هشام ودكتور رضا؟
لا ثانك يو فيري ماتش. احنا وي ار بيت ليت فاحنا عايزين يعني جاست تو هاري اب. احنا شاكرين على الكومنتات الحلوه بتاعتك يا احمد وبتاعت دكتور باسم ظريف وكل البانل الجميل الموجود وطبعا الدكتور جلال بيه. يعني we just wanted to show you some يعني a forgotten technique or a not very commonly used technique at least in many of our departments, but I think it's mandatory at least to know the simple maneuvers. Thank you very much.
Thank you very much.
Okay. Yalla, have a good day.
Thank you. I think we're okay, no problem.
We'll go back to the nightmares, and our second nightmare is going to be from Dr. Ahmed Al-Gindi.
Thank you, Dr. Mohammed. Dr. Mohammed Abdelghani, Dr. Hisham, it's an honor and a pleasure to be here. يعني ده أنا بعتبر برجع بيتي as always. So back to old techniques. I think we've seen our fair share of coronary work. This is going to be again a structural case. دكتور جلال ترانسبتال بقى ده احنا راجعين لك في الحاجات كلها. ده حاجة على ترانسبتال بانكتشر مش معقول هتمشي. But this is always great to be back home. So this is again away from the coronary work. A 57-year-old lady who underwent mitral valve replacement in 2003, redo MVR in 2018 for paravalvular regurgitation. Currently complaining of shortness of breath or moderate effort, severe hemolysis with repeated blood transfusion over the past few months, permanent atrial fibrillation, and TTE showed mildly dilated LV with preserved EF, severe pulmonary hypertension, a hugely dilated LE, and moderate mitral paravalvular regurgitation. You can appreciate from the 2D-TEE initially that there is a single lateral defect, mostly on the color 3D echo around 8 o'clock, slightly related or related to the left atrial appendage. Now, this was the size of the defect. They're usually crescentic defects rather than circular. On this occasion, this was a single defect, but because of the combination of hemolysis and heart failure, we had a clinical indication to intervene. Now, the CT is there. We usually do CTs for PVL planning. It helps us with very tricky leaks, especially when they're very large. But on this occasion, it's part of the routine. But you can appreciate how dilated both the LA and the RA are. Now, the first thing is when you do this in an antegrade fashion, you do a transeptal puncture. And one thing we've learned with transeptal punctures with the rising use of transeptal punctures for different structural heart disease interventions is that fluoroscopy can be very tricky. So what we're very much accustomed to in this part of the world for balloon mitral valvuloplasties, for instance, I can tell you that in patients who've had previous or multiple open heart surgeries, the anatomy is distorted to a great extent. So your classic fluoroscopic markers, they actually don't work that efficiently or that not in a reproducible way. The other thing is because we have so many procedures nowadays that require a transeptal puncture, doing a transeptal puncture just at the level of the fossa can be extremely counterproductive to a number of procedures. So with MitraClips, for instance, with LAA closure, you really want to pick a specific site in the septum, which is again not possible or not feasible with fluoroscopy alone. So 2D-TEE or 3D-TEE is the way to go when we're going when we're doing transeptal punctures for structural heart disease interventions, but occasionally they can become very difficult in patients who've had multiple previous surgeries, in patients with hugely dilated atria. Positioning can be difficult, and on this occasion, it was quite difficult getting a steady position across the interatrial septum. One technique that can be helpful is getting a highly penetrative wire through the transeptal needle. On this occasion, this was a Conquest Pro 12 wire, something we use for CTO interventions. And those can occasionally make a good tent within the interatrial septum and push you through. However, the course was very funny. And if you look here, the course here looks extremely funny. It's still within the cardiac shadow, but the wire was very sticky and we couldn't understand what we're doing exactly. Dr. Galal would remember that in the older days, when you occasionally, rather than cut through the septum, you dissect into the interatrial septum. Sometimes you do a gentle injection for the tip of the needle to delineate, we call it ferning, to delineate this interatrial septal anatomy. And this is exactly what we try to do with the sheath here. And I do not think we've seen this before. So what we have here is a track created by the CP12 wire. And we've simply advanced the transeptal, the Mullen sheath essentially, or the dilator on this occasion, did an injection to try to delineate the interatrial septal anatomy. And what you see here is this track. It's a hydraulic dissection. The track went all the way and opened into the roof of the left main. And this essentially means this was a high puncture. It traversed the transverse sinus, went into the wall of the aorta, and eventually find its way, because of the hydraulic pressure, into the roof of the left atrium. And it was difficult. Obviously, there was a lot of silence in the lab at the time of the injection. It took us a few seconds to understand what went on exactly. I can tell you we were not in full agreement between interventional cardiologists and imaging and surgeons and so forth. But the first thing you need to do before you understand what went on exactly is to secure the coronaries, obviously. So this was a quick Judkins diagnostic angiogram to understand what went on, and it confirmed that what this was a hydraulic dissection opening into the roof of the left main, puffing or opening at the junction between the left main and the LAD, and you can see the backflow into the aorta. So the next thing becomes obvious: protect both coronaries. And we have two wires now sitting across the LAD and the circumflex. Both are in the true lumen. And the next thing was to wait, because an important decision was whether this is a surgical candidate now and we need to send him for urgent surgery, or we can carry on and treat this percutaneously. And I think one important thing was to identify whether there was going to be a pericardial effusion at that point in time or not. So we waited for 10 minutes. We have 2 wires across the coronaries. Hemodynamics are stable. A quick team discussion in the cath lab with our imaging colleagues and with the surgeon, and we agreed that this is a stable situation. This seems to have traversed into the wall of the aorta. We have no pericardial effusion, and therefore we can continue to treat this patient percutaneously. Now, this was an IVUS image, in all honesty, for academic interest, to say the least, but it just confirmed what we had in mind. Going back from the LED, you can see a huge hematoma at 9 to 1 o'clock, and a dissection flap. This is where the site of the pop-off or the puff of the injection into the left main. And accordingly, we placed a single stent left main into the LED with good results. Now, having stable hemodynamics, very low or reasonable radiation dose, we agreed that we will carry on with the PVL closure. However, we need to do it in a controlled way on this occasion. So one way to get a good contact with the septum is to use a deflectable sheath. On this occasion, this is an 8.5 French Agilis sheath. We frequently use it for PVL closures, but we also use it for LA ablation procedures. And through the sheath, we have a 6 French coronary guide catheter, a CP12 wire, and this is what you can see traversing now across the septum into the left atrium. But you can appreciate with in the bicaval view that we now have a very steady position across the fossa. This is the coronary wire across the interatrial septum. And perhaps those 3 images explain why it was very difficult to cross initially. It's not just dilated atrium, but the interatrial septum was really tough. So we had to dilate with coronary balloons before we could put anything across that thing. And now you can see a 5 French coronary catheter being advanced into the left atrium. This was an INWI wire. We tried to cross into the defect and close it without having to establish a rail. This proved to be difficult. So we simply advanced Teromo wire into the LV aorta, snared it from the arterial side, and now we have an arteriovenous loop which facilitated delivery of an AVP12, a single plug that effectively closed the defect completely. So, and this was the final 3D image. We have no leakage, which is particularly important in patients with hemolysis. You really want to achieve no leakage rather than reduction in the PVL severity. So transseptal punctures, they have evolved from the late 50s with Bono and with the Brownwell and Morrow when they first introduced it for left-sided hemodynamic measurements. But now we do a lot of things besides what INWI introduced in the 80s. We're doing now a lot of EP procedures. We're doing LA closure, valve-in-valve mitral, PVL closures, MitraClip procedures, nowadays transcatheter mitral valve repair. So this is an expanding armamentarium, and it will only increase as we go on. This was the initial description by INWI back in the early 90s. And I can tell you, when you're doing structural interventions, this doesn't really help a lot because you really want to establish specific entry points or specific sites for your transseptal puncture, be it posterior and slightly upwards for mitral clips, or posterior and inferior for LAA closure, or anterior when you're dealing with slightly lateral defects for PVLs, for instance. And we can still go through the fossa when we're doing hemodynamic measurements or mechanical circuitry support, or for balloon mitral valvuloplasties. So the lessons I personally learned is transseptal puncture is obviously being increasingly required for structural heart interventions, as well as EP procedures. Training and operator experience remain critical to minimizing complications. However, doing that without the proper guidance with TEE imaging or ICE is progressively becoming the standard of care rather than an added step. Co-registration with fluoro and echo, and we have a couple of good softwares on the market that can actually facilitate that. Now, with difficult transseptal punctures, the use of electrocautery or RF facilitated, dedicated RF facilitated transseptal punctures are very useful. We found electrocautery in particular very useful for very tough interatrial septi. steerable sheaths, which is something we're progressively using, can significantly enhance the accuracy and safety in difficult procedures. Thank you very much.
Thank you. Thank you, Dr. Ahmed, for this excellent case and challenging case. I have one comment regarding the needle from the start. We noticed that it was too high.
Yeah.
We did a lot of cases, hundreds of cases for balloon mitral valvuloplasty, and we almost always we are caring for the aortic root all the time. That's why we put a pigtail catheter in the aortic root just for demonstration and delineation of the aortic root. But it is an extremely rare complication. Maybe Dr. Bassem did one case like this several years ago. But if we go to the simplest resolution, is a pigtail in the aortic root and guided also by the TEA, and you did a good job.
Thank you, Dr. Hamdi. Excellent comment. The only thing I just want to highlight is, yes, when we're doing balloon mitral valvuloplasties, for instance, our standard is having a pigtail in the aortic root. But with structural interventions, especially with hugely dilated atria after cardiac surgery, it really doesn't add much. We just create an extra arterial puncture. And seeing everything, we're seeing everything on the 2D and 3D TEE, you establish a very clear understanding of where the septum is. And funny enough, I think Boray and Osman are here, and we did quite a few PVL closure cases together. And in some instances, you would have, and when we started off doing PVLs, we would routinely put a pigtail. Funny enough, you would see the pigtail, and you would see that the transseptal puncture site is actually 3 or 4 centimeters above the level of the pigtail. And when you check your 2D TEE, it actually is falling right in the middle of the septum. So yes, I would definitely say if you're doing this without echo guidance, having a pigtail in the aortic root, it's absolutely mandatory. But with the 2D and 3D TEE guidance, you have, I would say, a clearer understanding of the anatomy.
Ahmed, why you want to enter the left atrium? I didn't.
Paravalvular leak. We're crossing to close the PVL.
Thank you for sharing. It was a very nice illustration how to deal with this very serious problem. And I had a story of something like that, but with the transseptal needle, just we going to do a test, we find that we are doing a coronary angiogram. Fortunately, the patient went very okay and the hemodynamics was stable. So we go for doing the mitral and we finished the procedure. And finally, we had a coronary angiogram and it was completely, there is no shunting or whatsoever. So I'm asking you, what is the situation regarding doing a PCI or a stenting to the coronary before doing while the patient was stable? If there is any way to avoid this? Or
why did we put a stent?
Yeah.
It was a massive dissection and hematoma. Just,
yeah, there is an indication, yes. but the patient was stable.
Was hemodynamically stable for now.
But on
the IVUS images, we weren't really, we obviously have not faced this complication before, so it's not like I have a manual.
Yeah.
But when we looked at the IVUS images and just found the size of the hematoma, no one was really comfortable leaving it without a stent. But perhaps we should publish both cases.
Yeah.
Being extremely rare.
The old days before even the IVUS was really readily available in hands.
Ahmed, a quick question. I mean, I noticed that the TOE was in from the beginning.
Yes.
Why do you think then, if you're under TOE guidance, why do you think that happened? Of course, complications happen and it's easy to think why or not.
So you have an extremely talented echo guy, but because the atrium was hugely dilated, at some point we were all under the impression, we're not sure, have you crossed? I don't see you in the right atrium. But then again, the part at the vault of the left atrium was completely out of the field of view. So we tried following around, and at one point we weren't exactly sure. And this is why we opted for a tip injection.
Right, okay. And the second question is, when you saw the hematoma in the left main, did you use any cutting balloon or just stented?
I just stented.
Because sometimes the reason I'm asking, I suppose, in the acute situation, but sometimes you could paste the hematoma, even the aortic wall or down the stream.
But we would do that with CTOs, obviously comfortably, but this was a very uncharted territory for me.
Ahmed, congratulations for the wonderful case.
Thank you.
Actually, simple trick that we are always telling our young colleagues just to go to the needle first. Don't introduce the sheath. Once you are sure that you are inside the left atrium, push the sheath. Otherwise, you can pull the needle without getting any problem.
Sometimes, yes, sometimes we inject a little dye to be sure, and delineation of the anatomy of the septum.
This was exactly the cause of the problem here.
Yes,
but that is the same as CTO. When you cross with the wire, if you're not in the right place, you can always pull the wire, not a problem. The minute you follow to the microcatheter, you made the hole bigger. Yes. So that's the same in here.
Anyhow, thank you very much for Dr. Ahmed. We shift for the next presenter, Dr. Mahmoud Sabbah.
السلام عليكم. الأول I would like to thank أستاذي الدكتور محمد بيه عبد الغني ودكتور هشام بيه صلاح على الدعوة الكريمة إن احنا نبريزنت قدام الجامعة والقامات العظيمة دي، وأخويا طبعا دكتور كريم محمود. أنا عارف طبعا إن السيشنز دي very interesting especially في النايت ميرز، ولكن الكور فاليو بتاع أو الكور مسج بتاع البرزنتيشن how to conceptualize, understand, analyze and learn from the complication. وبالتالي my agenda today, first conceptualize the complication. We would like to introduce a new analytic approach, let's say, look like a PSAL approach, and we would apply a small case-based complication, and we would apply this PSAL approach. First of all, what is about the complication dilemma? كل واحد فينا لما بيقابل الكومبليكيشن في الكاس لاب هو ده الشعور اللي بيحس بيه. كل الحياه كل الناس بتروح رايحه على طول بقى في الاستريس والنيرفسنس، سكيري، ايه اللي هيحصل؟ طب انا مدخل العين كويس على رجله، هيطلع يموت، هطلع اقول ايه للفاميلي؟ ايه مشكلتي؟ ده انا كنت امبارح عمال انظر عليهم واقول لهم ده اعمل القسطره كده وحط الواير هنا وحط المايكرو كاستر، انا دلوقتي انا اللي عامل الكومبليكيشن والعيان طالع يعني خلاص باك تو داي يعني. والمشكله بقى ان الناس كلها بتبقى خلاص الاوبريتور والتيم كله ديستراكتد من الفوكس على العيان، ان هو يبقى فوكس على كل الافكار دي which is very bad things. طيب the reality of what we do، ممكن احنا نبقى زي الناس زي الحكيم ده حاطط لي سماعه وراجل شيك وبعمل ايكو واقول لك انا ما عنديش مشاكل، انا ما بتحصليش اي مشكله. طيب بس سيمبلي انت ما بتعملش كيسز. احنا انت ماشي في الشارع او حاطط راكن عربيتك في الجراج طول الوقت، فهي اكيد مش هتتحكي يعني. تمام. طيب التروث ده الفيري distinguished and seminal pioneering paper ديت very important top important. الدكتور روبرت دانينج اند كروجر خدوا عليها النوبل برايز في 2000، وده بيشرح الفكره ما بين ان اي حد يبقى نايف في الاول يكون عنده very important حاجه اسمها cognitive bias. يعني ايه cognitive bias؟ يعني الناس اللي هم في الستارتنج في الكارير they tend to overestimate overinflate their self assessment، ويقول لك ايه يعني ما انا قاعد في الميتنج وشفتهم جرب الواير دوت والدكتور احمد والدكتور مهند عدى مش ده ما نفعش، هات جايه راح معدي، لا ما جربش الجايه راح معدي، هات مايكرو كاست وهوب حصل كومبليكيشن. تمام. ولكن الشعور ده مع الوقت بيتند ان هو تو ليسن كل ما يبقى عندك انت مور اكسبيرينس، وبالتالي الناس اللي هم عندهم ان اكسبيرينس people who have limited awareness of their own competencies they tend to overinflate of their self abilities. طيب let's conceptualize the complication بقى بالراحه بس كده. احنا الكومبليكيشن عامه عشان نفهمها ممكن تبص عليها في الليتريتشر، والليتريتشر بتعرض لك كل الداتا اللي انت شايفها. هيقول لك ايه؟ هيقول لك ان انت who's at the high risk of complications. العيان بتاعك ده سيميلر للعيانين دول، ولكن انت عندك شويه سيميلاريتي بس a lot of variation. طيب لو انت عايز تبص بقى على عيانك انت بالتفصيل يبقى انت لازم تبص بشكل مختلف، تشوف الاكسبيرينسد جايز بيقولوا لك who's the most likely happen, how you can avoid this complication and how the complication happens. طيب في a lot of analytic approach you have to build in عشان تتعلم من الكومبليكيشن بتاعتك، بس احنا النهارده هنintroduce a new approach. What this stands for? BSAL approach. This stands for prediction. This prediction based on the literature عيانك at a high risk of certain category of patient at high risk of this complication. وبالتالي انت you have to prepare yourself certain maneuver, certain techniques, certain tools ان انت you have to prepare for this complication. يبقى انت متوقعها تحصل مع العيان ده at high risk of this complication. الحاجه الثانيه اي complication زي ما الدكتور احمد او كل الزملاء اللي شرحوا في immediate incident you have to search for. بعد ما تخلص وتقعد كده مع التيم بتاعك لازم تبقى انت عارف ان في immediate incident حصل قبل الكومبليكيشن بتاعتك. فور اكزامبل انت عمال تشد في الواير اللي هو ترابد او جيلد في بايفوركيشن او بتشد في البالونه اللي هي ترابد معاك، هوب القسطره راحت نطه رايحه لقدام ورجعت تاني والستنت بالون ريتريفد والدنيا اوكي. بعد شويه بتلاقي عيانك هوب هايبوتنسيف دايسكشن، هوب بتلاقي في عندك ايه ليفت مين في الاورت اوسيال ديسكشن. عمال تمشي التولز بتاعتك على المونوريل بالون والواير فار ديستال في الفيسل، وبعد كده انت سحبت وخلصت البروكسيمال، واحد قاعد في الكنترول روم قال لك اسحب الواير عشان الواير ديستال، اوكي خلصنا الدنيا وبعدين في الاخر احنا لاقيين ديستال. وبالتالي انت يو هاف تو ميتيكولسلي ريفايز الكورونال انجيوجرافي لان في immediate incident immediately حصل قبل الكومبليكيشن. الاستراتيجي لازم تريفايز كويس جدا زي ما الدكتور احمد شرح كده، احنا عملنا ايه ستيب وايز وايه اللي ترتب على ده من اوت كامز، وبالتالي انت هتتعلم من الحكايه دي. والادفايز انت ايه اللي ممكن تعمل ادفايز كومبيرد مع سيميلار كيسز حصلت مع ناس ثانيه وتصرفوا سيميلار واي اور ديفرنت واي، واللايف ليسون ليرند. لسه بقى ايه نطبق الكلام دوت على فيري انترستنج كيس. ده عيان محدش يحب يشوفه صراحه، يعني very old patient with cluster of risk factors, hypertensive, diabetic, COPD, multiple exacerbation. He had an event mostly STEMI 3 years ago where already كان no revascularization, but lastly he had recurrent attacks of angina. وبالتالي احنا لما اتعمل له ايكو اسكيميك كارديوميوباثي راح على سبيكت ان في عندنا فايبل LAD وستيل في تيريتوريال اسكيميا LCX RCA. تمام؟ طب let's revise الانجيوجرافي. very big left main وعندك ال LED proximal total occlusion وعندك occlusion edge ده more than 3 years or above. عندك nasty angulated severe OM disease. وال RCA diffuse disease angulated vessel multi vessel disease بالمنظر دوت وبالبروفايل ده. he was insistently forced ان هو يروح للسيرجري ولكن
محمود سوري ممكن بس السلايد اللي قبله لانه I don't think anyone has seen the retrograde filling properly.
No we have retrograde filling with very
واللي بعدها
septal and epicardial interventional collateral and you can argue that maybe a little bit not so long occlusion. طبعا offered السيرجري ولكن هو refused من 2 surgeons due to severe LV dysfunction and multiple comorbidities واتعرض تاني على جراح ولكن الجراح الثالث قال له لا ده دي فيري هاي ريسك بروسيدور احتمالات الوفاه عاليه واحنا عارفين برضو كلام الايه الزملاء الجراحين. وبالتالي هو العيان بقى اللي قال لك لا خلاص انا مش هروح اموت. بالتالي due to insistence of او persistence of recurrent anginal pain احنا قلنا ان احنا نحاول ان احنا نفتح له ال LED دوت واحنا ما تمكناش من الفيرست ترايل هنفكس الار سي اي ونفكس ال LED والفكس ال LCX وياخد ري ترايل كمان في ال LED ليتر اون. ده المنظر عشان حضرتك تقدروا لكم فاكرينه. وبعدين while we are preparing ourselves عشان نحقن بس البايلاترال انجكشن هوب هو المنظر ده وحش. طبعا الدراما ابتدت عيان يا ظهري سيفير نايف لايك بين و هايبوتنشن زي ما احنا شايفين فيري بيج اورتو اوستيال ديسكشن والفلو كومبرومايز. ده دراي سيمي. طيب في الاول لازم احنا نبص على الليتريتشر بقى واحنا عشان نتعلم من الكومبليكيشن بتاعتنا نبص على الليتريتشر. الليتريتشر بتقول ايه؟ اليو كي ريجستري في اكثر من 55,000 عيان وجدوا تقريبا حوالي 65 عيان بس في الاورتو اوستال ديسكشن which is maybe اقل من 1%. معظمهم كانوا في الار سي اي ومعظم الحاجات اللي كان انيشيتنج الايفنت معظمها في الاي ال سواء دايجنوستيك او جايدنج. ومعظم الاورتو اوستيال ديسكشن دول هاز بين تريتنج بيركوتينيوسلي. لو احنا قلنا في حالات زي سيميلار واي زي CTO هنبص على الدونر فيسل ديسكشن تقريبا 2% Similarly, الاورتو-اوستيال dissection 1.9 او 2%. طيب الكلاسيفيكيشن لو انت عندك في very limited Dunning classification 1 very limited aorto-ostial dissection زي المنظر دوت you can wait and see or even put a stent. ولو انت عندك الديسكشن ممتد up to 40 ملم للاورطه you can opt ان انت تحط الانتري ستنتنج. ولو الامور اكتر من كده بكتير هتوازن ما بين السيرجري وما بين ان انت تحط ستنتنج. وطبعا احنا عارفين العيان كان بيضحك من شهر ولا اي حاجه وعمال يتحايل على الناس وهيديهم فلوس عشان يفتحوا صدره. دلوقتي هو في حد هينقذك وبالتالي ما كانش في اي حاجه خالص غير ان انت تعتمد على عقلك ودراعك ان انت تفكس العيان ده. ده المنظر عشان حضراتكم ده انكم فاكرينه. huge aorto-ostial dissection with flow compromise واحنا عارفين ان ال دي هناك مش معانا اصلا. طبعا الحمد لله رب العالمين فورشنتلي انف قدرنا نمانج ان احنا نعدي واير وبعد كده سمول اسكليتنج بالونز ومش هو ده شغلنا الشاغل يعني عشان نتعلم منه. وبعدين في الاخر خالص حبيت احط عشان طبعا كل الدليفري بتاع المسج التولز ما فيش حاجه عايزه تعدي فحاولت احط بادي واير anyway يعني وي كود مانج ان احنا نعدي بيج ستنت عشان نسكيور الانتري سايت. الحمد لله فورشنتلي يعني قدرنا نحمل الانتري سايت. بعد كده حاولنا نمانج الديستال اللي احنا
ممكن دقيقتين كمان لو سمحت.
سوري 2 minutes only. يس دايليتيشن وبعد كده مانجد الحمد لله ان احنا نعدي انذر ستنت. وبعد كده ايه خلاص بقى ما فيش حاجه عايزه تعدي والعيان بقى ستيبل. هو عنده بس الشيست بين المورفيا يعني شغاله كويس. فوقفت في الكاس لاب كده انا والتيم وخلاص بقى احنا ايه نتفرج عليه كده ونبص عليه. طب خلاص الدنيا ايه ابتدينا ناخد نفسنا وانتظرنا ايه 20 minutes الدنيا اوكي. وانا قعدت بقى جبت كرسي وقعدت جنبه وبعدين انتظرنا 35 minutes العيان اوكي خلاص ليتس باك تو وورد او سي سي يو. وبعدين العيان ثاني يوم اتعمل له سي تي فيري ليميتد فلاب وديشارجت في على اليوم الثالث. وفورشنتلي انف هو دلوقتي ده ال6 مانثs فولو اب. لما الدكتور كريم كلمني ان انا اعرض الحاله فكلمته عشان اطمن عليه فالعيان بقى احسن من الاول وكأن ان هو فاقع الكومبليكيشن ما شاء الله. طيب لو عايزين نطبق البيسال ابروتش بقى نتعلم الحاله.
I hope that's not one of the lessons learned بس
دي الفوقه اللي قبلها. طيب ايه البريدكشن؟ عيان زي دوت طبيعي جدا انت عندك ار سي اي الليتريتشر بتقول لك كده ان الار سي اي الجايدنج الديب جايد سيتنج لا يبقى انت تاخد بالك جدا ان انت ايه هيحصل لك اورتو-اوستال ديسكشن. طب ايه الاميديت انسيدنت؟ ايه اللي حصل مع ناس كتير جدا بنحط فيهم ايه ال في تقديري انا ان تقريبا بروبابلي حصل انتر اكشن بين الاي ال والاي بي يو او زميلي لان احنا حاطين الاي ال ديت حاطينها فيه على الليفت فيمورال وهو بيحاول يحقن لي الكونترالاترال انجكشن شد القسطره بتاع الاي ال. واحنا عارفين انت لما هتشد القسطره بتاع الاي ال مور دايفنج فيه وهو ده او يبقى فيه ديب سيتنج او مع الانسبيريشن. طيب ايه الاستراتيجي؟ وايرنج بالوننج ستنتل وانتر ستنتنج والحمد لله عدى كويس. ماي ادفايس beware of AL movement beware of AL movement during RCA intervention and my life lesson ان انت لما هتشتغل في دونر فيسلز حط واير مش هتحتاج وما فيش عندك مشكله. انما لو العيان راح على ديسكشن انت خلاص بسرعه هتروح تلحق. and my tips to remember complications are inevitable. طيب don't fear to discuss your complication. ما تخافش حاول تتعلم منها. حاول تتناقش مع منتورز مع التيم بتوعك مع ناس experienced. والنقطه المهمه جدا ان انت you have to build up systematized and organized way of analyzing your complication. والنقطه المهمه ديت by the end of your day لازم تقعد انت مع التيم بتاعك. انت لعبتوا 10 15 20 ماتش سهلين وكسبتوهم ما انت بتعمل كورونا جيوغرافي بس هل انت كسبت الماتش الصعب ولا لا؟ هو دي النقطه. لازم تقعد انت هل احنا اتصرفنا صح ولا كان ممكن في الخطوه ديت نعمل حاجه احسن. and thank you.
محمود thank you very much. انا هقول comment بس and we'll give it to the floor. 67 years old is very old هتجيب لك كلام كتير. This is one thing that Mohana, do you want to go first?
Yes, actually it's a very good case and thank you. The point you're raising are absolutely important about because I think the difference between a good interventionist and a bad one is how you deal with complication, how you act in the cath lab. A case like this, I think I could add to what you're saying about the interaction. I think there's a huge injection. Somebody has had a very good breakfast or lunch. These AL are deep-seated in the artery, and you're injecting very hard. You could see the jet back always reaching the opposite side of the aorta. That sometimes can lead to these. And of course, the second thing is to try to avoid further injection. Of course, difficult when you're positioning the stent, and instead of continuing to inject all the time, you really have to manage with very little amount of injection and very little force, because the force is what leads to that. I've seen just recently, one of my colleagues did the same. And incidentally, JR4, I know that study from the UK because we took part in that. JR4 causes more dissection in the RCA more than AL. Yes. When you're coming from the radial, which is quite interesting because everybody thinks it's the AL. Of course, the AL, how you handle it, you're absolutely correct. It's an opposite direction. If you lift it, it'll dive in. If you push it, it'll come out. So, learning about this is quite important.
Muhannad,
it's causing more dissections because it's being used more, or was it per number of cases? Yes. It makes a huge difference.
Sure, it is not because of the number of cases. If you think about when you're coming from the radial, you're coming out, it'll come this one, you'll have to turn. So there's a little bit of more tension built in the guide, and the tension built in the guide, and you could easily dissect the right coronary artery.
Dr. Hani.
Thank you very much. Sharing those kind of complications is so important. And, especially you didn't seem to do anything wrong. It just sort of happened, My question is, there is obviously, thank God, a big element of barakah and luck in this case, as the patient did well. So, but what was plan B? Like if this patient did not do well, so you open the RCA and the dissection is getting bigger and he's still crashing. Do you stent the ostium of the RCA? Do you have a surgeon who is ready to take that patient, who's anticoagulated patients there and then? Do you put them in an intensive care unit and try to support them overnight? What is plan B if the barakah had not intervened and the patient was not doing well?
The barakah factor. Mahmoud, do you want to pick that? But Aslana, sorry, one thing that we always refer to, because it's such an understudied area in literature, is the Dunning classification. And it's absolutely rubbish. Just to say, this is أكتر من 40 millimeter, we send the patients for surgery, ignores the pathophysiology. This is not a vasculitis type disease where the intima will continue to separate. This is a hydraulic dissection. It is iatrogenic. It's a single focal point of entry. If you manage to close it, then patients do fine. In the CTO arena, I think the biggest series كانت جاية 13 or 14 patients من جلاسي, and only one patient died on the 7th day. علشان اللي حضرتك قلته, they failed to understand that this can progress. But it's important. ومهند قال كلمة مهمة قوي. One of the ways you can make things worse is while you're placing the stent, you continue to inject. You depend on IVUS on this situation. You put in a guideliner or a guide extension, and you do your positioning with minimal contrast. Obviously, avoiding it in the very beginning by looking at the pressure waveform before you inject can be of help. But once you run into it, the only two indications for surgery, and I speak out of having Muhannad Bitali شافها قبل كده, a huge dissection actually went all the way around to the descending aorta. This patient is 2 years now. We followed him with CT. لما وقت ما حصلت كانت 2 الصبح, and I called one of the foremost cardiac surgeons and aortic surgeons in the world. Do you still have any active leakage into the false lumen? And I said, no. Is the false lumen compressing the true lumen and leading to a hemodynamic compromise? And I said, no. Do you have any visceral organ malperfusion because of a dissection? I said, no. The two obvious first questions, and those will be the indications for immediate surgery, either AR or pericardial effusion. This means surgery. بس مجرد الديسكشن قد ايه is absolute rubbish. عشان كده بس أنا Dunning classification
I'm just trying to exploring something. By exploring this data, I want to deliver a message of conceptualize a complication and try to learn from correction in a systematized way. This is a message from the, maybe I did a lot of mistakes in this case or another, but this is systematized analysis for learning for the juniors, for all of us. This is a message. Back to reality. Practically speaking, what kind of this situation? You have a backup surgery and you will say, hello, okay, let's transfer this to OR. Forget about this.
في جراحين ولاد حلال برضو. And معنا, you have a tip, and I will say one last tip because the positioning is very tricky as well.
Yes, absolutely. I think it's a very important point you're talking about. You're learning from your failure and from complication. You sit down and look back. Now, almost invariably, probably 90–95% of the time, it's the operator has done something that was going to be okay or cut the corner. No question about this. There are, of course, patient factor. There are equipment factor. But it's us that we do because what happens. And it's important to sit down and look, okay, I shouldn't have done this or I should have. And you should have the courage to say, okay, we don't do everything correctly all the time. We learn from complication quite a lot. One thing I was going to mention about this, if sometimes one stent might not seal the dissection, you could put a second stent inside it. Yes. Then you're a little more secure to inject a little bit more. Yes.
Thank you, Mohammed. Mohammed, is the stenting mandatory? And what is the best policy to monitor such patients?
I mean, quite often, because if the artery is clear, i.e., there's no disease distally, and you still have a good flow. The cases that I've seen, they've always been stented, because it takes a kind of a brave person. Because I have seen cases where it was stented, but they continued to inject, and the hematoma became bigger, and then compressed the ostium despite the stent. So I think it takes a very brave person to say, I'm not going to stent. You could wait a little while and see if the artery is normal and the flow is still. The majority of us, I think 100% of people will stent.
I think it's one of the best things you can do is stop any flow into the false lumen. This is the aorta we're talking about, rather than the coronaries. So I would say, but what actually happens is after you stent, because the immediate hydraulic dissection creates such a massive radial force within a confined space, the intimal flap is pushed towards the aortic lumen. And what you initially perceive at the ostium of the right coronary artery is actually protruding 2 millimeters or more proximal than what you would expect. So one of the very common things is A, missing the ostium when you stent, but B, when it becomes very difficult and you have a funneling right coronary artery, there are a couple of occasions where we had to put in covered stents, FIBO, graft masters, and those usually did the job.
I was going to mention that in account because you don't want to complicate it too much. You're absolutely correct. It's how you stent it, and you should use a longer stent. Don't be afraid, because this is the case, because you have no idea where the dissection flap has taken place. Almost invariably, it's inside the about 5 millimeter or more inside the right coronary artery. So just use a longer stent. And if you need to put the second stent inside it, don't hesitate.
Thank you, Dr. Mahmoud, for this present. And now we shift to Dr. Sharif Sar for the next presentation.
ما هو كان موجود وبعد كده إذا ما كانش لسه. هو فين دكتور محمد؟ اتفضل يا دكتور محمد. رئيس المؤتمر يا بيدل قال لنا اعمل ايه طيب؟ معلش
هتنزود.
السلام عليكم جميعا. بحب أشكر دكتور هشام ودكتور كريم على دعوتي الكريمة، وبحب أبارك لهم على نجاح المؤتمر. برضو أحب أشكر الدكتور إبراهيم ياسين أستاذ مساعد القلب في الأزهر على مساعدتي في الحالة النايتمير دي. Dear Chairman, dear colleague, let me present my case today. My case is a gentleman, 61 years old, diabetic, hypertensive, heavy smoker. He has done a previous PCI to the proximal LAD in 2010 without any available data about it. And then he do coronary angio in 2018. Also, there was no any available data, but the patient was told to perform CABG and he refused and continue on medical treatment. The patient was presented to us by a recurrent typical exertional and resting chest pain in the last 3 months, despite of the maximum medical treatment. The ECG was unremarkable. The echocardiography revealed normal dimensions and systolic function, diastolic dysfunction, lateral anteroseptal hypokinesia, grade 1 mitral regurg, and TR. Creatinine was normal 0.9, cardiac biomarkers were negative, and the patient was dyslipidemic. And the plan was to perform coronary angiography that revealed the following. As we see here, أنا عندي مش شغالة.
هو محتاج يشوف برضه.
As we see here, there is a distal left main ostial critical LAD, in-stent restenosis in the proximal LAD with mid-circumflex critical lesion. From the different views to distinguish the lesions, AP and aurocranial, the spider view, and the RCA shows atherosclerosis without significant lesion. So the plan was to transfer the patient for CABG who was refusing from 2018 or to perform PCI, and what is our strategy to perform it. After discussion with the patient, and we was planning to perform PCI, unfortunately the IVUS was present in our cath lab, but it was not working that day. So we do the PCI without IVUS. That was one of the defaults of us. Two wires, one in the LAD and the other in the LCX, starting to fix the mid-LCX lesion with a large Zions 338 stent. Then opening the struts of the LAD with an NC balloon, as we see the tight ostial LAD. Then fixing, we was planning to do at first the complex PCI using the TAP technique at first. As we see, the angle is optimal, more than 70. So was planning to do it by TAP. As we see, optimizing the ostial left main with the floating wire technique to be ensured to covering the ostial left main in the LAO and AP cranial positions. Then post-stenting and flaring and pot has done. The second step is to rewire and to open the struts of the left main LAD stent and passing a balloon, then kissing balloon. Then something happened that was not recorded, and I will explain what happened now. Let me see what happened after that. We see a slipped stent trapped in the ostial left main stent. We see it all, sir? Yes? Okay, what had happened, and after rewiring and crossing the balloon and inflating the balloon, the wires was dislodged and rewiring again, but it passed very smooth into the LAD and into the LCX. And I was thinking that the wire has passed through the struts and through the normal ostium, but unfortunately it passed sub-struts. And without again using a balloon to ensure it's passed through the normal struts, it was fixed in the, trapped in the ostial left main stent, and with just gentle traction, the balloon and the wire was slipped again. And as we see here, that was the situation. So again, recrossing the wire and passing the balloon to ensure that the wire has passed through the ostial left main stenting. And the next step, what is the plan to treat such situation with the total stent loss? There is several maneuvers to track this stent. Shall we use a small balloon? But we, in this situation, we should keep the wire inside the balloon, inside the stent, inside the dislodged stent. But the wire was dislodged outside the stent, so the stent is alone without any wire inside it. And it's floating in the aorta, so it's very difficult to pass through.
So, sir, were you trying to deliver the stent to the circ?
Sorry?
Were you trying to deliver your stent to the circumflex?
How?
And that stent that's lost in the ostial, were you trying to deliver it to the circ?
Yeah, to continue the complex PCI. Shall we do stent deployment in situ, but it's in the aorta? Shall we distal push it into the LCX and deploy? Shall we snare using multi-wire technique, crush with another stent, or prefer transfer the patient for CABG? The only situation here that we try to do is the snare, as there is no wire inside the stent loss. So this is how to do the small balloon stent retrieval, but it's not our situation here. First, we tried to manually snare the dislodged stent, but we failed. So we used the peripheral snare to track the stent and to attack it, and we succeeded to attack it. But with gentle traction, it was fixed to the stent, and we was very afraid to do a huge maneuver to make a disaster. So we tried to remove the stent with pushing it in a different direction with gentle, very gentle traction, but it was unable to be dislodged. Another idea to take a balloon into the left main just to fix the stent to avoid making a problem in the stent in the left main with inflation and deflation and increasing the traction over the lost stent in several maneuvers with inflation and deflation. Finally, with more traction, as we see, thanks God, the stent was dislodged from the ostial left main stenting, and we ensure that the stent have been trapped inside the guiding and removed it. We do an angio to be sure that everything is okay. The patient was hemodynamically stable, alhamdulillah. Now, shall we continue on the same maneuver by continue using tap technique? By pulling the lost stent, there is assured that there is a longitudinal deformation in the left main stent. So we decided to change our strategy to perform a Kilot technique. So we use a stent left main LCX and continue the procedure. While continuing, as we see, another problem has happened, that the distal LAD has occluded by a depress or strut or thrombus, I don't know. The wire was rewiring of the LAD and tried to push it into the distal LAD, but it failed until crossing the struts of the left main LCX stent. There are two metal now. Finally, we succeeded to pass the balloon and just milking, open the distal LAD. Final kissing and final pot, and the patient was doing well, alhamdulillah, and we continue the procedure. So during complex PCI, your experience sometimes is not enough to take steps rapidly. Wiring of the side branch should be followed by passing a balloon before stent insertion to ensure that it's not a substrat. Your cath lab should be always well equipped for any emergency that could happen during any procedure, as Dr. Mahmoud Baraka has told us. And thank you very much.
Thank you, Dr. Muhammad, for this interesting case. I think in bifurcation techniques, it's very common to go when you are doing rewiring to go substratus. For this, it's very important to do a pot before rewiring, recrossing. So this is a well-known complication. If you have done a pot, it will save all of this.
We have done, but the balloon was 4, and in the final step, I used 4.5 balloon.
Okay. The second thing, I had a similar case before, and they have put a big balloon in the left main, inflated, and then pull the other stent by the snare. it has been cut down and pulled up safely.
That's what I have done.
Yeah, but yes, because sometimes it can change to a wire, like a wire.
Deformation in the stent already of the left main. We are very afraid from doing deformation in the stent. So you should make sure that you have the left main LAD stent to be safe by putting a balloon with inflation and deflation, so that you can fix it in position and you can trap it more.
Okay. Sorry, one of the way, which is the simplest way of making sure it doesn't go, you could use the main wire that you stented on to bring it back and cross into the side branch, so you know inside the strut, which is a very simple step to do. And that's what you get taught in bifurcation. Of course, I noticed that the wire was a little kind of bent, so might not work very well, but this is one way to make sure that you stay inside the stent.
Yeah.
Dr. Mohamed, do you have any recent news about the October trial regarding the OCT-guided PCI in bifurcation and complex lesions?
It is still ongoing. I think the recruitment will finish in about 2 or 3 months. It's one of the most complicated studies that I've taken part of, because it's like 100 million steps to an OCT. But it's good to give you the information that you want. The problem with bifurcation, I don't think there'll ever be a one step or one approach. It's always going to be different. Everybody's going to give you a different opinion. And that's typical of interventional cardiology, I suppose. You ask 3 cardiologists or interventional cardiologists an opinion, you get 4 opinions.
But you think it will give us more ideas about the performance of...
It will, and I think there's two more studies also ongoing at this stage also for bifurcation. Yeah. Exactly, because every study is performed differently, and I think we'll never have a final answer.
Mohammed, thank you very much. I particularly love the fact that it was obvious that the stent would have been longitudinally deformed after all the snaring and so forth. So readjusting your strategy to a QLOT after having faced the complication was a very wise step. Thank you very much. Dr. Hani.
Thank you very much. Again, it's very, very educational. Thank you. When we face complications, we think mostly about getting out of the room alive, the patient and us. But we don't think about long term. But this is a patient with a lot of metal in the left main bifurcation. The last cine slide we saw, even without using any form of imaging or stent boost, shows a clear waste on the left main LAD stent. Even there and then. Yes, and my expectations are that there's no way that this patient is going to continue to do well for any significant amount of time. So it's better to anticipate this and to, communicate a lot with the patients, because in Cairo University, like in Ma'had Al-Qalb, cost should not be that much of an issue like private centers. So this would have been a very good patient to IVUS after he stabilized.
Yes, we were planning
to look at the left main.
We were planning to bring him back for IVUS. Yes.
Yeah, because this patient is going to have very soon problems.
The problem with complication like this, he couldn't wait to finish and get out.
Yeah.
The thing is,
we all picked up how the ostium of the LED stent looked.
But that's typical because it's a reverse kilot, isn't it?
Before problems happen is absolutely a good idea. You're now out of the heat of the acute moment.
Yeah.
You've sweated it. You've owned your complication. You're showing it here. But bringing those patients before they run into problems.
I was going to mention that left main looked at least a 5 millimeter.
Yeah.
So between the Expedition 3.5 designs, which do not expand more than 4.
No. The 3.5 and 4 expands up to 5.6.
That's the Sierra. The Expedition doesn't do that.
Yeah. So for the sake of time, one last question from Dr. Mohammed Hosni before we move to our next speaker.
It's just a comment on the management of stent loss. When we have a stent loss, the use of multiple wires, I think it's not advisable when there is already deployed stents in the coronaries. because I have bad experience of stent loss while there are stents in the coronaries and passing the multiple wires technique. Unfortunately, after doing the twisting maneuver, the wire entangled into the already deployed stent.
Yes,
and this
is what the solutions, the available solutions to how to resolve such a situation. Not this situation, but a lost stent. I don't mention that these are the solutions in this situation. I was mentioning.
لا هو محمد بيقول
محمد
بيقول إنه اللي مهند اقترحه إن use the wire already there and the other will only make, not only will it make sure إن أنت you don't go substrate, but also you avoid introducing other wires, because sometimes with the introduction of new wires, when you have a stent in place and with the manipulation, you end up inadvertently getting stuck into the stent and pulling it all together.
So it's not advisable to do it by multiple wires if there is already a deployed stent.
Thank you, Mohammed. I think for the sake of time, again, excellent case. واضح إن موضوع stent loss is taking a toll. دكتور أحمد الحمراوي is around. Oh, Dr. Ahmed, where is the stent? I assume it was lost at some point.
Okay. Bismillah ar-Rahman ar-Rahim. Mr. Chairman, dear colleagues, it's my honor and pleasure to be with you today. I'm going to present also a case of stent loss. She is a 63 years old female patient presenting with recent onset of chest pain with a non-ST acute coronary syndrome with positive troponin. She had a history of a PCI to the LAD, which was done 15 months ago. She is having diabetes and hypertension. Her ECG showed T-wave inversion in the anterior chest leads, and the echocardiography showed a good left ventricular function with hypokinesis of the apical and mid-anterior lobes. Her labs showed normal hemoglobin and adequate creatinine clearance. The patient was sent to the cath lab, and this is her coronary angiography. You can appreciate having a paraosteal LAD tight lesion just before the previously implanted stent, and also there is a significant lesion in the ostium of the circumflex. In the cranial views, there is a significant progression in the ostial and proximal LAD disease compared to the procedure which was done 15 months ago. And in the LAD stent, the previous stent was patent. So we are having an ostial LAD and ostial circumflex, and the right coronary showed nothing. At that moment, we are quite sure that this patient is having an ostial LAD and circumflex lesions that should be fixed both. So we are going to perform PCI for the LAD, for the ostial LAD and ostial circumflex, but which strategy shall we perform? We started off doing a two-stent strategy, of course, by the crush technique for the circumflex first, and then to the left main LAD. So a 7 French guiding extra backup catheter and wiring of both branches with the floppy guide wires. And then pre-dilatation of the ostium of the circumflex. You can appreciate how tight is the ostium of the circumflex. Good luminal gain using an NC balloon. And then we started to do stenting for the circumflex while having a balloon in the left main LAD, which will be parked later on in the LAD to perform the future crushing. And while manipulating the stent to be adjusted in the ostium of the circumflex, we had this. The stent slipped into the left main, but fortunately, we have the guide wire in place. So the stent is lost in the left main, but still the guide wire is in place. What shall we do? We passed a small 1.5 millimeter balloon inside the stent and then gradually inflating the balloon and then trying to gradually retrieve the stent from the left main. We succeeded to retrieve it away from the left main and then removal of the whole system with the entrapped stent and the balloon down to the femoral. But unfortunately, the stent couldn't get out of the sheath. It was trapped in the common femoral artery. At that time, the patient started to have agonizing chest pain. We went through a left femoral puncture and we recannulated the coronaries again, and we tried to make it simpler by using one stent from the left main to the LAD 4x33 millimeter stent, and then doing a bot and flaring with a 4.5 millimeter balloon. And this was the final result with TIMI-3 flow in both branches. We stopped like this by shifting our strategy from the two stent to a single stent strategy. And then we went down to look for the stent, trying to retrogradely snare the lost stent. But unfortunately, we couldn't cross the iliac because the right iliac has a significant stenosis. And if you can see, the stent is not present in the common femoral anymore. By tracking the stent, it's now parking in the popliteal artery. So what shall we do next? Going back to the literature, this is the proposed algorithm by the Euro intervention group. If you have a stent lost in the cerebral or the carotid arteries, definitely it should be retrieved with a neurointerventionist. If the stent is lost above the femoral arteries, you can snare it. But like our case, if the stent is lost below the common femoral artery, you can use conservative measures. You don't need to do anything anymore. And the patient is now had been followed up for more than 2 years, and she is doing fine regarding her cardiac state and her right lower limb. Again, I would like to finalize and remind you with the different strategies that we can adopt while dealing with a lost stent. As we did here, we can use the gradual balloon inflation to retrieve the lost stent. If this failed, we can do one of both. If the vessel size is matching the lost stent, you can gradually deploy the stent in situ, or you can just push the stent with an inflated balloon to a distal site. And if this failed, you can do either snaring or you can use the multiple wire technique. And if all of these failed, you can crush the stent against the coronary wall and use another stent. But this should be the last choice when you are dealing with a lost stent in the left main. And thank you.
Questions from any questions? Very nice case, yeah. Very well done, and that tells you something that you keep it simple from the start. Yes. Is much better.
Yeah, keeping it simple from the start is a good option.
Yes,
yes, of course.
Any comments? Let's thank you, Dr. Ahmed. Thank you. Next speaker, well, Dr. Sharif Saqr, next nightmare, last nightmare.
بسم الله الرحمن الرحيم. دير كوليج مستر شيرمان، بداية شكري للأستاذ دكتور محمد عبد الغني والدكتور كريم على الدعوة، وبشكر يعني ببارك لهم على نجاح المؤتمر. ودايما نايت ميرز يعني بنتعلم دايما من النايت ميرز اوفر ذا بريفيوس ييرز. كريم لما طلب مني حالة، أنا كنت مخلص كل حالات النايت ميرز بتاعتي في المرات اللي فاتت، فما فيش بقى الا حاجة يعني بدور على أي حاجة نكدت عليها في القسطرة، فما لقيتش إلا الحالة دي. فده male patient aged 55 years old, hypertensive, diabetic, dyslipidemic, presented with unstable angina, history of BCI of LSX 3 years ago, mild CKD with serum creatinine 1.6, hyperuricemic, the ECG average normal with sinus risk, Echocardiography show fair global ventricular function with resting segmental wall motion abnormality. The angio revealed that the left main was free from stenosis. LED show mid-tight stenosis. LSX was dominant with a stable plaque, about 70% stenosis. This is a tight lesion in the LED. The right coronary, non-dominant, diffusely diseased, non-stentable, non-graftable. The decision to do BCI of the LED after wiring, balloon dilatation, a stent with the 2.25 stent, then I decide to do post dilatation. I check for the position of the balloon 2.5 to check for the post dilatation. I find there is no flow in the artery. I don't know any explanation for this. What I do, I try to withdraw this balloon. I withdraw it with some resistance. Then the resistance is lost. I get it. I find this picture. One of the assistant inflates the balloon by fault and don't tell me without contrast. And no contrast, and the balloon was inflated. This is angio after withdrawal of this balloon, dissection at the edge of the stent. I think he inflated at high pressure and the larger size, edge dissection at the end. At this moment, the patient was sweaty. Check for blood sugar was hypoglycemic, start glucose 25% IV. After a while, the patient developed VF with fluid discharge from the mouth. VF was reverted by DC shock with restoration of circulation and consciousness. Intravenous Lasix was given and the patient stabilized. Then I try to rewire. There is a very difficulty to rewire this stent. That's because the stent underdeployed, not properly apposed over the wall of the vessel. It is undersized. The second, the direction of the ostium of the stent away from the direction of the wire. After several trials to pass the wire, it behind the struts. Then I succeed to pass from the behind the struts, then re-enter from the middle of the stent to the true lumen. My strategy to crush the stent by a CTO balloon, 1.2 balloon to open the struts, then 2.0 balloon to crush, then NEC 275 balloon to crush. After crushing, I will stent. This is the first stent, was 2.25 by 32. Then NEC post dilatation by NEC 2.75. Part of the first stent is not covered by the second stent. I decided to put a third stent to jail or to cover all the crushed stent. This is the last stent, 3.0 diameter. And this is the final result. The second case, male patient, 56 years old, hypertensive diabetic, presented with unstable angina. Past history BCI with LED 8 years ago. ECG was average normal, echo fair, normal systolic function with no resting wall motion abnormality. This is a coronary angio, show the focal non-significant atheroma, eccentric atheroma, proximal ostium of previously deployed patent stent. This is regarding the left system. Right system, right coronary show two consecutive tight lesion in the mid right coronary with proximal non-significant atheroma. I decided to do BCI for this right coronary since it's a Calvert lesion by ambulance caster to good support, wire, balloon dilatation. Be sure that it's okay. In the first stent, 3.5 by 38, properly positioned, dilate, and this is the result. I get another stent, 4.0 by 38. When I get the second stent, what happened? Sometimes with the ambulance caster, the system get out. While deploying the second stent, system get out. I recannulate the right coronary. I try to pass the wire. While I try to pass the wire, I find this is happening. When I pass the wire, I find the resistance just by simple tracking by the wire. The wire was tightened to the struts and bring the struts and broken by simple traction. I find this. The same also recannulate the patient in agony or in chest pain at this moment. I try to, by the same tricks, to pass the wire anywhere. The task in the wire distally in the lumen of the stent and in the lumen of the true lumen of the artery, even behind the struts. Several try by different wires, and they try to pass is 1.2 balloon. I use 1.2 balloon. By several trial, I failed to succeed to pass the balloon. I don't know what's the course of the wire till finally I succeed. This is a trial by more than wire and try to pass the wire but the balloon not pass. I try to use the balloon to crush the opening, the entry of the wire from behind the stent. And I failed several times till lastly, fortunately, I several re-enter the wire from other way. Fortunately, I succeed to pass the wire and 2.0 balloon pass freely with dilatation along the whole course of the previous deployed stent. Then I introduce the second stent safely, inflate the second stent, and lastly, I do this overlap. It's very important. This overlap at bus freely. With this picture, the linear dissection in the distal right coronary, this is after deployment of the third stent, and linear dissection, non-flow limiting in the distal right coronary. And this is the end result. Take-home message, always keep BC wire as long as the procedure is not completed. Be cautious with ambulatory caster while stenting the proximal artery not to disengage the artery. Crushing of previously deployed stent is an accepted technique if the wire passes behind the struts. And thank you.
Any comment? Thank you very much, Dr. Sharif. Any comments from the floor? Questions? So I think with this, we conclude this session. Thank you, everyone. A wide variety of interesting complications. Thank you for your time. Thank you.
Now it's time for chronic coronary syndrome session. May I call Professors Jamila Nasr, Hani Ragi, Sharif Saqr, Tagreed Hilal, and my dear colleague, Professor Amr Hassan.
Yes. Okay, we have a little bit of delay, but I think we can catch up. This session is about revascularization in complex coronary stenosis. Our first, I welcome my colleagues here, and first case will be Dr. Nabil Farag, insights from guidelines.
Okay. Thank you very much, Dr. Amr, for the introduction. First of all, I would like to thank my dear friend, Dr. Mohammed Abdelghani. طبعا he's my brother actually, for inviting me for this nice meeting. دكتور هشام صلاح أنا يعني أحب برضو أشكره لأنه هو كلمني في الأول، وهشام إحنا علاقتنا متميزة ببعض. هو الموضوع يبدو يعني one of the hot topics، إحنا a lot of debates about this، هي revascularization in chronic syndromes. وانا هتكلم على mainly two guidelines. او guidelines هي myocardial revascularization دي كانت in 2018، والسكند guidelines هي chronic syndromes in 2019. Let's go كده. Actually this is a presentation دي presented in the European Society of Cardiology guidelines in 2019, and actually the agenda discussing the general indication, assessment of hemodynamic relevance and the importance of this, especially in patients presenting with chronic syndromes, choice of revascularization modality, if indicated, whether to go with transcatheter intervention or CABG, and my take-home message. I will start my introduction actually with a question about which statement of this is incorrect. Revascularization improves prognosis over optimal medical therapy in patients with left main stem and proximal LAD. This is correct or not. To assess hemodynamic relevance of intermediate grade stenosis, either FFR or IFR can be used to assess the hemodynamic significance. Also, this is correct or not. In patients with multivessel disease, this is a very important part. Patient with multivessel disease and reduced LV ejection fraction. By reduced LV ejection fraction, we mean that an ejection fraction of 35% or less. Viability testing, and take care of this. Viability testing is mandatory to assess potential benefits of myocardial revascularization. Let's go to the...
Shall I reply? Do you want one of us to reply to the question? Or?
Yeah, please.
Okay.
Yes.
I think the statement which is incorrect is number 3.
Yes, it's true.
Because we do not need to test for viability if the patient is in heart failure, yes, according to the latest guidelines based on the outcomes of the STEACH trial.
Yes. And this is the evidence. I will go through this. Thank you, Harry, for your comment. I will go through this. Number 1, if we go to the general indication of intervention in patients with chronic syndrome, the first indication is definitely in patients with left main, significant stenosis or stenosis of more than 50%, or proximal LAD. The second indication is patient coming with heart failure due to ischemic heart disease, and they have a multivessel disease, either 2 or 3 vessel disease. The third indication is if we have a large ischemic burden, more than 10% by radioisotope study. And the fourth indication, if we have still symptoms or anginal symptoms in spite of optimal medical therapy. Let's go first to answer the first statement, whether intervention for patients with left main or proximal LAD will benefit or not. And this based on an important systematic review and meta-analysis. And this found that in patients with left main stenosis or proximal LAD, revascularization, whether by CABG or transcatheter intervention, significantly lowered mortality versus optimal medical therapy. So revascularization has a great benefits in such patients with left main stenosis or proximal LAD. This is number 1. And number 2, if we compare PCI versus CABG in such patients with isolated distal left main or proximal LAD, actually there is no significant difference as regard the composite of death, stroke, or MI, and both can be done in such patients. The second indication is heart failure with multivessel disease, 2 or 3 vessel disease, and as Dr. Hani mentioned, and this STEACH trial, and it's a long-term follow-up of this STEACH trial comparing CABG with medical therapy, and they found that definitely CABG is superior over medical therapy as regard primary endpoints, which is this and this from any cause. So revascularization in patients with heart failure and ejection fraction of 35% or less and multivessel disease is indicated even without viability. So if we go to the second part of this study, which is a sub-study as regards viability assessment, the assessment of myocardial viability actually did not identify patients with differential survival benefit from CABG as compared with medical therapy alone. So this patient actually don't require assessment of viability if they have heart failure with a multi-vessel disease. The third indication, if we have a large area of ischemia as assessed by radioisotope study, and actually the cutoff point of this ischemic area is 10%, and this found to identify patients who benefit from revascularization. And now we have this very important trial, which is ischemia trial. And ischemia trial, if we go this comparing initial invasive versus initial conservative treatment in patients coming with stable coronary artery disease or chronic coronary syndrome, and this included more than 5,000 patients, and this was stable patients with moderate to severe ischemia. So they included even patients with ischemic burden of more than 10%. And they randomized to either invasive strategy plus medical therapy or conservative strategy plus medical therapy. The conclusion of this study was that in such patients, stable coronary disease with moderate or severe myocardial ischemia, an initial invasive treatment strategy did not prevent either net recurrent events or net total events more effectively than an initial conservative strategy. The fourth indication of revascularization is symptoms, the presence of anginal symptoms despite an optimal medical therapy. Again, we go for the ischemia trial, and this is one of the conclusions of this ischemia trial. They found that we don't speak about mortality, we don't speak about morbidity, but we are talking about quality of life. We're talking about symptoms. So based on ischemia trial, patients with stable coronary disease and moderate to severe ischemia had significant durable improvements in angina control and the quality of life with an invasive strategy if they had angina. In patients without angina, an invasive strategy led to minimal symptom or quality of life benefits as compared with conservative strategy. And in patients with angina, shared decision making should occur to align treatment with patients' goals and preferences. And if we go to the guidelines, and this is the myocardial revascularization in 2018, this is the indication for revascularization in patients with stable coronary disease. At that time, it was called stable coronary disease, but this changed in 2019 into chronic coronary syndromes. The main indications based on anatomical or functional assessment for prognosis. This is different from, this is very important if we are doing intervention to improve prognosis as regard mortality. So left main stenosis with a stenosis of more than 50%, proximal LAD more than 50%, 2 or 3 vessel disease with stenosis of more than 50% with impaired LV function again, and large area of ischemia detected by functional testing, or single remaining patent coronary artery with stenosis more than 50%. But here we have to have a documented ischemia or hemodynamically relevant lesion defined by either FFR less than 0.8 or IFR less than 0.89, or if we have a stenosis of more than 90%. Definitely stenosis of more than 90% will not require hemodynamic assessment, and we will go directly for intervention in such lesions. As regards symptoms, as regard improvement of symptoms, again, the class 1 recommendation level of evidence A, and this again in the myocardial revascularization in 2018, hemodynamically significant coronary stenosis in the presence of limiting angina or angina equivalent with insufficient response to optimize medical therapy. This is another indication for revascularization, either with CABG or with PCI, and this again, class 1 level of evidence A. What about assessment of hemodynamic relevance, whether to use FFR or IFR? Let's go to the Sweetheart study and define FLAIR. Comparing IFR with FFR, they found that no difference between both as regard the functional assessment of lesions, moderate lesions. That's why we can use either IFR or FFR for hemodynamic assessment of moderate lesions. And this is again the European Society of Cardiology Guidelines 2018, myocardial revascularization. When evidence of ischemia is not available, either FFR or IFR are recommended to assess hemodynamic relevance of intermediate grade stenosis. وهنا المقصود بintermediate grade stenosis up to 90%، يعني لغاية 90% بيعتبروه intermediate stenosis. أكثر من 90% we can go for intervention. And again, in a patient with multi-vessel disease, this is a famous trial comparing PCI in multi-vessel disease, comparing angiographically guided intervention with FFR guided intervention, and definitely the conclusion was that angiography alone was insufficient in selecting lesions in multi-vessel disease. That's why in patients with multi-vessel disease, we have to do functional assessment for such lesions. And based on the guidelines, when evidence of ischemia is not available, FFR or IFR are recommended to assess hemodynamic relevance of intermediate grade stenosis, and FFR guided BCI should be considered in patients with multi-vessel disease undergoing BCI. As regards choice of revascularization, whether CABG or PCI, this will depend on 4 important factors. The first is a surgical risk. And for the surgical risk, we have to use an STS score to assess the surgical risk of the patients. Second, disease complexity. And for disease complexity, we can use a Centex score. Third, completeness of revascularization, whether by PCI or CABG. Sometimes CABG may not be able to do a complete revascularization. So completeness of revascularization is very important, and the presence or absence of diabetes. These are the 4 important factors we have to look at when we decide to choose between either PCI or CABG. And again, this is a commendation as regard choice between PCI and CABG, assessment of surgical risk. And by assessment of surgical risk, we have to use STS score. Assessment of disease complexity, we can use the Centex score. And this is, again, very important, is the last one when considering a decision between CABG and BCI, completeness of revascularization should be prioritized. And this is based on the presence or absence of diabetes. And this is a 5-year all-cause mortality after BCI versus CABG according to diabetes disease and disease type. And unfortunately, single vessel, 2 vessel, 3 vessel, left main, it seems that CABG is superior over PCI in all diabetic patients based on this study. And if we go to the guidelines again, in a patient with multi-vessel disease, without proximal LAD, definitely BCI will be superior over CABG. But with proximal LAD, both BCI and CABG are equal with class 1 recommendation. In patient with 2-vessel disease, again, without LAD, in this condition, BCI is superior over CABG, but with proximal LAD, both PCI and CABG has class 1 has class 1 indication. As regards 3-vessel disease with diabetes, in this condition, we have to look at the Centex score. If the Centex score is low, Centex score 0 to 22, so both PCI and CABG is a class 1. If Centex score is high in this condition, BCI is class 3, is not recommended in such patients. In the presence of diabetes, even with low Centex score, BCI is class 2A and CABG is class 1. This means this shows the superiority of CABG over BCI in all diabetic patients. And again, in patients with suitable coronary artery disease, suitable anatomy for both, and low predicted surgical mortality to look at. This is my take-home message. Again, if to look at the indication of BCI in patient coming with chronic coronary syndromes, the presence of left main or proximal LAD is one of the indication. Heart failure in the presence of 2 or 3 vessel disease causing this heart failure. Large area of ischemia, still large area of ischemia of more than 10%, and symptoms despite optimal medical therapy. And this is my last slide, and this is decision tree for patients undergoing invasive coronary angiography. First, we have to look at if there is angina symptoms or not. If there is angina symptoms, second, we have to look at the presence or absence of documented ischemia. If we have angina symptoms and documented ischemia, and we have a multi-vessel disease, in this condition, BCI guided by FFR or functional assessment is very important to do this.
If we don't have multivessel disease, but we have a documented ischemia related to the artery that has a significant source in this condition, we can go for revascularization on top of medical therapy. But if we have angina without documented coronary artery disease, 3 indications. First, if we have a stenosis severity of more than 90%, go directly for intervention. If we don't have such stenosis, it's less than 90%, we can use FFR or IFR again. And if the FFR is less than 0.8 or IFR less than 0.89, this is an indication for intervention. And if we have an LV ejection fraction of 35% or less due to coronary artery disease, in this condition, we don't have to do this functional assessment and we go directly for intervention. The second part, if we don't have angina, asymptomatic patients, but we have a documented ischemia, and this documented ischemia is a large area of more than 10%, we go for revascularization. But if we don't have documented ischemia, again, we have to look at severity of the lesion. If it's more than 90%, go for intervention. If less, go for functional assessment. But if we have heart failure, we can go for revascularization directly. Thank you for attention.
Thank you very much. As usual, very elegant presentation. Professor Nabil, you know, there is ups and downs for looking for viability. And there, as you know, on real ground basis, apart from the guidelines, there are many ways to look for the viability by single photon emission computed tomography or dobutamine stress or other MRI and so and so. And it was proven from the recent studies like the clinical trials, STITCH and HEART, that it has no prognostic evidence in some
patients with heart failure.
Yes. In real ground basis, and if you would like to Egyptianize the guidelines, what will be your recommendation?
Thank you, Dr. Jamila. طبعا this is a very important question, but actually it's very difficult to answering it الحقيقة. يعني for Egyptian patients, أنا myself I will do the same. يعني هو اللي أنا قلته ده بالضبط أنا اللي هعمله في my patients. إنما إحنا actually we don't have the database or the statistics ان احنا نقدر يعني ان احنا يبقى عندنا different decisions or different algorithms or different guidelines that we can make it for our Egyptian patients. We don't have this. That's why myself I'm following this.
I had actually a question in the same direction.
Yes.
But would you, when you say heart failure, it could be compensated heart failure. And then patients with compensated heart failure on medical treatment and multivessel disease, would you look at them the same, a group with ejection fraction 40% and another group with ejection fraction below 20% or 20% and below? I would imagine there would be a room for functional or viability studies in the lesser ejection fraction group, at least in terms of prognosis from the outcome of revascularization, if we're talking about surgery. There could be, I'm sure there will be subgroup analysis in this study. I haven't looked at the study in detail, but if you take the group with dilated ventricles, ejection fraction below 20%, I believe viability studies will still have a role in at least prognostication of the outcome of surgery. Would you agree with that?
Yes. دكتور عمرو طبعا ده يعني احنا مثلا لو if we go for مثلا valvular lesions guidelines هم لما بننزل عن ejection fraction less than 30% especially مثلا in patient with severe mitral regurgitation هنا الديسيجن فور سيرجري بيبقى very doubtful وان احنا we go for surgery or whatever mitral valve repair in such patients if they still symptomatic in spite of optimal medical therapy. This is an example بالظبط اللي انت قلته ان هم patients عندهم heart failure and ejection fraction of less than 20 طبعا less than 20 that's a very high risk patients for surgery and have a multivessel disease. Actually وده برضه study كانت ischemic cardiomyopathy وهم ما حددوش بالظبط يعني at what level of ejection fraction نقدر not to interfere مش زي الفالفولار هم محددين الايجيكشن fraction
يعني ايه الليفل اللي احنا نقدر نتدخل فيه وايه الليفل اللي احنا ما نتدخلش فيه او ان احنا نعمل حتى ترانسكاستر ريبير. طبعا فاليد ان احنا لما يجي لي عيان يعني ejection fraction of less than 20% وهارت فيلير ومالتي فيسل ديزيز. But I think لو هو is compensated, if a patient is compensated لأن definitely البيشنت اللي عنده 20% وcompensated definitely he has a viability. هو ما فيش حد 20% وعنده multi vessel disease without viability definitely will benefit. عشان كده هم قالوا دول هيستفيدوا من الجراحة. وهنا الاسسمنت اوف viability حتى ما هو يعني هنستفيد بيه بمعلومات ايه؟ هيقول لنا areas of viability او areas of non viability وانهي areas، يعني هل ده هيبقى جايد للجراح at the end who will need surgery؟ هل ده هيبقى جايد للجراح يحط جرافت على انهي ويسيب انهي؟ برضو عايز اقول ان الفايابيليتي ستاديز دي ما هياش accurate 100%. يعني احنا شفنا حالات بتبان ان هي non viable وبستاديز تاني بتطلع فايبل. مثلا لو عملنا بريجو اسوب ستادي طلع نون فايبل، لو عملنا بالبيت او بالكاردياك ام ار اي بتطلع فايبل. يعني في حتى a lot of discrepancies as regard assessment of viability by different tests. القصه ان هم العيانين دول will benefit from surgery as long as دول هم compensated، وان احنا to deprive them من الاوبشن ده يعني ممكن يعني هم susceptible ل more deterioration because of the presence of the cause. احنا يعني ما تعاملناش مع الكوز نفسه.
وانا عندي كومنت برضه حضرتك ان الايجكشن فراكشن نفسه misleading، لان في وجود البريزنس اوف سيفير mitral regurg الايجكشن فراكشن از اوفر استيميتد. يعني احنا لو لقينا عيان عنده ايجكشن فراكشن 40% مثلا وعنده سيفير mitral regurg actually الايجكشن فراكشن از true around 20%. يعني it means that التول اللي احنا بنستخدمها it is not right.
وهو الجايد لاينز دكتوره جميله، انا عايز اقول حاجه برضه، هي الجايد لاينز لما بتقول في المايترال ريجيرج او سيفير مايترال ريجيرج تقول لك ال في ديسفانكشن and ejection fraction of less than 60%. يعني بيعتبروا سيفير مايترال ريجيرج ال في ديسفانكشن less than 60% مش less than 50%.
Thank you very much, Professor Nabil. I think this last presentation was so important because it should really shape our practice. In Egypt, we have قوائم الانتظار بتاعت وزارة الصحة, which we're looking at officially now, and I can tell you that more than half the patients based on this presentation probably do not need revascularization and can do very well with medical treatment. So maybe we should direct our resources to the acute cases and to other cases. So thank you very much.
Thank you.
Very, very informative presentation. It gives me a great honor, number one, to thank the Cairo University for inviting me to be here today. I'm truly honored by being in the meeting of the oldest university in our part of the world, and certainly the oldest and most established, well-established cardiology department, Cairo University Cardiology Department. And then it gives me special pleasure to introduce the next speaker, our host, Professor Mohammed Abdelghani, who's a scientist and a dear friend, who's gonna continue in the same session in chronic coronary syndromes. And as we know, the name has been changed from stable angina to chronic coronary syndromes for many good reasons. Professor Abdelghani is going to talk to us about PCI, basically percutaneous coronary interventions, versus bypass grafting in multivessel disease. Professor Abdelghani.
Thank you, Mr. Chairman. اسمحوا بس لي ان انا اشكر حضراتكم جميعا. انا عارف النهارده يوم طويل وان احنا متواجدين لحد دلوقتي، ده يعني شرف كبير الحقيقه لاسم القلب في القصر العيني. احنا على مدى الاسابيع والشهور اللي فاتوا عملنا حاجات كتيره، عملنا مايوكاردايتس داي وعملنا كاردياك ريهابيليتيشن داي، والحقيقه النهارده مميز الانترفنشن، وامبارح دكتور هشام صلاح الحقيقه عمل فيه مجهود كبير. احنا بندعوكم الاشتراك كمان في بقيه المؤتمرات العلميه بتاعتنا. احنا الاسبوع الجاي عندنا سبورت كارديولوجي داي، اللي بعديه عندنا كروس توك، الدكتور محمد الرملي عامل كروس توك مع اقسام التشيست والنفرولوجي والنيرولوجي في القصر العيني. عندنا حتى في رمضان عندنا كاردياك جينيتكس داي، وعندنا كمان كاردياك اونكولوجي داي، وعندنا كمان دكتور هاني مخصوص كاردياك اميليدوزس داي. عندنا برنامج حقيقة حافل جدا، فأنا بدعو حضراتكم جميعا للاشتراك مع كلية طب القصر العيني في الأيام العلمية القادمة. Dear colleagues, السؤال المهم، عيان عنده مالتي فيزيت ديزيز، يا ترى أبعته يعمل جراحة ولا العيان ده هو ممكن أحط له دعامات؟ خلونا نتفق إن الترايلز كانت واضحة. most، وأحط تحت كلمة most دي خطين، most of the trials متفقين إن الكابج has the ability to reduce risk of repeated revascularization more than PCI. وكمان الريسك of myocardial infarction in some trials كمان أقل مع السيرجري. لكن few trials هي اللي كانت بتقول إن السيرجري أحسن regarding السرفايفل. تعالوا مع بعض كده هو نشوف ليه الترايلز فرقت بيننا وبين زملائنا في جراحة القلب. لما نقارن البي سي اي فيرسس كابج، في المدة القصيرة بتاعت الكابج احنا عندنا risk of death more, infarction more stroke, renal failure, bleeding, need for transfusion, infection, prolonged intubation, and prolonged recovery. This is the fact of life, open heart surgery. لكن لما بنقارن في الترايلز خصوصا في العيانين اللي عندهم دايابيتس، بنلاقي البرايمري كومبوزيت اند بوينت لا in favor of cabbage. ليه؟ معظم الحقيقة الأرقام الحلوة دي بتيجي من myocardial infarction less. Survival slightly better، لكن definitely فيها عندها more stroke. Cabbage leads to lower all-cause mortality than with PCI drug-eluting stent in long-term follow-up. دي كانت الفريدم follow-up on trial في 2019. مش بس الفريدم، كانت الإكسل كمان جابت نفس النتيجة. لا، السرفايفل أحسن مع الجراحين. لما حبينا نشوف السرفايفل أحسن بقد إيه، لقيناه 6 شهور بس. وكمان في الفريدم ترايل كانت واضحة، لما تقعد تتابع العيان بتاعك 8 سنين، الجراحة هتطول عمره 3 شهور بس. يبقى لما نقول survival benefit احنا بنتكلم على شهور محدودة. السينتكس كانت واضحة، السينتكس كانت عملت 10 year follow up، لا مفيش فرق. survival benefit واحد من الاثنين، no difference in mortality in syntax trial. يبقى واضح ان في جاب بين البي سي اي وبين الكابج. How to close this gap؟ ازاي احسن السرفايفل في العيانين اللي حضرتك بتحط لهم مالتي فيزل ستنتنج؟ لا اما حاجه لها علاقه المورتاليتي بالستنت ريليتد ايفنتس، او حاجه لها علاقه بالنون ستنت ريليتد ايفنتس اللي هي دي نوفو ليجنز. مش كده؟ العيان بتاعي هيحصل له ايه؟ لا اما حاجه لها علاقه بالدعامات اللي انا احطها، لا اما اماكن جديده خالص. الحقيقه معظم الترايلز اللي ورت سرفايفل بينيفيت مع الكابج كانت بتستخدم early generations of drug-eluting stents، وكان كمان عندها lower rate of FFR والIFR guidance، وكان عندها low rates of imaging guided. ما كانش بيستخدموا الايفاس الا باعداد بسيطه من الحالات. وكمان كان الكونسبت بتاع الكومبليت ريفاسكولارايزيشن ما كانش موجود في الترايلز دي. معظمها كان incomplete revascularization 57% في السانتكس والبيست والبري كومبات ترايلز. يبقى انا من خلال النيور جنريشنز اوف دراج eluting ستنت ومن خلال الاوبتمايزنج البي سي اي سواء بالايفاس او بالاف اف ار او بالكونسبت بتاع الكومبليت ريفاسكولارايزيشن ممكن احسن السرفايفل، والعيانين اللي يعملوا بي سي اي يبقى السرفايفل موازي للكابج. طيب هعمل ايه في الدينوفو اسكلروزس؟ احنا كمان بقى عندنا بيتر ميديكال تريتمنت، بقى عندنا اوبتمايزيشن الميديكال تريتمنت. حضرتك عندك انتي بليتليت ايجنتس اقوى، عندك حاجات اقوى، عندك كمان BCSK9 inhibitors، عندك ستاتينز، انت اوير بالجرعه المظبوطه اللي ممكن تديها. كل الحاجات دي هي ممكن تخلي تحط العيانين دول على اوبتيمم ميديكال ثيرابي ما كانش موجود قبل كده. انتوا لو عايزين تعرفوا النيو جينيريشنز دراج الوتنج ستنت عملت ايه؟ لا عملت في الايزار تيست فور ال 10 year mortality فرق between الاولد سايفر and the new science 22%. في التاكسيدو لما بتتكلم على التاكسس versus نيو ساينس كانت الارقام برضو واضحه. انا بتكلم على السرفايفل على فكره 4.3 versus 2.5 cumulative mortality على مدى 1 year. فبتكلم على كابج versus new generation drug eluting stent. النيويورك ستيت كاردياك ريجستري عملت 4-year follow up new generations drug eluting stent versus كابج. حضراتكم تقدروا تشوفوا ان السرفايفل كان almost similar. بص للبي فاليو. لو ما هتتكلم على ستروك لا، كابج بيشنتس جالهم مور ستروك في نيويورك ستيت كاردياك ريجستري. مايوكاردال انفاركشن يس كان اكتر مع البي سي اي، لكن لما عملوا سب اناليسيز وشافوا العيانين اللي اتعمل لهم كومبليت ريفاسكولارايزيشن الام اي كان سيميلر between everolimus stenting versus cabbage. يبقى الكونسبت بتاع complete revascularization ده مهم جدا in reduction of myocardial infarction among PCI patients. ده النيويورك ستيت كاردياك ريجستري death stroke myocardial infarction في complete revascularization patients almost similar. Repeated revascularization yes definitely أكتر مع ال BCI patients compared with CABG patients. يبقى احنا لما نرجع نقارن بقى الجاب اللي كنا بنتكلم عليها between BCI and CABG في التسعينات كنا بنعمل بالون اونلي. الكابج الجاب كانت كبيره، قلت شويه مع البير ميتال، قلت شويه مع الفيرست جينيريشن، بقت نون سيجنيفيكانت مع السكند جينيريشن دراج الوتنج ستنت. البيست ترايل برضه كانت بتقارن بي سي اي نيو جينيريشنز فيرسس كابج، لقت ان لما حطينا ديث انفارشن ريفاسكولارايزيشن الكابج كانت احسن. لما شلنا الكابج وحطينا ستروك لا، كانوا الاثنين زي بعض. بيست ترايل. ان دايابيتس كمان نفس الكلام، ما كانش في فرق regarding الديث ولا regarding composite endpoint of death infarction and stroke. Still repeated revascularization was better among CABG patients. فعلا احنا كده الامور بقت واضحه. لما اتكلم على الكابج معناها ريسك اوف ستروك اكتر، لما اتكلم على بي سي اي معناها ريسك اوف ريبيتد ريفاسكولايزيشن. فانا لازم اختار يجي لي ستروك ولا اعمل ريفاسكولايزيشن. كانت في سيرفي ظريفه جدا قديمه شويه، سالوا المرضى، قالوا لهم تحبوا تتعرضوا للستروك ولا تعملوا ريفاسكولايزيشن؟ طبعا معظم المرضى قالوا لا، احنا مش عايزين الستروك. الناس اللي بتشتغل في الترايل ما فضلتش الستروك. الجايد لاينز الحقيقه ان شورت كانت واضحه في وجود عدم وجود الليفت مين، وفي وجود ايجكشن فراكشن اكتر من 50% تريبل فيزل ديزيز، ولما الاثنين يبقوا سيميلر الاثنين خدوا نفس الجريدنج في الجايد لاينز. الحقيقه this is my conclusion. Evidence from observational study and randomized trials show similar mortality between CABG and second generation drug-eluting stent BCI. The decision about CABG versus BCI should be based on ability to completely revascularize your patient, weighting short-term risk of death and stroke with CABG and long-term benefit of reducing risk of repeated revascularization, and finally, patient preference. Thank you.
Thank you very much. Thank you very much, Professor Mohammed. If none of my colleagues have anything urgent to I'd like to thank you for the meeting. I think the message is very clear. And what we need to do is to know the guidelines, but we also need to improve the quality of what we're providing to the patients. So we can talk as much as we want about PCI or bypass, and then go in and do suboptimal procedures with smaller stents than the vessel of the artery, or stent arteries which don't need stenting, or use a lot of venous grafts, not to use a lima, or not to use arterial grafts, or use grafts that will crash and cause problems to the patients in a short amount of time. So the data has to be applied to us locally. And for instance, let me give an example, Cairo University. It's very difficult for a cardiologist to go into Cairo University cath lab and do a deliberate bad procedure like in a private hospital. There are too many layers of protection for the patient, okay? And the same in the big hospitals in Ain Shams University, in Mahad al-Alb. We need to make this available to all Egyptian patients in Dar Fuad as a private hospital in Salam. The patient is protected by those multiple layers of protection, assuring good quality, assuring that somebody who is training is supervised enough so that no patient will be harmed in the procedure. So following the guidelines and the recommendations is something, and considering every single patient a relative and a very precious and important patient that should receive the best standard of care is another story. So how can we overcome this? I mean, in a country of 100 million people like Egypt, with hundreds of new small cath labs and small hospitals performing surgeries, how can we control the quality? How can we provide the Cairo University quality on a national level?
أنا هتكلم على تجربتنا في القصر العيني، ويمكن الدكتور نبيل يكلمني على عين شمس. الحقيقة إحنا مش مسموح لحد يعمل انترفنشن في الكاث لاب unless إن هو يكون معاه الام دي. وحتى بعد ما بياخد الام دي هو بيبقى سوبرفايزد لمدة 6 أشهر أو أكتر، وبعد كده هو بيبدأ يشتغل لوحده. ما بيعملش برايمري بي سي اي إلا بعد ما تظهر عنده يعني السكيلز اللي تسمح له ان هو يعمل برايمري بي سي اي. احنا كل يوم في الاسبوع، كل يوم حد، دكتور محمد الرملي بيشرف على سيشن اسمها auditing for primary BCI intervention. بنشوف كل الحالات البي سي اي اللي اتعملت وبنقعد نراجعها مع بعض. فيرتشوال طبعا لان كل واحد بيبقى في حته. بنحاول نضمن كواليتي معينه، بنحاول نعمل سيلف كريتيسيزم، ما بنحاولش ان احنا نضايق اي حد بيشتغل، بس ان احنا بنناقش. بنعمل ام ميتنج every other week، دكتور محمد عادل هو اللي مسؤول عنه، والحقيقه برضه ده بيبقى مهم جدا. فهو السيستم ان احنا لما نحط سيستم بنحاول ان احنا ما بنقولش ان احنا يعني احنا بنحاول نحسن من نفسنا. معرفش دكتور نبيل.
احنا برضو في مشكله كبيره. انا من ساعه ما يعني ما جيت رئاسه القسم كان اهم حاجه من ضمن الحاجات الحمد لله قدرنا نعملها هي سوفت وير فور داتابيز، ونجحنا وان شاء الله والسبريد ده لكل الاقسام بعد كده، لان السوفت وير دي غاليه جدا بتكلف كتير، بس قدرنا نجيبها بطريقه غير مكلفه. طبعا شركه هي سبونسرنج ده، وهي وعدتني ان احنا والسبريد ده في كل الاقسام. السوفت وير ده الهدف منه ايه؟ مش ان احنا يبقى عندنا ريجستريز او ان احنا يبقى عندنا ريسيرش او كده. السوفت وير ده ان احنا نعرف احنا بنعمل ايه، نعرف الكومبليكيشنز بتاعتنا ايه، نعرف الديفكتس الحقيقيه اللي موجوده عندنا ايه، نعرف الكومبليكيشنز بتاعت كل واحد فينا. ممكن انا اكون بشتغل كتير جدا وشكلي بشتغل كويس بس عندي كومبليكيشن ريت عاليه. وانا دايما بقول لهم الامريكان كولج اوف كارديولوجي عامله حاجه اسمها كاس لاب ستاندردز. كاس لاب ستاندردز دي منها ان هي بتاسس وبتيفالويت كل دكتور بغض النظر الدكتور ده الرانك بتاعه ايه. ان شاء الله رئيس القسم بيعملوا تاني ري اسسمنت في نهايه السنه، بيشوفوا الميجر كومبليكيشنز بتاعته.
بلاش رئيس القسم.
بيشوفوا الميجر كومبليكيشنز، بيشوفوا الماينر كومبليكيشنز، وهي ليها برسنتج معينه. البرسنتج دي لو اكسيدد رقم بيقولوا والله احنا السنه دي هتشتغل از فيرست اسيستنت، يعني مش هتبقى انت المين اوبريتور. الحاجه الثانيه بيشوفوا السنتر اللي هو يبقى كواليفايد يعمل برايمري. ما هو السنتر يبقى كواليفايد يعمل برايمري لازم يكون بيعمل عدد معين من الاساطر كل سنه، وعدد معين من البرايمري. والبرايمري دي لان الناس متخيله البرايمري انترفنشن ده ايزي بروسيس، ده هو ده بتاع الكومبليكيشنز، هو ده بتاع المورتاليتي، هو ده بتاع النوري فلو، هو ده بتاع الكارديوجينيك شوك، هو ده بتاع كل حاجه.
والعيان ملوش شويس، العيان ملوش
فالمفروض زي ما قلت دكتور محمد، المفروض اللي يشتغل برايمري ده يبقى ويل اكسبيرينسد اوبريتور ويكون بيشتغل برايمري كتير، يعني غير ان هو بيشتغل كمان الكتيف لازم من ضمن الكرايتيريا يكون بيشتغل برايمري. احنا بالداتا بيز اللي احنا بنحاول ان شاء الله نعملها، احنا لغايه دلوقتي احنا دخلنا 150 عيان، اتس اوريدي ستارتد خلاص، دخلنا 150 عيان. يمكن نعمل زي بريس كونفرنس كده في اخر مارس على ان ده هيبقى يعني هيروح كل الاقسام. انا عايز اعرف معلومات عن شغلنا، عايز اعرف معلومات عن اللي احنا بنعمله. افتكر ده فور ذا كواليتي. احنا برضو لازم تعرف كل واحد بيعمل ايه وبيشتغل ازاي عشان حتى تحسن. انت عايز تحسن الدكاتره اللي بيشتغلوا زي ما قلت كده بطريقه طبعا يعني فيري بولايت، وان احنا بنمونيتور وبنأوديت النتائج بتاعت الدكاتره. والاوديتنج ده فيري امبورتنت، مش عيب ان انا تأوديت على حد، لان احنا في الاخر ما يهمناش الا المريض والنتائج بتاعتنا. فده برضو من ضمن الحاجات، بالاضافه طبعا الويكلي كونفرنس اللي احنا بنعملها. تيتشنج اذا تيتشنج كونفرنس اللي هو الموربيديتي ومورتاليتي اللي هي الايكو، حاجات تعليميه كلها. وفي نفس الوقت البرايمري انترفنشن اللي بيتعمل، احنا برضو عندنا، انا يعني عندي في القسم دكتوره نيرين متوليه الموضوع ده، بتتابع بتشوف المورتاليتيز وبنراجع حاجات كتير جدا، بتعمل ستاتستكس كل شهر. احنا معانا كام حاله برايمري، الكومبليكيشن بتاعتنا عامله، دي كانت ماشيه قبل ده. فالاوديتنج والكونتينوس اوديتنج ده على الديبارتمنت ده فيري امبورتنت. وانا طبعا بشكر الدكتور محمد، وافتكر ان احنا ممكن نحط الكرايتيريا السنترز بقى اللي تشتغل يعني، بس دي تبقى حاجه احنا محتاجين السبورت بتاع الجفرمنت. يعني مش يعني انت محتاج سبورت ان انت تقول السنتر ده يشتغل والسنتر ده ما يشتغلش، عشان فعلا في سنترز المفروض ان الحقيقه ما تشتغلش، المفروض حتى ما تعملش قسطره. دول بيعملوا اوبن هارت، بيعملوا حاجات طبعا، وحتى الكواليتي بتاعت الحاجات اللي بيستعملوها تبقى كواليتي مش كويسه، ودي بتبقى في الاخر على نتائج المريض. فافتكر احنا بنبدا حاجه محتاجين سبورت بتاع الجفرمنت بتاعت الوزاره، علشان ان احنا تؤودت بقى على مصر كلها، على السنترز كلها، ونقول مين السنتر اللي اشتغل ومين السنتر، ونحط الستاندردز دي. الستاندردز دي تطبق على كل الناس، على كل الدكاتره بغض النظر
هو مين ولا ايه ولا كده، والستاندردز دي لازم تنفذ، وده يشتغل وده ما يشتغلش بيزد على شغله وعلى نتائجه وعلى الكومبليكيشن ريت بتاعه.
هو this is طبعا this is easier done in university hospitals, but there are probably many patients that are done outside university hospitals in private centers or government. And I think there should be always 3 levels of thinking of how to improve outcome. One of them is preemptive, yani who does the procedures. And this, I think every hospital has to have a privileging committee to decide who is allowed to do certain cases and who should not. At a level of evaluating outcome, and mainly the complicated cases, there should be a morbidity and mortality committee or an auditing committee which discusses what went wrong and how to prevent it, rather than to point a blame or point a finger on who did what wrong. And there is another level in between which should optimally, ideally, be in every complex case. ما تبقاش الحالات بتتعمل ad hoc. In complex cases, you should do the diagnostic, and then you call on the heart team, which involves many people. And in these complex cases, by definition, the best man should be available to do the job. So if the patient has a CTO that has to be open, then this person who's most experienced in CTO should be available during the procedure. If there is a calcified lesion and you're going to use shock therapy or a rotablator, then one person should have, or more, should have a vast experience in this particular technique to be available during the procedure. Of course, these are theoretically, they should be done, but it's more difficult to really implement them in every center if we want to assure the best outcome for our patients.
هي في معهد القلب القومي كمان في سيشن ويكلي هارت تيم سيشن. دكتور هاني يمكن انا حضرت قبل كده سيشن جامده جدا بين اطباء القلب وجراحه القلب، واحنا نقلناها من اليوم هارت تيم. انا عارف انها شغاله الحقيقه، دي من الحاجات القويه جدا. احنا كمان نقلناها، احنا بنعمل افري اذر ويك هارت تيم سيشن مع الجراحين. الدكتور وليد عمار بيبقى مسؤول عنها، وبرده ما حدش بيعمل CTO كيس ولا كومبلكس كيس الا مستعرض على اللجنه دي.
هو حضرتك انا برضو اعتقد لازم نعمل ليفل للكاث لابس في مصر. يعني انت ما ينفعش ان يبقى كلها حاجه اسمها كاث لاب، ولازم يبقى في تشيك ليست. التشيك ليست دي تنقسم الكاث لابس بمستواها. يعني لو انت هتعمل CTO مثلا، المفروض يبقى عندك another كاث لاب. ما ينفعش ان انت في مستشفى كبيره يبقى، يعني اقصد ان احنا وي ان احنا نعمل ستاندردايزيشن وليفلنج حتى كل الكاث لابس، وده يبقى بيزد على ستاندردز علميه.
يمكن دي فرصه كمان هني حضرتك والدكتور نبيل بعضويه مجلس اداره جمعيه القلب المصريه. والحقيقه دي فرصه بقى ان احنا كل الامبلمنتيشن اللي احنا بنتكلم عنها تبقى من خلال حضراتكم في الجمعيه. الجمعيه ممكن يبقى ليها دور الحقيقه كمان في الستاندردايزيشن بتاع الكاردياك كيث والبروسيدور نفسها.
انا كنت لسه هطلب ده الحقيقه. شكرا لحضرتك على المحاضره الجميله. الاوديتنج للكاث لابس اللي موجوده في اماكن كتيره في الجمهوريه، اعتقد لو طلبنا من الجمعيه المصريه للقلب يبقى لها دور في الاوديتنج او الايفالويشن للكيسز او السنترز دي. نشوف البروتوكول يتعمل ازاي او الدنيا تمشي ازاي. I think this is essential. نقطه ثانيه عايزه اقولها، احنا بنقول PCI versus CABG. في الغالب البيشنت بريفرنس هي اللي بتبقى ending the story. فانا برضو بقول البابليك اويرنس او الاديوكيشن للبيشنتس والفاميليز is essential، بحيث ان احنا لما هيسهلوا دورنا احنا في الاختيار او في ان which one to be applied. يعني
May I add something?
تفضل دكتور.
I would like to share بس my experience الحقيقة. الكلام اللي اتقال ده كله حقيقي جميل جدا، يعني يقدر ينفذه يا عمرو كمان، لان هو يعني ماي اكسبيرينس من فرنسا عندهم حاجتين. عندهم كوميتي اللي هو اوديتنج كوميتي كانت فيها ماري كلود موريس اب تو تروح لاي حته وتقول له انت طبقت ده، يقول لها انا حطيت 2 ستانس. حطيت ليه 2 ستانس؟ ما انت عندك الجايد لاينز. هتقف عن الشغل وهنحول اب تو كده. ومراكز كبيره نفس سان جورج. وبعدين الحاجه الثانيه اللي هي الاكسلنسي سنتر، اللي هو يعني اونري موندور اللي كنت شغال فيها كان فيها ليزر، الباقيين ما عندهمش ليزر، فكان بيحولوا لنا الحالات واحنا نحول لهم الحالات اللي احنا ما نقدرش عليها. والكوميتي دي مش هتحتاج غير الافراد الموجودين دول بالظبط يعملوا كوميتي وهم اللي ليد الحاجه، مش محتاجه يعني حاجه كتير. ثانك يو.
Thank you very much, Dr. Muhammad, for arranging this excellent meeting and for this excellent lecture. Thank you very much. We close this session now. وفي session تانية ولا خلاص كده يا دكتور محمد؟
Our last session of nightmare عندنا أنا أدعو بقى الدكتور محمد زهران، دكتور نبيل، تشير بيرسونز. محمد تشير بيرسون ولا ماشي؟
لو هنقلب تكست من هنا تكست يمين.
عبد الله. This is our last nightmare session. احنا هنديهم، احنا قاعدين. هم احنا طيب خلاص. طيب انا عايز هنعمل شوية تعديل كده في البرنامج. هندي سيمبوزيوم بتاع شركة سيربيه وسنوفي، وبعد كده هنستأنف آخر last session of nightmare.
تمام اوكي يلا. اوكي لا المحاضرة قدامك اسمها. مساء الخير. احنا مستنيين التشير بيرسونز يطلعوا.
لا مايك بقى وحاجات كده.
دكتور كريم اعتدنا منهم دايما النجاح، والحمد لله على السلامه من اللايف، كان حاجات يعني مرعبه. الحمد لله على السلامه. منين؟ دكتور هشام دلوقتي هيكلمنا على الاتشيفنج LDL جول a new player in town. اتفضل دكتور هشام.
Thank you very much for your kind introduction. طبعا احب ارحب بحضراتكم وبعتذر ان انا ما كنتش قادر ابقى معاكم هنا فيزيكالي من اول الميتنج، بس معانا طبعا رئيس القسم دكتور محمد عبد الغني. احنا بنبدل مع بعض كل شويه، حد يروح وحد يجي، فاحنا ستيل ذا لايف ترانسميشن، بس شكلنا مش هنخلص قبل 9 بالليل اللايف هناك، لان عندنا still many cases، وبرضو some of the cases need anesthesia, or some of the cases need some sorts of intervention. The topic I'm going to give is يعني I think it's interesting. It's achieving LDL goals a new player in town، لأنه في دواء جديد نازل، والدواء الجديد دوت الشركة مهتمة بيه جدا، وليهم حق، لأن الجايد لاينز قاعدة بتتغير، والأرقام بتاعت ال LDL that we want to achieve are becoming lower and lower. And I think with the current medications present, it may be difficult to reach such goals. أنا عجبني الستيتمنت دي: save one life you're a hero, save 100 lives and you're a doctor. ودي الحقيقة. انتوا كلكم هيروز، دي بالنسبة لي أقل بكتير من الحقيقة، لأنكم انتوا كلكم قاعدين بتشتغلوا وبتعملوا حاجات بتنقذوا مش مئات الأرواح بس آلاف وآلاف الأرواح. النهارده لو تشوفوا في الكاث لاب وازاي ان الناس كلها شغاله as one team, it was really something nice يعني. وكمان ان احنا عارفين ان الديسليبيديميا حاجه من الحاجات المهمه جدا التي تسبب الوفاه. فبس just to highlight the importance of the topic، الحقيقه ان 13 scientists who have researched cholesterol have received Nobel prizes. بس just to highlight the importance of the topic. والحقيقة with 110 products for dyslipidemia in the market, we have to ask ourselves, do we really need a new player ولا لا؟ وإذا كنا محتاجين new player, why do we need it؟ وعلشان إيه يعني؟ مجرد يعني أدوية قاعدة بتدخل، ولا فعلا في a real difference between such medications؟ بس لازم نبقى فاهمين that still the number one killer across the globe is cardiovascular disease. It claims approximately 18 million lives a year. احنا حاليا في 2022 and we are expecting that this will continue. أعداد الوفيات من cardiovascular disease are on the rise. دي لأن عندنا ناس أعمارها بتزيد، وعندنا أمراض كانت زمان بتموت early، دلوقتي لأ، بنقدر ننقذ هؤلاء المرضى وبيعيشوا أطول ويحتاجوا يبقى عندهم مشاكل أكتر وأكتر. والحقيقة إن إحنا we are having a real disappointment. إحنا الديسابوينتمنت جاية من كذا حاجة، ومن ضمنها داتا جاية لنا حتى من أوروبا، دافينشي ستادي. الدافينشي ستادي دي بينت لنا إن كتير جدا جدا من العيانين بتوعنا almost half of the very high risk patients were prescribed not high intensity statin as we should be expecting, but they were given moderate intensity monotherapy, which resulted in LDL goals which are definitely not within the goal. والحقيقة برضو that more than 60% of high-risk patients were also prescribed moderate intensity monotherapy, which resulted also in definitely less than optimal LDL goals. وتاني نقطة برضو لازم نحطها في الحسبان، مش بس إن في inertia من الدكاترة to prescribe the proper doses of statins for patients who are indicated. لا، إحنا عندنا مشاكل أخرى، بس هي الحقيقة مش مشاكل، هو الحقيقة إنه الجايد لاينز اتغيرت، وال LDL goals at least in those who are at a very high risk has been got down to 55 milligram per deciliter or lower. والجايد لاينز الحقيقة واضحة جدا. الجايد لاينز بتقول إنه the higher the risk of the patient, the lower you want your LDL cholesterol to be. وبالتالي الناس اللي عندها very high risk زي العيانين اللي عندهم coronary artery disease or peripheral vascular disease or strokes احنا عايزين يكون ال LDL كوليسترول بتاعهم below 55. الناس اللي at high risk only بس not very high risk عايزين ال LDL كوليسترول ينزل ب 50% على الأقل وال LDL كوليسترول بتاعهم ينزل تحت ال 70. والجايد لاينز موضحة ده very clearly. بس يمكن في ال 2019 جايد لاينز اللي نزلت كان في statement مهمة بالرغم ان هي it received the 2B recommendation which was that for patients with atherosclerotic cardiovascular disease who experience a second vascular event within 2 years of the first vascular event, they were recommending that the LDL goals should be considered to be below 40. It's a 2B classification معناها انه مش لازم تعملوا كده ولكن اكيد احنا حاليا حاطين ده في حساباتنا ان العيانين ان ال LDL كوليسترول بتاعهم still حتى في حدود ال 55 and still they are getting vascular events, we should be considering lowering the LDL cholesterol lower and lower. طبعا تنزيل ال LDL cholesterol لتحت ال 55 أو تحت ال 40 is very challenging. وبالتالي I'm not expecting in many of the patients in which we are giving even high intensity monotherapy إن احنا نبقى reaching ال LDL goals. ناهيكم عن إنه في نسبة من العيانين لما بترفع الدوز ممكن يتولريت دوز مثلا اتورفاستاتين 40 ولكن لما بترفع ل 80 ممكن تلاقي السايد افكتس اعلى واعلى. ممكن يستحمل روزوفاستاتين 10 او 20 بس لما بترفع الدوز ل 40 you may be getting more side effects. وبالتالي الجايد لاينز are becoming more clear. The second immediate line if you did not reach goals with the high intensity statin is to add ezetimibe. الحقيقه انه مش بس كده القصه ما بقتش كده انه هو واخد كلاس 1 level of evidence B. القصه بقت كمان انه العيانين دولت انك المفروض بالذات مثلا في عيان عنده acute coronary syndrome if you have ditulistatin high intensity if you did not reach the goal within 4 to 6 weeks you should be going in with ezetimibe. ما بنستناش 6 اشهر ما بنستناش سنه. You have to do this fast. ده لازم يتعمل خلال 4 ل 6 أسابيع. بعد 4 ل 6 أسابيع تانيين if the patient is not at goal you have to escalate. Maybe you may be considering a therapy which works on the PCSK9. ابتدى كمان في 2021 و2020 ان يبتدي يبقى فيه some other new concepts وابتدوا يفكروا هل المفروض نبتدي from the very beginning using medications combination medication. انتوا عارفين طبعا انه في الهايبرتنشن حاليا اصبح ان معظم العيانين بتبتدوا combination therapy. مش شرط نبتدي بمونوثيرابي except في الالدرلي قوي او الناس اللي عندها ضغطهم just very mildly elevated. غير كده الرول انك تبتدي بcombination therapy. Having this in mind ابتدت الناس برضو تفكر انه يمكن برضو المفروض انك انت تبتدي بcombination therapy في نسبة كبيرة من العيانين ان لم يكن معظم هؤلاء المرضى انك تبتدي لهم بكومبينيشن ثيرابي. وابتدت تبقى في بيبرز بتتكلم على هذا الموضوع وبتتكلم على انه maybe in patients having cardiovascular disease انه في مجموعه من العيانين هو at extremely high risk. احنا عارفين طبعا يعني ايه very high risk بس كمان العيانين اللي هم at extremely high risk زي مثلا العيانين عندهم polyvascular disease او عندهم multivessel disease او عندهم complications اخرى ممكن تفكر انك انت تبتدي لهم from the very beginning by using combination therapy. ونفس الكلام بالذات في العيانين الاكيوت coronary syndromes ان ابتدى نزل position paper endorsed by the International Lipid Expert Panel ودولت الحقيقه برضو they recommended انك انت ممكن تفكر تبتدي بcombination therapy from the very beginning في العيانين اللي انت لا تتوقع انك لما تديهم monotherapy high intensity that you will be lowering LDL cholesterol to the levels you want. ويمكن ده ظاهر جدا في اليوروبيان جايد لاينز اللي نازله بتاعت الديسليبيديميا اللي موضحه انك if you use high intensity statin the utmost that you should be expecting is to lower the LDL cholesterol by 50%. But mind you انه تقريبا ربع لنص العيانين اللي انت بتديهم high intensity statin and you're expecting ان ال LDL cholesterol بتاعهم ينزل by 50%، الحقيقه ربعهم لنصهم ما بيوصلش التنزيل بتاع ال LDL cholesterol ل 50%. بعضهم بينزل 50%، بعضهم بينزل حاجه و60%، بس في بعضهم برضو نسبة مش قليلة ما بنقدرش ننزل بالال دي ال كوليسترول بتاعهم لل 50%. ويمكن بقى في نفس الجايد لاينز اللي نزلت قالوا ان الهاي انتنسيتي ستاتين plus ezetimibe you should be expecting a lowering of LDL cholesterol by approximately 65%. وهنا بقى يجي our new player. هو اسمه لايبوكومب، وانا عاده ما بحبش اقول اسم التجاري ولكن الحقيقه هو يستاهل انه يتقال. لايبوكومب دوت عباره عن روزوفاستاتين بلس ازيتامايب، ونازل حاليا في تركيزين 10 10 و20 على 10. 20 مللي جرام روزوفاستاتين وازيتامايب 10 مللي جرام. طبعا لازم نسال نفسنا why did they choose this combination؟ واشمعنى روزوفاستاتين؟ لان روزوفاستاتين للي ما يعرفش كان نازل على انه كان اسمه ايه يا محمد يا عادل لما نزل؟ لا كان اسمه ايه يعني الماركتنج بتاعه منزلينه على انه ايه؟ ميري. كانوا منزلينه مسمين حاجه غريبه جدا، كانوا جايبين صوره جوريلا ومسمينه ده جوريلا ستاتين على اساس انه ده الوحش الكاسر اللي نازل يكسر السوق. فالحقيقه انه هو اقوى واحد من الادويه التي تستخدم حاليا في الستاتينز that lower LDL cholesterol. وحتى في الاستادي اللي باينه هنا الوحيد اللي معدي ال 50% LDL reduction is the rosuvastatin. ويمكن احنا كمان لما بندي combination مع ezetimibe مع rosuvastatin we may be expecting up to 63% reduction in LDL cholesterol. رقم كبير جدا، بس اعتقد ان في نسبه كبيره من العيانين خاصه مع lower and lower goals that we are using we are actually expecting ان احنا هنبقى محتاجين جدا ان احنا ندي هذا الميديكيشن في نسبه مش قليله من العيانين بتوعنا، خاصه ان احنا ككارديولوجيست احنا عاده ما بنتكلمش غير على الهاي انتنسيتي ليبيد لورينج ايجنتس وليس فقط على الهاي انتنسيتي ستاتينز. احنا عارفين طبعا ان superior combination in lowering LDL cholesterol that there are 4 times more LDL reduction and twice as many more patients at goal when you combine ezetimibe added on high intensity statin. ليه؟ لان احنا عارفين الرول ان لما بتدي ezetimibe additional بيحصل reduction of 20 to 25% more LDL cholesterol reduction، ولكن اما بنعمل doubling of the dose بيحصل a 6% reduction for each doubling of the LDL cholesterol. Maximum cardiovascular protection is achieved أكيد بالذات لو العيان compliant, and one way of increasing the compliance of the patient is to give combination therapy. فهنا الداتا دي ظريفة جدا مبينة if you are on a high intensity statin and you are adherent to this medication اللي هيحصل that there is a 40% reduction in cardiovascular events. على عكس الناس اللي هم on high intensity but they are not very compliant you will be having only a 10% relative risk reduction of cardiovascular events. ويمكن كمان فكرة انك تدي separate tablets of ezetimibe plus statin versus انك تدي combination therapy انك هتلاقي انه the adherence is significantly even it's almost twice more adherent patients to this treatment if you give a single pill combination عن لو انت اديت just 2 tablets separately. والحقيقه يعني الشركه فخوره قوي بال such product. ليه هم فخورين قوي بهذا الكومبينيشن؟ ان هم شايفين that the success of actually producing this type of tablets which needs a very characteristic method of production ان هم حاسين ان this is actually a great success. ليه؟ لان rosuvastatin ezetimibe is a hard capsule formulation, it's a gelatin capsulation. ايه اللي بيحصل بقى في القصه ديت؟ يمكن الفيديو ده يبين هي عباره عن حاطينها الكومبينيشنز الثانيه اللي مستخدمه روزوفاستاتين مع ايزيتامايب اتس ا باي لاير كومبينيشن. هنا ما عملوش كده، هم استخدموا حاجه ثانيه خالص، استخدموا 2 بيلز حاطين الايزيتامايب في اسيدك ميديوم علشان يعمل مينتننس. On the other hand روزوفاستاتين عاملينه correlated مع الزنك عشان يبقى ليه انتي اوكسيدنت ايفكت، وبالتالي كانهم محطوطين 2 تابلتس ان كبسول بطريقه تخليه متحافظ عليه ويدي الماكسيمم بنفيت that we are expecting. ويمكن احنا يعني دايما الناس بتقعد تتكلم كتير جدا على قصه البريفالنس اوف ستاتين انتولرنس، بس احب اطمنكم انه يعني احنا طبعا بنشوفها وكل حاجه، بس it's very يعني rare. هم بيقولوا incidence of 9.1% are believed to exaggerate based on definition، ولكن الحقيقه ان في مجموعات من الناس who are actually having such side effects اكتر، سواء نتيجه being elderly او having an Asian race او different other factors زي ما حضراتكم شايفين. وفي النهايه such a combination is well tolerated with very minimal side effects، سواء بنتكلم على hepatic tolerability ولا بنتكلم على المسل سيفتي. مفيش دواء بدون side effects، ولكن at the end of the day this is an excellent combination that we're expecting a great result out of it. Finally, my take-home message is that recent European Society of Cardiology guidelines recommend aggressive LDL cholesterol targets for very high and high-risk patients, وإنه such patients لما بنديهم this combination will lead to a significant reduction in outcomes. الحقيقة إن such a combination which is introduced into the market is effective with up to 63% reduction in LDL cholesterol, increases the rate of adherence to such medication, and the safety is relatively very high. Thank you very much for your time، وأنا مبسوط إن إحنا في الوقت دوت وفي لسه ناس قاعدة. أنا عارف إنه يوم دسم جدا وبدين من الصبح بكمية حاجات. لو يريد بس أشرف ممكن بس المايك يتصلح. Thank you very much. دكتور محمد واخد طبعا المايك ومش راضي يديهم المايك الشغال.
انا بس عايز اقول لكم ان احنا عندنا لايف ترانسميشن بعد دقيقه. طب خد يا دكتور.
طب يا اشرف خد المايك كده دي بس، وزي ما دكتور محمد قال احنا هنقطع كمان شويه صغيرين عشان نوري اللايف كيس، وبعد كده هنبتدي الحالات. اللايف كيس مش هناخد وقت كتير، عايزين ناخدها كده في 5 دقائق. وبعدين اللايف كيس اللي هتتقدم دلوقتي ظريفه برضو لان فيها روتابليتور وفيها ايفس وكلام من ده. والحقيقه انا بحب انتهز الفرصه ديت واشكر الشركات كلها اللي جابت لنا كل الكلام دوت فري اوف تشارج عشان خاطرنا، بس عشان احنا القصر العيني. احنا كلمناهم جالنا يعني مش عايز اقول كام دعامه وكام واير وكام روتابليتور وكام، يعني انا قصدي كم حاجات من الاكويبمنت كامينج جاست فور ذا سيك ان احنا قلنا لهم ان احنا عايزين نعمل مؤتمر. اتفضل يا طارق.
الحقيقه الفواتير بتجيلي انا بعد كده.
ايه؟
الفواتير بتجيلي انا.
طبعا الريزوفا
ما سمعتش والله، عايز اسمع.
الريزوفا موست بوتنت ستاتين الموجود، ولو حط عليه الاسمايب ستاتين موجود موست بوتنت ستاتين الريزوفا. لما اتحط الاسمايب بقى فعلا بيعمل ماركت ريدكشن لل دي ال. وحتى في الاستاديز القديمه اللي هي الاسترويد والريفرسال، الريفرسال كان في الاتورفا كان بتقلل البروجريشن بتاعت الاثيروما فوليوم في الكروتيد. الريزوفا كانت بتمنع البروجريشن نفسه، مش بتقلل البروجريشن، كانت بتعمل ريجريشن للاثيروما فوليوم في الكروتيد.
بس برضه يعني عشان for the sake of يعني honesty، احنا الريفرسال had 2 arms بس الاستيرويد كانت single arm. فيعني مش قادر قوي ان انا يعني الاستيرويد كانت single arm study على 300 وحاجه عيان، ايفا ستادي فولو اب فور 2 years، بس ما كانتش 2 arms. الريفرسال كانت 2 arms. اوكي. يعني لو اللايف عايز يدخل لو هم جاهزين. مهند
شو في بالفلويد؟ ها؟ شو في بالفلويد؟ what medications in؟ في شيء بالفلويد؟ في نايتريت، هيبرين، what's in it؟ شو what's in there؟ Yeah.
عبال ما يجي.
Okay.
عبال ما يجي في دوكيومنتس بسرعه قوي.
اوكي.
اولا دكتور محمد بيقول لك الفواتير بتجيله هو.
الفواتير طبعا مش رئيس القسم طبعا.
ثاني حاجه انت ما شغلتش جيبك، وفين الالافات اللي بتنزل كل يوم دي يعني.
الحاجات كلها بناخدها.
شركه عن حاجه في التصنيع الدواء. تصنيع الدواء فيه بيقولوا 2 طريقتين للتصنيع.
Can you silence this? Make it silent. Yeah, whatever is beeping, sure will beep. Something is beeping. Yeah. Yeah, just make it silent, please. Yeah. Yes.
يا ريت اشرف اقطع الارسال عنهم. اقطع الارسال.
دكتور مهند انت سامعنا؟
Yes.
بس خلاص.
Can you hear me?
Yes. But we cannot see you.
مش لازم يعني.
We can't see me. Okay.
اقطع الارسال.
Maybe that might be a good thing. No, this needs to come up so I can see it.
اسال سؤالك كده يا دكتور طارق.
في طريقتين من شركات الجينيريك والبراند بيقولوا ان في طريقتين للتصنيع. طريقه ان انا بجيب الرو ماتيريال مثلا بتاع ريزوفا والرو ماتيريال بتاع الاسمايل وبيتحطوا مع بعض هاند ان هاند. والطريقه الثانيه ان هو
بيعملوا ايه؟
بيتحطوا مع بعض كتو سيبريت موليكيول.
لا ما هم بيتحطوا، ما هو ده اللي حاصل هنا، بس الثانيه باي لاير. يعني حط لاير كذا ولاير كذا، زي ما يبقى مثلا الكور حاجه والشال الاوتسر شال كده. اوكي يعني دواء تاني.
انه كرييت نيو موليكيول لما بيتحطوا ان كومباينيشن مع بعض انت كرييت نيو موليكيول للبروبرتيز بتاعت ده وبتاعت ده. يعني في طريقتين في المانيفاكتشر بتاعت الدواء. فدي بتزود
خلاص تمام. ارجو ان هم يكونوا جاهزين.
يعني. هم دلوقتي معانا سامعيننا.
قديش في اير بالسلندر؟ 110. Yes, can you hear me?
Yeah, we can hear you. Yeah.
Right. So we have a case for you, which is going to be a root ablation. I know the clinical detail a little bit, but somebody could tell you. Anybody can tell the clinical detail about the patient. Yeah. How old is the patient? 82. So 82. Yesterday they tried to do an angioplasty on the right coronary artery, wire pass, but the balloon only 1.5 or 1.25 could go through the proximal part, and nothing else will go. There's heavy calcium. Well, have you right? Okay, good. You stop the fluid for a second now. You stop the fluid until we stop.
Hello,
talking.
everyone. Our patient is an 80-year-old male patient. He's chronic heavy smoker with smoking index of 600, hypertensive, history of a stroke 3 years ago, presented with high-risk non-STEMI. The patient was vitally stable on admission, and his investigation showed positive cardiac enzymes and GFR of 53. The ECG showed sinus rhythm with alternating left bundle and right bundle branch block. The echo showed borderline LV dimension with impaired overall contractility, ejection fraction of 32%, dilated left atrium with regional wall motion abnormality in the LAD and the RCA territory with mild mitral incompetence. We did coronary angio by Dr. Ahmed Samir showing left main 30% distal stenosis. LAD showed diffuse atherosclerotic with calcific irregularity with no significant obstructive lesion, and the LCX was non-dominant vessel with proximal 40 to 50% stenosis. The RCA was a dominant vessel with severe proximal stenosis. Another mid-segment with severe calcific stenosis was seen, and CTO distally with distal cap at the RCA distal bifurcation. Dr. Ahmed Samir did investment procedure with dilatation of the proximal and mid-RCA lesion with successful wiring of the CTO in the distal RCA true to true, but was unable to proceed due to lack of equipment. Thank you.
Thank you.
Right, so we had the catheter in place and the wire in place, but the pressure was low. So test there, gentle test. Okay. So we're back. Yeah, because the guide dives into. So I've chosen an AL1 guide here.
Can you show us the cath, please?
Yeah, just 1 second. Just 1 second here, because we've got no pressure. I just want to get, this is, so, I mean, I suppose we could show you the angiogram that's been taken a little earlier.
Yes, please.
Okay. Yes, let me secure the artery first. She might have to exchange again with the test. Gentle test. You go. Very gentle. Okay, and have the talker. The white talker. No, the white talker. Just give me the white talker for the rota. The rota talker, please. Yeah, thank you. So as you could see, can you go show us the angiogram first? Yeah, so just show, not this one, show the angiogram that we took. what's happening here? Okay. Little test. Okay, that's fine.
Okay, can you show us the diagnostic images, please, while you're fixing the guiding?
So can you just show the diagnostic? Can you run the diagnostic images? Yeah, from the start.
It's not the patient.
Not the patient.
Are you showing a different patient?
Yes.
Oh, great. There you go. Go back one. So these are the diagnostic images. Can you see them now? Can you see on the?
Yes, yes.
Okay. So yesterday the proximal lesion apparently was the problem. You could see there's a lesion at the tip of the guiding catheter, and there's one where that RV marginal branch comes off. And there's also a distal lesion at the RCA itself. The resistant lesion was the one with the two branches coming off in the middle. So obviously this is, that's me there. Okay, I think using the RotaWire, especially the floppy wire, is not going to take us through. We're going to have to do the, let's have the microcatheter and a normal wire. So yesterday we spoke about uncrossable and dilatable lesions. And of course, you could use multiple ways of dealing with this. This is happening, right? Okay. Multiple ways of dealing with this. This was mentioned today. If you think you need the rotablation, just use it. Because people think I'll try and I'll test the lesion, and it prolongs your procedure time. You end up using many more balloons without much benefit. So if you need the rotablation, just use it. So in this case, there's a lot of calcium in the RCA. Which wire did you use? Okay, can you just...
Have you done IVUS or not yet?
No, we haven't done. I mean, the IVUS will not go. If a 1.5 balloon did not go, the IVUS, there's no chance it will go.
Mohanad, how can you explain that yesterday they passed with a wire and today?
But this is the rota wire.
Okay. Yeah,
and this is a floppy rota wire. I mentioned that yesterday. I often use an excess support rota wire, which is a little bit easier to manipulate, and you could wire with it because the radio-opaque segment and the tip are a little different from the floppy one. And of course, Boston are coming up with the new wire. I think they call it the Elite, or they wanted to change the name, but which is still not available everywhere.
I need to ask about GFR.
53.
No,
53.
just give me a fielder wire, please. Fielder or fielder FC. Hydrophilic wire, yes. Fielder or fielder FC. FC, whichever. FC. Can you put the cones in a little bit? Cones in. Yeah. Yeah, that's fine. That'll do. So we had everything set in place just so we could show you the rotor, but now the guide has gone out. So we're just going to have to do this and show you what we are going to do. There are steps that you really have to make sure that you follow when you're doing rotablation so you don't run into trouble and you're prepared to take on any lesion. Okay, just have that there. So the first thing, there's a draw, it's called DRAW, that you need to check, which is the drip and the speed and the wire and the brakes. But we'll do this in a second once we've wired this artery.
Mohanad, this is Mohammed Zahran. Welcome in Egypt and in Cairo. As usual, we enjoy your company a lot.
Thank you. Thank you very much. I enjoy being here.
We're glad to meet you.
Thank you for having me.
Yes. Just take your time. We will make a wrap up for the case with the audience.
Excuse me.
You may focus.
Cones in, please.
So this is a 55-year-old lady with the CTO of the RCA,
okay,
and mildly reduced ejection fraction of 45%. Good kidney functions. Her GFR is 53. And Dr. Ahmed Samira, our dear friend, yesterday passed the wire, the CTO wire, and he passed a 1.5 millimeter balloon.
Okay.
And then he met the uncrossable lesion. So this is a CTO where you get the wire passed through the CTO segment, and then you are faced with an obstacle to pass the balloon. So sometimes you have a calcium. I cannot see the calcium shadow in the coronary angiography here actually, but apparently there's something maybe not in the wall, so it's not staining that hard, but actually it's making an obstacle for the balloon to pass. So the plan was to make a rotablation, and as you know that the rota wire is not an easygoing friendly wire. The rota wire is a firm wire. So what Muhannad is doing now is that he's passing a Fielder FC. The Fielder FC is a hydrophilic wire, and it will move smoothly as you see on the screen now with Muhannad, and then he will pass the microcatheter. He will exchange this wire for the rota wire, because the rota wire عنده الحلزون اللي هيلف عليه المبسم بتاع الروتا. So this is the steps that Muhannad is doing now.
So this is the microcatheter now. I'm just gonna pass it distally, and I'll take this away from me. Okay, and now we just put the rota wire in. Just let that go.
May I say something? Hi, Dr. Muhannad. Hi, everyone. Sure. First, listen, what Ahmed Samir did is not an investment technique. يعني دي كده حاجة على جنب، ده investment technique حاجة تانية خالص. زي ما قال زهران كده، دي entity معروف عندنا اللي هي uncrossable non-dilatable lesions بعد ما فتحنا CTO. الحقيقة منظر المايكرو كاثيترز وهي بتعدي، شايفها بتعدي سموث قوي، ولما معنى ان مايكرو كاثيتر تعدي بالشكل ده، يعني I think ان احنا طبعا الروتا ده بيست اوبشن، ويعني غالبا لو عملنا ايفا تو ذيس بيشنت هنلاقي يعني نير فول سيركل اوف كالسيفيكيشن حتى لو احنا مش شايفينها كويس في الفيسل. لكن قصدي ما دام المايكرو كاثيتر عدت بسهوله كده وهنكستشينج الواير عليها، اعتقد احنا عندنا the option of using cutting and scoring balloons. مش عارف رأي حضراتكم ايه.
Are you asking me or asking the panel?
No, they're asking everyone. You can.
It's okay. Just let me hear what people think first, and then I'll say what I think. Is this Caravelle? This is Caravelle, is it? Hold on to this.
Do you think cutting balloon will do something here, or you cannot pass it even?
Well, they've tried a balloon yesterday. They've started the 1.5 balloon, and they couldn't pass anything else. So the answer to your question is no. You could try it, and you probably spend another half an hour using God knows how many balloons, and that will not affect the lesion and will not allow you to do what you want to do. So I think if you think you need rotablation, just use it, because they've tried it yesterday and they didn't use a rotablation and that didn't work. So the chances of that working today are very little. So you have the equipment, use it.
So what you are saying, Muhannad, is that you're using rotablation here to modify the lesion, to make the lesion more friendly. It's not the issue that I cannot pass a balloon, so I'm going to use the rota to pass a balloon, or I can pass a smaller balloon. I can pass a guide liner, and definitely if I pass a guide liner, I will be able to pass a balloon.
You pass the balloon, but you wouldn't know whether it's going to be dilatable or not.
The lesion is not modified properly. What rotablation does actually, it does modify the lesion. It makes it more friendly for the further balloon dilatation to achieve the proper vessel size, and then the further stent and the stent expansion, and as long-term results for further stent loss of its width and so on is much better if you adequately break and modify this calcium. So I agree with the rationale of using the rotablation in such a case, because not essentially it's a balloon non-crossable lesion. It can be crossable, but the balloon will not obtain the degree of calcium modification.
زهران يعني هو الفكرة بس إنه this case already was done a few days ago, not yesterday ولا حاجة, a few days ago. And Ahmed Samir tried, and Ahmed Samir is a good operator, but he didn't have in hand a rotablator. So we reached to the conclusion, and he called me up, that the best option for this patient, especially if there is a clear, significant calcification, is to go in with a rotablator. And this is the plan for this procedure.
So what we are going to do, we're going to set the rota. So the most important part is to set the rota outside the body, the speed. With a smaller burr, 1.2515, you could go up to 180, 200. I usually put it about 180, 185. Anything above, you start at a lower speed, 150, 155, 175 burr, 2.0 or 2.5. So we're going to set that at 180. Go up. Go.
طبعا في steps for preparation of rota.
That's okay.
Before introducing it, بيسموها the draw steps.
Yeah, so we've checked. We set the speed at 80, and I've already checked this that it moves. And we're going to use the clip. If you look at here. Okay, where's the? So this comes in. I don't know if you could see my hands here.
No, we cannot see you.
Okay. So obviously with the Rota Pro, it has changed. In the legacy device, used to have the foot pedal to activate the Rota, and here it all moved to this knob here. Can you see?
No, please. ممكن تشيلوا الحاجز وتحطوا الكاميرا على ايد دكتور مهند.
I'm just gonna bring it across here. You might be able to see it.
Okay.
Can you see it now? Yes.
Yes.
That's okay. That's okay. So everything is controlled from this knob here, right? It's okay. It's okay. Just don't worry. Just let go for a second, because I don't want to. So this activates the Rota instead of the foot, and the DynaGlide now. There's a button at the end, and then you have to push this button to activate it, instead of just, it used to be just single button before. So advancing the hang on to this for me. I'm gonna take this out. And again, one more thing to mention. So this is the brake and the Rota here. It's opposite to what you do in your car. In your car, yeah. Can you see it here?
الكاميرا تبقى على ايد دكتور مهند لو سمحت.
Can you see it here?
No, we cannot see. We're seeing
okay.
The nurse. الكاميرا مان لو سمحتوا حد من النواب يقف جنبه بس لان هو مش عارف احنا بنصور ايه.
I can't see it anyway. Can you see the?
Yes, now we can see it.
Okay. Yes. So as I said, everything has moved to this button here, to this knob. You activate it and deactivate it from here, and you have the brakes in here. It's opposite, kind of counterintuitive. In your car, to stop the car, you push the brakes in. In here, this is a brake and this is brake off. You push it in to to get rid of the brake. And the same token, just gonna advance this a little bit here. The DynaGlide button now is at the back. You push it in, and of course you have to have the brakes off when you're doing the DynaGlide. And I usually use this, and you have to activate it through this button here. And now we're gonna advance this first. So all what I want you to do, just push at the DynaGlide button. When I tell you, just 1 second, actually. I'm gonna put it inside the, so, okay. Let's put this in. It's done in many different ways. For me, it doesn't matter if you, can you push the screen up so I could see the images, please? Can you push the screen up? Push it up. Okay, good. Right. So the recommendation before used to be not to DynaGlide up the guide. And basically because they thought the DynaGliding the guide, you could shave the inside, but that doesn't happen. And I've been doing it for years and never caused any problem. And in fact, actually, I don't even screen. So, okay, activate and come with me. Come with me. So you can see I'm not even screening. I'm just pushing this. Come with me. When I come close to the RT, come close.
Okay. Can you show us the angio, please?
No, don't stop until I say, please stop. Without screening, we don't activate. That's an important thing. Never activate the burr without screening, because sometimes it builds attention and I could jump in without knowing. So we always screen before you move the burr. You hear that little, okay. Yes. That little noise because it's coming off the ostium. The AL is not coaxial, but I'm leaving it out so it doesn't stop the pressure. Now, before I start rotablating, you can see I come off the DynaGlide. We put the brakes on. Remember, if you push the brakes off, to take it off the brakes on. And the approach to any lesion is what's called the pecking technique. You get you get the burr to the lesion, let it work, 2 or 3 seconds, 5 seconds, 10 seconds, whatever it is, and you drop back so the blood is washing every debris down. Often when I start with any case, particularly in this one, this patient has got a wide QRS. I don't know if you see it on the screen.
No, we don't see it.
Okay, anyway, he has a wide QRS. This is a large RCA, dominant RCA with lots of calcium. So there's a huge potential here for severe bradycardia.
Oh, okay.
So what we do with any rotablation case, I will start with a very 5 seconds run and see the response of the patient. Heart rate, blood pressure. Then that will tell me, can I rotablate for 10, 15 seconds or can I not? If you start with a bigger burr, like in here, I was going to start with 125, but I think it's not enough for this artery. So we're going for 1.5. And the 1.5 usually will take a little longer time, but we'll test it first run. So you unlock this, start screening. And can you see the angiogram now?
Yes, we can see the angiogram. This goes with the previous past history of rotablation. When we used to rotablate the right coronary artery, some operators used to put a transient pacemaker or a transient wire as a routine before rotablation because of this calcium debris causing heart blocks and so on.
Yes.
But with the current technologies and expertise, it's not essential. But as you said, this prerequisite of rotating for 5 or 10 seconds, yes, to test what's going on.
Unlock the table.
That's right.
Yes, افتح طاولة. No, unlock the table, not the unlock.